Уважаемые коллеги и дорогие друзья, мы рады приветствовать.
Friends, welcome to the 7th Moscow International Festival on Endoscopy and Surgery. Today, from the National R&D Surgery Center, named after Vishnevsky, we'll be on this Monday morning opening the traditional conference, Laparoscopic and Robotic Colorectal Surgery. Colleagues, it's our pleasure to give the floor for the introductory remarks to academician Shaligin, Yuri, President of Russian Coloproctology Association, Director of the National Center for Coloproctology, the Rizhik Center. Yuri, the floor is yours. We are all ears. Thank you, Yuri. I'd like to welcome everyone and to say that I really admire what you are doing. For several years, I have seen the Moscow International Festival develop and move forward. We can see that it's becoming even more practically and scientifically important. And this is crucial in this difficult time. Sure, we all lack communication. Sure, digital technology is handy in letting us perform the plans we had even last year, but nothing can replace the face-to-face communication, our handshakes, and our in-person discussions. The digital technology, on the other hand, can increase the coverage and increase the number of people who are with us. So in our Coloproctology Association, we decided to combine these two modes. Hopefully, life will come back to normal soon, and we will further combine the in-person and online communication. I'd like to welcome our experts from Russia. That's ESTA team. They know all the teams for treating colic issues, be them benign or malignant. And it's my pleasure to welcome international experts. Most of them have been to Russia repeatedly, and this includes Andrea de Hore and Amjad Parvais. They've been to Russia many times, and I believe they have supported the development of laparoscopic surgery in Russia big time. I wish you a successful event, and I hope that we will overcome the difficulties we are facing now. I wish you all the best. Please take care. Sound health. Thank you very much for having me, and I'm really glad that our institutions and associations cooperate. And it's my pleasure to welcome everyone and to mention that there are new young colleagues joining us. Thank you very much. All the best to you. Thank you very much, Yuri, for your kind words, for your guidance. We are really glad that we collaborate and that we move forward jointly. Thank you very much. Colleagues, it's my pleasure to introduce the program director for our conference on laparoscopic and robotic technology in colorectal surgery. Artem Goncharov, you are welcome. You're our program director.
Руководитель отделения колопроктологии Центральной клинической больницы Управления делами президента Российской Федерации Артем Леонидович собрал удивительную программу, собрал удивительных экспертов, как мы говорим, из дальнего зарубежья, из ближнего нашего зарубежья. Многие колоректальные хирурги все знают практически всех наших замечательных экспертов. Артем Леонидович, я вас приветствую как президент и передаю вам слово для представления и дальнейшего ведения нашего заседания, вашей программы, вашей сегодняшней конференции. Пожалуйста, вам слово, Артем Леонидович.
Доброе утро, коллеги. Спасибо большое, что отозвались на приглашение и участвуете в Endofest2020 в режиме онлайн, но тем не менее мы постарались сегодня собрать самых интересных, самых выдающихся экспертов. Большое спасибо, Юрию Анатольевичу, что вы открыли сегодняшнее наше заседание. Сегодня наша конференция, наш день будет разделен на 3 части. В первую часть мы обсудим онкохирургию. Мы сфокусировались на раке ободочной кишки. Будут доклады Артема Зелинского про роль неодъюванта все возрастающего лечения рака ободочной кишки. Мы увидим 2 операции.
Today we'll have a busy agenda and we'll have 2 broadcasts of operations. And this will be our friends operating, Mr. Chernikovsky and Mr. Chernyshov. So you'll be welcome to watch these operations online. We'll have a lecture from Amjad Parvaiz. He'll talk about training surgeons in the robotic technology and laparoscopy. Then Mr. Karachun will share with us a new trial. New trial results.
Будет лекция из клиники первого меда. Мы ждем профессора Царькова Петра.
We'll have a lecture from Professor Tsarkov. He will talk about the differences between various dissections in colic cancer. The second part of our discussion will be on non-tumor diseases. And this year we'll be celebrating the 20th anniversary of the operation performed by Andrea Dore from Belgium. So he'll be talking about rectal prolapse. And this ventral mesh retroplexy operation has been really useful and promising. And we'll be able to listen to the author of this method. Now we'll show our robotic operation related to the rectal prolapse. And we'll also talk about minimal invasive technologies in ulcerative colitis and Crohn's disease. And the second session will be concluded by a lecture from our colleague from the US, Igor Belansky. He is an outstanding expert on hernia treatment using laparoscopic and robotic methods. He has his own style and types of operations, so he'll talk about perimostal hernia repair. This is really interesting. This is a rare topic and a rare technology for us. And the third part will be on new technologies and extreme surgery or emergency surgery. And we'll have with us Sam Atala, one of the leading US colorectal surgeons. And apart from other things, he also tests and develops new surgical robots. And I believe that we'll see a glimpse of the future from him into luminal and abdominal robotic surgery. And then Ilya Chernikovsky will speak. He'll talk about laparoscopic multivessel resections. Sergei Baido will talk about exenteration, laparoscopic exenteration, and then we'll talk about this experience. Thank you very much for your attention. I believe we can kickstart our conference, and the first speaker is Artem Zelinsky. Artem, you're welcome. Hello, colleagues. I'm really honored to be invited to this conference, and I'll mention that this conference has been held for many years, and every year it's more and more interesting, and you're raising the bar higher and higher. I'd like to say that the corona crisis we are facing now prevents us from in-person meetings. On the other hand, now we have a great opportunity of using online option to speak, and I believe we can cover more people through this online discussions. I will talk about one of the hottest topics, neoadjuvant therapy in colic cancer treatment. We know that for rectal cancer treatment, this is a standard, and we have some latest developments in the colic cancer neoadjuvant therapy. So this will be a good preface for the next speeches. So the first question, what do you want to improve? To answer this question, I'm sharing this data. This comes from GCO-GO404 trial in Japan on laparoscopic open D3 dissection for stage 2 and 3 of colon cancer. So these are the patients who will be invited for randomized trial and for routine practice for neoadjuvant therapy. What are the results? 5-year survival was 90.5% for open surgery and almost 92% for laparoscopic surgery. These results are unprecedented for all the tumors in the abdomen, so these results are great. So we see that surgery with chemical neoadjuvant therapy. But what is the issue? The issue is with the relapse. About 20% of patients had systematic relapse or a local failure. So we can see that neoadjuvant therapy is a candidate for effective reduction in the number of relapses and recurrences. And this way will further increase the 5-year survival. So the 3 pillars of neoadjuvant therapy for colic cancer. So number 1 is selection. So we need to select the patients to be operated on. So those who can benefit from surgical intervention. For colic cancer, we are talking about selection of candidates for neoadjuvant therapy. So when we have neoadjuvant therapy, we can assess the effect and personalize the strategy after the operation. The second thing is to reduce toxicity. We are talking about toxicity as a consequence of the surgical stage. So we can downsize and downstage the tumor, and we hope that neoadjuvant therapy will let us reduce the scope of surgery, reduce complications after surgery. And this way, we'll reduce the toxicity of the surgical stage. And the third pillar is to improve results and outcomes, including the long term. And this means that we want to treat micrometastasis 2 months before. So the data we can use. A brief disclaimer. Unfortunately, the full text is not available from the only randomized trial of phase 3. This is Foxtrot. That's why I had to use materials of ASCA 2019 and ASCA 2020, Selmer and Grotti materials. They're big proponents and they're opponents of neoadjuvant. And so we'll talk about Foxtrot. And this slide shows the current and planned trials for phase 1, 2, and 3 for the locally advanced colic cancer. So we'll talk about various types of neoadjuvant therapy there. I'd like to stress this column. So what is considered to be the endpoint here? You can see that the endpoints are different. Some talk about 3 or 5 year survival without relapse. Some are focused on 3 years or 2 years. Some are focused on response, safety, and feasibility of this therapy. So the spectrum of endpoints means that on one hand, neoadjuvant therapy is enjoying a lot of focus in the locally advanced colic center. And on the other hand, it shows that there are many gaps in our knowledge in this technology. Okay, a few words about the results of Foxtrot. This is the only completed randomized multi-center stage 3 trial, neoadjuvant therapy in locally advanced colic cancer. The hypothesis, so you can see we had more than 1,000 patients, 1,052 patients in this trial. They were split into groups, those who had surgery, and then based on histology, they were either provided or not provided neoadjuvant therapy, and a group of patients who had 6 weeks of neoadjuvant therapy, chemotherapy, before surgery. Then surgery came, and then they had 18 weeks of neoadjuvant therapy. Here we also had a third arm. These were the patients who in neoadjuvant also had panitumumab, and we have very little data on this third arm, so that's why we are not considering it now. Hopefully we'll be able to discuss it later, and the role of panitumumab in this neoadjuvant therapy when we have the full text published. The hypothesis was that neoadjuvant, so 6 weeks chemotherapy based on oxaliplatin, would reduce the hazard ratio to 0.75 local recurrence. So the forecast was 32% of relapse within 2 years without neoadjuvant therapy. They wanted to reduce it by 25%, that is to 24%, and they considered short-term efficacy. So to see, so let's consider the stages of tumors. So they included not only T4 and not only N2, but also T3 and NO and N1, and 3/4 of tumors were really big. So they were T4 using CT or T3 with more than 5 millimeters invasion. And one more important thing was that they didn't include patients with obstruction, and obstruction is a bad forecast factor for colic cancer. And we know, based on our own communication and our own practice, we know that patients with obstruction often have a stoma with chemotherapy, neoadjuvant therapy, to improve the outcome. And Foxtrot didn't include these patients. So the goal was to reduce the 2-year relapse by 25%. So what do we know retrospectively about this tool, how effective it is? So here you can see the stages. The design of the trial was such that the patients were added to 2A and 3C stages. So this means that we have a diverse group of patients. So we are more focused on neoadjuvant therapy for T4A, especially T4B. So they are bulky metastasis. And here you can see that the different patients here And based on the data available, we understand that the tool used here wasn't outstanding. So this slide on 10 follow-up using mosaic file. This is an adjuvant trial, and you can see that cisplatin chemotherapy has scarcely any effect for stage 2 of cancer. Foxtrot has been discussed in ASCA, and the authors were asked the question. So, using the 10-year follow-up mosaic, why cisplatin treatment for patients in T3? We know based on mosaic that it wasn't going to be effective. And the doctors said that the staging could change. So chemotherapy before the surgery would lead oxaliplatin to be more effective for these patients. Okay, how safe is that? Well, I did mention chemotherapy toxicity results from Foxtrot. So those who had oxaliplatin received toxicity, and they all survived this, and almost all of them were operated on. And we received very good results in terms of surgical complications. In Foxtrot, 682 patients who had neoadjuvant therapy, you can see they have a twofold reduction of anastomotic leak and intra-abdominal abscesses, almost double reduction in the number of repeated operations, and also reduced the number of applications which prolonged hospital stay. So this is something which wasn't really expected. So we would expect the patient after chemotherapy to be weaker and in the going to the surgery. And we can see that we have fewer early surgical complications. And the hypothesis of the author is that surgery was easier to be performed, and so this asks for further studies. And the second hypothesis is that neoadjuvant therapy changes the immunological profile of the patient, and heavy complications are less likely. So we're expecting the full text to be sure about it. Okay, chemotherapy in general. So this is the thing to highlight. You can see that chemotherapy didn't postpone surgery, and where people received neoadjuvant, they implemented the strategy quite often. 98.2% of patients having neoadjuvant therapy had the resection, curative resection, and those patients who came following neoadjuvant therapy, only 1.3% were not operated on because some inoperable or metastatic disease were identified. This is less than in the group who didn't have chemotherapy, and 96% of patients received after operation chemotherapy. So this is the arm with neoadjuvant therapy. And here I'd like to highlight the weakest point in this trial. 27% of patients who went to surgery without neoadjuvant were not given chemotherapy at all. And 16% didn't need it at all. So in the group which didn't receive chemo, initially the patients were operated on, and after the histological research, they didn't find any risk factors which would suppose adjuvant chemotherapy. And only 11% didn't receive chemotherapy because they were unfit to chemotherapy, so they couldn't tolerate it. So maybe that's the amount of after operation complications. So we remember in the neoadjuvant group we had fewer complications. So maybe that's why more of them had chemo after the operation compared to those who didn't have adjuvant therapy. Okay. Those who had microsatellite stability didn't respond to chemotherapy. total response was 4.7%, and we can see that marked responses or moderate responses were not there, and those who had microstable instability, so they didn't respond in any way to chemotherapy, and there were a lot of patients like that. So if you look at the whole group, in the Foxtrot group, so we had 492 patients with microsatellite non-stable. So every 6 of them, if not tested before neoadjuvant therapy is prescribed, can have microsatellite instability, and then they'll have no benefit from cytotoxic treatment. So did they achieve their goal? This is a slide from 2020 with a longer analysis, and unfortunately, the Foxtrot trial goal wasn't achieved. They reduced the number of relapse in the upfront surgery to 17 and 13%. The hazard ratio was 0.75 as assumed. The level of forecasted relapses was lower. We thought that it would be 34% in those who start with surgery, and there they had only 17%. But this data is not statistically significant in terms of the reduction in relapse. So P was 0.08 or even 0.07, and so we don't have any digital statistical confirmation of neoadjuvant chemotherapy reducing the number of relapses or recurrences. So GCOG 0404. So you can see that they have almost the same results for the open and laparoscopic surgery group without adjuvant chemotherapy. So this trial didn't progress much compared to the previous data. Okay, what are the issues of this trial? First of all, low precision in terms of staging, TNN staging. Well, to see the difference between T1 or not advanced T3 or advanced T3 versus T4, so it can be done only in 77 to 70%. So sensitivity is 77, specificity is 70%. If we talk about anal status, then sensitivity and specificity are even lower, 71 to 67%. And this is a huge issue because we use CT rather than MRI, and here we want to add the patients based on CT staging, and we understand that this is not precise. And this means that we can overtreat the patient with chemotherapy if CT increased the stage. So the second issue of the trial is providing chemotherapy to non-responders and factors of negative forecast. So those who had neoadjuvant therapy, so we can see PT1, 2, and P0 and 0. So that's a lot of people who didn't need any axilipotent chemotherapy, that they were still randomized in this trial, just like those patients. And here in microsatellite stable, we had 25%. So these are the TRG0 patients based on histology. So it's not logical to use chemo for them because we have histological confirmation that it doesn't work. All these patients had the adjuvant component, and this is bad. And I showing a slide with one more trial, which is called SCOT trial, which changed the adjuvant from 3 to 6 months due to the long-term toxicity. So they built the program in such a way so that the neoadjuvant should be a closed loop when everyone received chemotherapy initially, and after surgery, all of them completed chemotherapy. So here we have a high risk without the potential chance to improve anything. So we can have nephropathy as a result. Okay, the results of Foxtrot for neoadjuvant therapy. TNN downstaging. Many tumors responded and shrank. So this means that the biology can be better, the surgery results can be better, surgery can be easier to perform. We saw the trend increasing relapse-free survival. Unfortunately, this trend wasn't statistically significant. And the third thing, the conclusion, which is peddled by the co-authors, and maybe this can be a potential standard of treatment for T4 and N2, but only for the MSS patients. And this is the most important thing we have learned. So this is the first randomized data showing that chemotherapy in neoadjuvant for microsatellite instability doesn't work for colorectal cancer. And this doesn't increase the price potentially. Why? Because the patients can have good histology after the surgery and they will not need any chemo treatment. So what is against neoadjuvant polychemotherapy? Well, the results are not statistically significant. So radiology is not ideal in terms of staging, and maybe we overtreat a lot of patients, and the drugs we are using are not that nice. So what would like to learn? The role of triplets, three-component chemotherapy, foxerin, and also the effectiveness of advanced immunotherapy in MSS patients. So now they are treating BRAF mute in neoadjuvant. The question is, can we miss neoadjuvant if we have a good histology, and what's the role of circulating DNA in selecting and assessing response? So we cannot only use CT. So hopefully answers to all these important questions will come from the Foxtrot 2 and Foxtrot 3 trials. Foxtrot 2 will only have microsatellite stable patients who have for Fox 3 weeks, and Foxtrot 3, so they are microsatellite stable and they can survive triplet chemotherapy. So maybe the results of these two trials, Foxtrot 2 and Foxtrot 3, will let us have a clear scheme for treating patients with advanced tumors with neoadjuvant therapy if it's non-stable, and triplet therapy if they are MSS. Thank you very much for your attention. Thank you very much, Artem. And before we move forward, I'd like to welcome the team of co-chairs of the meeting on the current trend in colorectal and colic surgery. So if I may, please show Alexey Korachun, Professor Korachun, a well-known expert. He's been with us almost every year of this festival. Can we please show our experts? You're welcome. Alexey, we are glad to welcome you. Yuri, hello. Hello, it's our pleasure. Well, same here. I'm also a laureate of the festival. Exactly, laureate of the festival. I remember you gave me an award. Yes, I do. I do remember. That's really nice. We are also glad to welcome the whole team. Ilya Gatsadze. I believe that we can see you as well. And Kirill Burmich as well. Okay, he is not here yet. Oh, we can see Kirill. Hello, Kirill. Ilya, hello. Welcome to our festival. It's your first time with us, and we are glad to have you. And one more thing, I'd like to welcome Amjad Parvaiz, our guest. He's a mentor. He has contributed big time into training our colleagues in Russia and in Europe. So let us welcome Amjad Parvaiz. And as president of this big event, I'd like to personally welcome you and thank you very much for joining our Congress. Thank you very much indeed. We are expecting your speech. We see so many colorectal surgeons in Russia who are admiring you and consider you to be their mentor. Thank you very much. Thank you very much for joining our Congress, our festival on endoscopy and surgery. Okay, Artyom, I'll give you the host hat. Colleagues, let me mention that we can ask questions using the chat.
Председатели и эксперты получат эти вопросы.
And our experts and chairs will read these questions from the chat, and they'll be able to answer your questions. And one more thing to mention before we proceed by our agenda jointly with Artyom is that the conference today is sponsored by Medtronic. They're our general sponsor for the conference, and let me thank them very much for their support in arranging this conference. Co-chairs, the floor is yours.
Мне отрадно, что каждый раз, участвуя в фестивале, я для себя узнаю что-то новое. Например, сегодня узнал, что мой друг Кирилл Бурмич еще и Кирилл Сергеевич.
I'm glad that Kirill, my friend, is Kirill Sergeyevich. So this is a new thing to me. We are friends, and I always learn something new in our festivals. Well, friends, we'll have 2 broadcasts now. I can see the coloproctology hospital image. Let's ask Hospital 62. Do you have any connection? So do you think they are fine in Hospital 62? Well, the thing is that I cannot see any image from them. I can see the wall only. Okay, Stanislav, can you hear us? Stanislav Chernyshov, head of department of coloproctology research center, would like to hear you. Am I connecting? Andrei, can you hear me? Am I connected? Okay, let's pick it. Let's grab it. Okay, I'm connected. Okay, please make me connected. Stanislav, you are online. Stanislav, you are connected. Yuri, good morning. Thank you very much. Thank you very much for Thank you very much for giving us a chance to communicate. We don't often communicate. We know why. So we are already in progress. You can see the screen. Ilya is also performing his operation. I'd like to say a few words about the patient. So the patient today has a tumor in the upper part of the colon. We have examined her. We saw the lesion 13 centimeters from the outer wall of the anal channel, and CT of the abdomen and thorax didn't find any metastasis. That's why we are going to have anterior resection, laparoscopically assisted. So you can see that we are already in progress. We have mobilized the left part. We have went through the artery and so the vein. We don't have enough colon yet, so we are mobilizing the left flexure. So we are still in process. How are you doing, Artyom? Thank you very much. We are watching you. It looks nice. So what kind of anastomus will you have? We've given it some thought, because initially we thought that localization would be high. We thought about intercorporeal anastomus, but since the patient has a lower localization of the tumor, we'll also have anastomosis, and we'll have a circular stapler for this. So we'll see how it goes. The tumor is not very big. It doesn't go beyond peroneized part of the rectum, so maybe we will remove it through the colon, and we'll have a circular anastomosis either end to side or end to end. We'll see how it goes. We'll see how we can supply blood to this area. So let's see how it goes. Okay, thank you very much. Can we connect to Hospital 62? Yeah, indeed. We would be glad to listen to Ilya. So we'll be performing little by little. Sure, sure. You're welcome.
Алло, нас слышно?
Hello, can you hear us? Yeah, we can. How are you doing? Artem, hello. I also heard Alexei is here. I recognized his voice. Yeah, he said that he has to go to the operating theater. It's me and Kirill and Amjad. Nice to hear from you. Let me welcome Amjad. We saw each other in another conference a few days ago. This was our UFIM colleagues. And I'd like to thank the organizers of the conference. I'd like to thank Yuri, Seda, and Artyom. Thank you for letting me present here as a surgeon and as a lecturer. The patient has the ascending colon, which is very close to the cecum, T3 and 1,0 tumor. And this also interesting because it's a primary multiple disease. The patient has a tumor in the right kidney, and the patient, that's a male, will have also a resection of the right kidney. So today I have the resection of the colon. So I would like to show something comparatively new, maybe. We are going to have the right hemicolectomy with the intracorporeal anastomosis as usual. So we'll have equipment for this, and we'll use our method, the one we are promoting. We have D3 lymphodissection. That's what you can see now. We have reached the anterior position of the upper mesorectal vein. An interesting thing was from another conference, our colleagues from Norway showed their understanding of D3 lymphodissection, so those who followed could see it. So we believe this is D4, what they did, and we are confident that we don't need to have a dissection of this scope. As for D3 lymphodissection, by the way, if I talk too much, just let me know. So as far as D3 lymphodissection goes, we believe that if we have right hemicolectomy, this can be useful if we have the right anatomic guidance here. So when we do D3 lymphodissection, we understand that even if we plant D2, we will have the target vessel, and we'll deal with it at the foundation, so we know where it comes from. Did you hear that? Yes, we did. Thank you. Thank you. Nice. Hello, this is Yuri Starkov. We can hear you well, and we can see your operations, so please proceed. Thank you very much. Nice to hear from you. Thank you for inviting me. So now we'll go to the base of the artery and vein. So we can see that the tissues are unconsolidated, a little bit overweight. So this is a standard patient in Russia, so to say. So now we are using the tools provided by Medtronic, and we use them and quite often. So I have a Sony Cision with me, and we will also use the stapler. This is a new thing. We'll showcase it later.
Сейчас у нас небольшое здесь кровотечение.
We have a small bleeding here, and now we are treating it.
Не надо пока. Ага, поближе.
Илья Леонидович, скажи, пожалуйста, а вы планируете резекцию почки?
Okay, you plan the kidney resection after you establish anastomosis, or we will leave the start here. We have a paramedical issue here, so you know what quota is. So, frankly, the idea we had was to split this into 2 operations, for all the reasons you understand, given the end of the year. Our urologists are also ready to follow us with the kidney resection, and if we do it this way, we'll start with the anastomosis, and then we'll let the urologist operate. Why so? Well, you all know that kidney resection is a bloody operation. We'd like to have anastomosis to complete our part without too much blood, and then we will give the steering wheel to the urologist. I believe you would have done the same way, Artem. Last week, we had a similar operation. We also had a kidney resection. We invited urologists. They provided their stage, and then we built anastomosis after the urology. And this was the left hemicolectomy. So I prefer completing our part, and then, you know, with a peaceful mind, I'll give the tools over to the urologists. Now we clip the vein, the ileocolic vein. You can see it pretty well. As you can see, we prefer the 3D stent operations, so we really like it, especially when you do a lot of sutures intracorporally. This is really convenient, and now people are arguing, so what do we need more, 4K or 3D? Well, we believe, especially when you do a lot of sutures in the abdomen, in the cavity, so 3D is better. We have it from B. Brown, so I'm using it all the time, and this is Einstein 2. So this is 2 3D, 2 matrix. That's why, so people say that your eyes ache after working with 3D. So for me, it's not the case. So we have reached the iliac artery base. So we will take some notes. So this is the fat line people talk about. And Alexei, for instance, likes talking about it. And it determines whether it's a D3 dissection or not. So whether it impacts the oncological results is not clear yet, but everybody knows the trial initiated by Alexei called trial, and this will soon give us answers to the questions. You can see the mesenteric vessel. So this is the base of the iliac artery. Colleagues, by the way, please ask questions. I can't hear you well. Could you speak up, please? Yeah, please ask questions. Yeah, Kirill, Amjad, please ask questions. Amjad, has your practice changed with the spread of D3 or CME technology when you use the right hemicolectomy procedures?
Амджад, вы нас слышите?
Amjad, can you hear us?
Скажите, пожалуйста, изменилась ли ваша практика?
Can you tell us whether your practice has changed with the coming of D3 and CME technology for right hemicolectomy?
Artem, is this the question for me?
Yes.
I didn't get the translation. Your translator didn't translate.
I think that we are translated. Do you change your practice due to overwhelming technique of D3 and CME? Everybody do it, show it, but it's very controversial.
Yeah, no, I think most of the sort of debate is between central venous ligation for the right colon cancer. As it is shown here very beautifully by Ilya, you could see that he's using the superior mesenteric vein as a reference going along. The medial to lateral plane, which he's going to show now, which is a CME plane, that hasn't changed. This concept has been around as long as people are doing oncological operations. You know, like for example, the Japanese in 1970s described the same operation for colon cancer. So I think our technique for medial to lateral, doing it this way in an embryological plane, they have not changed. What we have done recently, because of the data and some of our colleagues convincing us that in selected patients with hepatic flexure cancer and proximal transverse colon cancer, we tend to do central ligation on the right side of the tumor. I must say that when we looked at our data recently, about 700 colon cancers done this way, there is no difference.
Amjad, will you be so kind to turn on the English language, please?
How do I do that?
Yeah, just to switch on the interpretation, please. Yeah, on the bottom bar of your Zoom.
Oh, yes, I agree.
Yeah.
Okay, English there?
Yeah, turn on the English, please, yes.
Okay, can you hear me now?
Not yet.
I have turned it to English. This is okay?
Yes. Yes, everything.
Okay.
Они назначены. Выключили звук.
So, like I was saying, our technique of central ligation have modified for proximal transverse colon and hepatic flexure tumor in somebody who has N2 disease, potentially on preoperative imaging. So in those patients, we actively try to stay at the superior mesenteric vein level and clip everything coming from the right of the vein. We just have looked at our data for nearly 700 cases, done with a conventional technique of leaving a 1 centimeter stump from ileocolic and right branch of the middle colic, but maintaining the CME plane as I described. And we have not seen any difference in survival as long as disease-free survival and overall survival when we compared it to Erlanger series, for example. Although we showed less morbidity because laparoscopy has got slightly less morbidity in our hands at least, or it has slightly better short-term outcome. I think the key thing here is Ilya is demonstrating a beautiful operation, and if people are wanting to learn how he's doing it, you would see the first thing he did was that he isolated or identified ileocolic pedicle, which is a very similar technique. And then he developed medial to lateral plane, dropping the duodenum a very long way before he tackled the vessel. Because if you take the vessel very early, then the curtain drops and it becomes very difficult to maintain the curtain or the traction to do medial to lateral dissection. So this is an important thing to remember. Other important thing was, as you saw him do it very, very beautifully, is that he sticks to right onto the vein, because vein, when you stick right onto the vein, then embryologically it becomes easier to dissect. And I think this same applies on the left side when we are doing an IMA dissection. Unless we come really very close to the artery, it becomes a bit difficult because you keep breaking the lymphatics and they bleed. I hope I've sort of answered the question, Artin, that you asked me.
Спасибо большое, Амжад.
Thank you very much, Amjad. Thank you. Really interesting to follow. Very informative. Okay, good. Let's go to the Coloproctology Institute operating theater to see what's going on there.
Станислав, скажите, пожалуйста, что у вас происходит сейчас?
Stanislav, how are you doing? Hello again. The discussion was really interesting. I completely support Ilya in terms of right hemicolectomy. I'm really pleased to hear from Amjad. And as for us, well, traditionally, for anterior and low resection of the colon, we mobilized the left part. We mobilized the left flexure of the colon so that we perform one of the conditions for good anastomy, so no traction. And now we can start mesorectumectomy, and we can see that this is the upper ampular cancer will not have total mesorectomy. So here you can see as we start. So this is the hypogastral nerve to the left. I'm using the blunt part for this and the blunt side. So we also use a Sony Cision harmonic scalpel. This is my favorite device. And now, as our tutors have told us, including Amjad and Alexei Korochun as well, so we are doing total mesorectomy from behind. We lift so here we lift the rectum, and in this plane you can see the rectal and presacral faces, and here we go between the faces, and here we visualize the holy plane, and we can use a hook for this. I can use a monopolar coagulation. Maybe we'll do it from the anterior. And since I really like Sony Cision, it's very ergonomic, so I'll be using it. So the patient doesn't have a clear layer here, so please let me use a napkin to clean it. Do you try to mobilize the splenic flexure, or can you save the artery and perform less scope? So I mobilized it this time because as soon as we saw the revision in the abdomen, we saw that we don't have enough of colon, even if we have anterior resection. That's why we had to cut the lower mesenteric vessel at the base. You know, in our clinic, we routinely cross the mesenteric vessel at the base. So we don't leave the left colic artery. We don't often. So we usually use low tie approach. Sorry, I have some napkins here. A little bit closer. So we can see a little bit of mess here. Closer. And the tumor, you said the tumor was small. Do you see it? Do you palpate it? Or have you marked it somehow? So now we palpate it. It's of a small size, but not too small, well, not to be seen.
Так, салфеточку. Давайте немножко все-таки отсушим. Хочется, чтобы было.
Okay, I want this to look better.
Конечно, я согласен.
I agree.
Что иногда, когда мы
Sometimes, when we use the harmonic scalpel, this doesn't look nice because it glues layers together. So sometimes it's difficult to sort out things. But frankly, I like it. I personally like it. So let's remove this napkin. Okay.
Отлично. Ну что?
Great.
Нет, пониже. Вы лучше вперед мне дайте. Хорошо.
Please move me forward. Good.
Скажите, пожалуйста, Артем, а что касается вас, насколько часто вы?
Artyom, how often do you, in your hospital, when you have colic or left side operations, how often do you do high tie of mesenteric vessel? Let me find holy plane again, and I'd like to hear Amjad's position on this. Yeah, please take your time. Take your time. No hurry. Yeah, we will find it. Okay, in our hospital, we don't keep the left colic artery often. We do it when we have the long sigmoid colon and we have side-to-end anastomies because we understand that we can have a lot of colon here. So we don't have it as a recommendation to have it all the time. So I wouldn't recommend it for low resections. Well, there are some other opinions on this. Ajat, what do you say to this?
So we actually wrote about it a while back, our experience. So like Artem mentioned that the patient population in Western Europe, they often have a short sigmoid and they don't have large descending colon in vast majority of our patients. So we almost always take inferior mesenteric artery at the origin, 1.5 or 2 centimeter from the origin. And we routinely mobilize splenic flexure for low anterior section. When you are doing a high anterior section, then you can do it selectively, particularly in Russian population. I have seen they have very large descending colons. And in those patients, we do them selectively. But like you said, it's very important to have attention-free anastomosis. So I think that's the key. We don't routinely take or spare the left colic. We do one artery on the left side, which is inferior mesenteric artery, and one vein. That's the standard protocol. Here, I think you are one layer too deep. If you go back posteriorly, you can show him that he's one layer too far back, because you are looking at presacral veins, which is usually a clue.
Вот так. Просто вот так сделай. Вот так сделай просто. Я согласен совершенно
So this is the way you should do, and actually I completely agree with Amjad.
Я немножко зашел, наверное, за пресакральные фасции.
I guess that now I am behind presacral fascia, and now I've selected the posterior semicircle. I will follow the anterior one.
Конечно, тоже есть свои преимущества у
Of course, monopolar device has its advantages as well. We can see the layer quite well. And each of us has grown on Amjad surgeries. Thanks a lot. We're trying to repeat them. As he said, our surgeries should be similar. And they should be similar even when performed by different surgeons. Artem, what do you think about it? Is it truly like that?
Well, I can tell you that you are doing it better than me.
Спасибо большое.
Thanks a lot.
Что-то здесь не жгется.
It's not cauterizing. Don't know why.
Немножко сюда на бок, потом
A bit
поменяемся.
sideways. And after that, I will change here. I wanted to ask Amjad. Artem, may I ask a question of Amjad? Yes.
Yes, sure.
So
Go ahead.
here we have a patient, and the uterus was removed in this patient. Actually, I like lifting the uterus. We're suturing it separately, but if we're operating on rectum cancer and the uterus was removed, is it feasible to lift this part of peritoneum with the cervix or without the cervix? So what
Yes,
do you think about it? Do we need to lift it or not?
Yeah, I do try to put a stitch even in those patients, because it allows my assistant
даже и
to
когда
go
нет матки.
deeper. So if you have a stitch there, then your assistant can help you with counter traction in a much deeper level. So I do put a stitch even in these cases to get exposure better.
Можно нам теперь максимальный Тренделенбург?
So Trendelenburg position,
Максимальный Трендель.
maximum Trendel.
Ну что, будем накладывать шов?
So will we suture it,
Советует Амджад поближе.
as Amjad is saying? Okay, in that case we will do it as well, because we want to have it in a convenient way, probably in future we will use linear stapler, and we will suture it now. So we will suture this fissure, we will lift it, and I agree with you.
Подошьем?
So we will suture it.
Один посередине. Отпусти пока. Покажи ровно.
Станислав Викторович, доброе утро.
Please. Hello. If you do not mind, I would like to switch to oncological hospital number 62. Yes, of course. And we will continue. Okay, and after that we will return to you. Thank you. Great. Can you give me the internal needle holder?
Я попрошу организаторов конференции, если есть
I
возможность.
request the organizers of the conference to switch us to hospital number 62 to show the broadcasting on the screen. Can you hear us? Can you see us? Yes, yes, we're here with us. Hello. Hello, Kirill Sergeyevich, I'm very glad to hear you. So do I. So we were listening to your conversation very attentively, and what have we done? We have already mobilized the transverse colon. Now we're at the distal margin of resection, and this is maximum Trendelenburg. We're mobilizing the iliac cecal angle from bottom to top, lateral medially. This is the standard stage of surgery. Here we can have some adhesions in the pelvis. So, no, we will suture using this device. No? Okay. So, what else? Regarding preserving left colic artery, we have had your discussion, and actually I would like to comment on this issue as well. We never preserve it, and we think that it's more standard, more appropriate to mobilize splenic fissure if you do not have the necessary length of the descending colon. And actually, it's much easier to standardize this approach because there is a standard procedure for splenic fissure mobilization. Here, there is standard exit to the base of inferior mesenteric vessels. And regarding the left colic artery, it's a bit more difficult because the vascular anatomy is variable. Probably in some cases it will be absent, or Mashkovich artery can be present. So standardizing this technique is much more difficult than crossing the base of inferior mesenteric artery. Following the principles of SME, if it's necessary, it's also possible to mobilize splenic fissure, but we know that there are alternative standpoints. So you can see that this is standard mobilization, and in these cases, when we are in the layers, when we do not go to superior mesenteric vessels but mobilize the colon in the layer, in the plane, we're trying to use monopolar device. So actually it protects us from errors, because if you are not in the plane, just even a little bit, then when you use monopolar coagulator, you will encounter some bleedings. If we use harmonic scalpel, then we can go behind the plane and we will not notice it because there will be no bleeding. Ilya Leonidovich, may I ask a question? So, regarding the morning lecture of Artyom Zelinsky, neoadjuvant therapy, could you please share your experience and your opinion? What group of patients should receive such treatment? That's an interesting question, and all of us are aware of the intermediary results of Foxtrot trial. And in cases when we have a patient with colon tumor T4B and N+, we try, if we have a doubt that we can actually do R0 resection, then in this case, we are trying to give them neoadjuvant therapy. We have very good examples of neoadjuvant therapy when it was very efficient, especially speaking about locally advanced tumors with MSI high status. Why are we speaking about it actually? Actually, the patients that have huge locally advanced tumor and there are no lymph nodes, no remote metastasis, so it's quite huge, but there are no metastasis in lymph nodes, no metastasis in liver or lungs. The probability that this tumor will have microsatellite instability in cells is much higher compared to general population. So in this case, although this is off-label story, still, if we use immune therapy together with chemotherapy, then we can get unbelievably good result. And an example that we discussed in For Surgeons Club, for example, was a patient and they were going to do right hemicolectomy because tumor was actually ingrowing into the duodenum and into the head of the pancreas. This was quite a young patient, about 40 years old. We decided to analyze it on MSI status. This was MSI high tumor. This patient received immune therapy together with chemotherapy. After that, he was operated on, and in this case, the surgery was about laparoscopic right hemicolectomy because tumor regression was really good. And the main thing is that during the morphological study, this patient showed complete regression of tumor, complete regression. So, we should not underestimate the role of neoadjuvant treatment for patients with locally advanced tumors of colon. So, I just wanted to emphasize it. Thank you. And what's your opinion in this context? Do all patients with locally advanced colon tumors should be checked for microsatellite instability? So do you take into account this data? Well, yes. Yes, I'm sure. If you see locally advanced huge tumor that ingrows into neighboring structures, and if you see that there are no metastases, that there are no enlarged lymph nodes on CT, then I'm absolutely sure that you should do the analysis for MSI. So now we will pass the mesentery of the small intestine to reach proximal resection margin, and after that we will start forming intercorporeal anastomosis. And now we will switch to another OR and we will return to you when you will be preparing intercorporeal anastomosis. Okay.
Станислав, мы с вами.
Stanislav, we're here with you. Yes. Hello once again. So, step by step, we are moving. Show it, please. Well, actually, the tumor is not really small, quite big, and this is where it's located. So I think that here we will select it, go lower, we will cross the part of mesorectum that will be there. We will use new Sigma device, and after that we will form anastomosis laparoscopically with circular device. We will not remove the tumor through the anus because it's not really small. So we will not reinvent the wheel. Besides, if in the upper part of the abdomen, it was quite good. We had a good plane, but here I actually selected only the anterior semicircle using the monopolar coagulator. So I went down to the mid-third of the vagina now by using sonicegen to mobilize left semicircle. Tom, I wanted to ask you, do you think that in laparoscopic surgery and in robotic surgery, first of all, we should mobilize the posterior semicircle of the colon, after that the anterior one, and after that the lateral ones? What do you think about it? Thank you for the question. It's an interesting question because, of course, standard procedure is posterior wall, lateral walls, and anterior wall. Although the plane is there from all around, and if you can say quite very frequently, it's more convenient to follow the left wall. So it can differ. And speaking about the guidelines, so the way we should teach others, then I think that regarding the way Amjad does it, so at first posterior wall, after that lateral walls, and after that anterior walls, I think that this is the optimal way for work. Yes, I agree with you. So as Amjad recommended us, we sutured the anterior semicircle, we sutured the cervix, and it's easier now. Now we're below the tumor. So let me see it. Could you please lift it? Yes. And we will follow it now. Stanislav Viktorovich? Yes. This is Kirill. Hello. Today it's very sunny in Kiev. It's -8. And I can see that here with us, we also have Ilya Godzadze from Georgia. Let's welcome him and let's give him the floor. Okay.
Ilya.
Ilya. Yes. Hello. Hello. It's quite cool today, quite cold. It's snowy. And it's so fascinating for me to watch both our experts that are conducting these surgeries. I like these surgeries a lot, and actually all the questions that are asked are very relevant. I'm just enjoying these surgeries performed by both experts. Stanislav Viktorovich, now you are treating the left wall of mesocolon. So I have a question. Now, a lot of young people are watching you, and quite frequently we notice actually the fact that it's necessary to preserve hypogastric nerves as much as possible. And could you please give some recommendations to our audience regarding the way we can do the safest procedure during total mesorectal excision, and how can we preserve hypogastric nerves as much as possible? And actually, many people discuss the importance of hypogastric nerves. So could you please share with us the way you can work in this zone with the maximum safety? Thanks a lot for your comment, Ilya. I'm very glad to see you as well. It's very pleasant for me to talk to you. And I also can boast that we have good weather as well. It's minus something, it's dry and it's sunny, because, you know, normally all of us come to work when it's dark, and after that, when we are in the OR, we can look at the screen, or we can look at the sun. That is quite seldom seen in Moscow. Regarding recommendations, well, it's difficult to give any, and, you know, I am actually experienced laparoscopic and open surgeon in case of rectal cancer, and still there are some problems related to the absence of plane to select the operating specimen well, and I selected sonicegen. I used monopolar coagulator as well. Still, I can feel that regarding the right semicircle, now I'm going from behind, rightwards. No, it's so difficult to do it, but still I am within the plane. Regarding hypogastric nerves and other structures, of course, I think that it's necessary to follow the recommendation of Amjad. So we should actually follow interfacial space. In that case, we will succeed. This is left semicircle, where you can see hypogastric nerve quite well. So here it is. And very slowly, I'm going along mesorectal fascia. And Jod actually corrected me, and it was right. When we were going down in interfacial space from behind, in this area, I actually went behind the plane. I was more lateral, but after that, I stopped and I mobilized the lateral semicircles and followed the necessary plane. So my recommendations, not only to young surgeons, but also to quite experienced surgeons, are as follows. First of all, you need to look for the plane and go along the plane. And secondly, you shouldn't worry and you shouldn't be in a hurry. Thank you. So I would like to ask another question, if possible. So I'm not a real colorectal surgeon. I actually operate on various pathologies. And when you do not have this experience in your daily practice, it's always quite problematic to conduct laparoscopic total mesorectal excision in patients that had previously been irradiated. And it's especially difficult to go along the last centimeters of the distance when you treat the lower margin of medium ampular department and low ampular department itself. And sometimes it happened that we were not in line with the plane and we went behind the pelvic fascia and we dropped sacral veins, and you know that the plexus is quite strong there. So what about you? Do you have such cases? You are a specialized institution, and if there is bleeding, is it always an indication for conversion, or there are some other methods? So what can you do to stop bleeding from sacral veins? It's a very difficult story, and now you're in the zone where we frequently argue about the presence of medium rectal artery. So do you think that it's present because you are in this zone? I think that it is present, but it is not actually quite significant in all cases. And I think that when it is present and when a surgeon injures it, it will be possible to see it, but probably in this case we did not see this artery because we're using sonicision, and this device allows us actually to operate without preserving various planes. Regarding presacral veins, this story is quite complicated, and I can say that not every surgeon is able to cope with bleeding even in open surgery. That's why it's very difficult for me to judge. And in my experience, we actually haven't had such inter-op complications related to the injury of presacral veins, but in open surgeries we had them, especially in locally advanced tumors when resection was needed of parietal fascia and other things. So you should be very careful and you should try to forecast. So if the tumor is fixed on posterior semicircle, you understand that there can be complications and you should be ready for it. And you should be able to use various hemostatics, sponges and foams. Thanks. Thanks a lot.
Вот смотрите, Илья, вот сейчас мы уже спустились ниже опухоли. Вот даже я сейчас вижу.
Okay, we have gone down lower than the tumor is. I don't really like the way it looks. We have damaged the tumor, I believe. So we can use the signal electric stapler. So now we can have the distal resection. So we can cut the colon lower than the tumor. So let us do it now. So we have gone down to the colon layer where we can resect it. So the patient isn't very obese, so quite convenient. She has the layer, and in the small pelvis we had some issues anyway. So let us pick it, and then we'll cut it. So in hospital 622, they'll start making the intercorporal anastomosis. So let us go there, and then when you perform anastomosis, we'll go there. Okay, I believe we should have a look at it. So how you are doing this, and then we will shift to hospital 62. No, just a minute. We should have a look at the colon severance. So let's go back to the other broadcast.
Переключите, пожалуйста, звук на Станислава.
Please show Stanislav again.
Мы используем вот этот новый аппарат Signia.
We're using Signia. This is like Endo-G, but it has an electric drive. So all the movements and the mechanic impact, which is usually done by the surgeon to sever by pressing various levers, all this is done by small buttons here. So at this level, we'll sever it. I'm not sure whether one cassette will be enough. So I have turned the branch, and now you can see how I press it first. And then I press the button. So we are ready to cut it. And now the electric drive will do all that for us.
Хорошо. Вот видите, я только стою и нажимаю.
So I'm just standing here pressing the button.
Скажи, пожалуйста, а вы используете какие-то варианты обработки культей перед
Are
прошиванием?
we using any treatment for the stump before suturing? Sometimes we do it, but this patient is well prepared. And we had the revision of the rectum. And before we install the circular, so we'll use betadine or chlorhexidine.
Сейчас посмотрим, получилось ли у нас.
Now let's see whether suturing was good in one go. Let's see it. Yeah, and so I believe it works, but we have some part remaining. So let's have another go. That's great.
Очень удобное устройство, скажу вам по секрету.
So this is a very convenient device. So sometimes you do it with one go, right? I usually have 2 goes for this. Well, it depends. Sometimes you have 260, sometimes you use 245, sometimes 1645. Sometimes you have it with one go. Well, the more suturing we have, the more cassettes we use, so the more chances of leakage. So if we use 3 cassettes plus, then we have statistically more often leakages.
Вот так. Ну вот так, наверное, мы будем уверены, что у нас все
So now we'll be sure that it works in two goes. It's not one go, it's two goes. Stanislav, the stapler works in automated fashion, right? Right. All the movements, opening, closing, suturing, the movement of the head, it's all in automated fashion.
So
this works, and all these movements, they are all automated. So you can rotate it. So this is really convenient. So I'll close it and we'll take it out. Okay, so we've performed the low closure, and let's have a look at the pelvis. We have the stump, and we had TME, lower plant partial mesorectomy. So the cavity is good, and the nerves are intact, no bleeding sources, so that's good. So we'll prepare the cannon for anastomies. We'll have some ophthalmic cuts to remove the tumor and to install the head. Thank you very much. Very, very informative. Thank you. Okay, so we have cut the colon in the resection margins, a small suture. So we have some disserosis concerns. So that's why we have a suture here. And then we'll start building anastomosis. Could you please comment on these small bleedings? How do you deal with them? So, if the blood supply is good, and it's good, we have some bleeding where we cut the colon. It should be clipped if this is the staple suture, so we don't need calculations, we don't need power here. So we stopped it with clips, and so we cannot see any small intestine bleeding. So everything is ready for anastomies. So on the liver we have the tumor cut. So this is our operating area, operating field. So we'll have anastomosis using this method. So we will do it as a peristaltic with a, so we make the hole with a monopolar in the intestine. We don't need a big one, a big hole. If you use some harmonic tools for this, then the cut will be bigger than we need.
Очень важно, когда мы делаем отверстия на
So when we make the holes in the small intestine, it's really important to do it here. So we don't need to cover mesentery with a suture. So we want it to have to this side for this to be visible. So hopefully you can understand what I mean. Yeah, sure, we can hear it and we can see it. Good. And now we will watch the camera.
Значит, мы сейчас тоже, вы нас заразили, мы тоже хотим использовать
we also
аппарат Signia.
Want to use Signia.
И мы его сейчас взяли в руки.
So now we are holding it. So this is the electric equipment. So people believe that if
не механический, а электрический и плавный,
it is electric drive, then the suture is more reliable. One more important thing to remember. We don't have preliminary sutures because this is much more difficult to put it on the equipment. So now you can see it's movable, and so we put it on.
Вот мелкие.
Okay, these small films are fine with us. Don't have any issues with it. So let me unfold it. And you start with the transverse colon. Yeah, with the colon which is, or with the intestine which is less movable. Yeah, let's pull it a little bit. Okay, this way.
Ждем положенные 15 секунд.
We have to wait for 15 seconds.
И прошиваем.
And then we suture it.
Ну вот на эту теперь. Не прошивает.
Okay, it's not suturing.
Что? Возьмем обычный аппарат, давайте.
Okay, for some reason this didn't work. Let us see why.
Опять закрывать?
Why didn't it work? Okay, we'll have another go. Yeah, so we'll show twice how we put it on.
Как бы это будет тренировочное.
Yeah, practice makes perfect.
Чтобы убедились все, что это не сложно.
So for everyone to see that that's not a big deal.
Где? Возьмем этот G.
Илья Леонидович, мы за вас переживаем. Расскажите, что у вас там происходит.
What's going on? How are you doing? Well, nothing to be concerned with.
Не встал. Сейчас мы возьмем обычный NDG.
We'll take the conventional NDG and suture. So give me the conventional one. Yeah, so we'll show you for the third time how we can easily put on the intestine, put it on the device.
Илья Леонидович, разрешите вопрос?
Can I ask you a question? Sure. Do we have any randomized trials to show the advantages or disadvantages of corporal and extracorporeal anastomosis if we have right hemicolectomy? Well, we don't have any trials like that. They're not easily performed. We have meta-analyses, several of them, comparing the results of intra and extracorporeal anastomosis, and they showed that there is some advantage in terms of pain, in terms of shorter postoperative time. We have fewer complications in the wounds, and we can also take out the tumor through the small cuts.
Мини-доступа. Салфеточка со спиртом. И вот поэтому мы используем интеркорпоральный анастомоз.
So that's why we use intercorporal anastomosis. We have some data, but I believe it's not well confirmed. So they say that there is a difference in terms of leakage, but I don't think there should be any leakage rate difference. But we had it from one of the trials. Okay, so now we have the napkin with some spirit. Now we'll need to close this opening. We always have a continuous two-row suture for this, and one work showed that the safest in terms of complication is closing this with a two-row continuous suture with the use of anchor or woven.
Якорную нить конкретно вот вилок мы пока не используем, хотя многие, как мы знаем, для анастомозов ее используют кишечных, потому что официально эта нитка.
We thread and we don't use the ones which are not registered for the intestinal sutures. So this was the first suture of the second row. We start with it so that we can lift the colon this way, and we'll see the whole of it. And we can look inside of the anastomosis to see whether we have any bleeding from the stapler suture line. Let's have a look. We cannot see any bleeding, as you can see, so that's an okay suture. If this happens, then we should use a clip, or we can suture this area having the same suture. So you should never use any power here.
Скажите, пожалуйста, какое ваше отношение к интеркорпоральным анастомозам?
And what's your take on intercorporal anastomosis? Is it worth it, or is it just beautiful?
It's the combination of both, I think. If you ask me where is the utility, then perhaps the utility is in obese men with short mesentery and a proximal transverse colon tumor, where you have done either an extended right hemicolectomy with a short mesentery. Then there is an advantage to both surgeon and indirectly to patient, because if surgeon can do it safely, then there would be indirect advantage to patient itself. Other than that, as long as we have a specimen to come out, it is very difficult to prove the advantage when you compare extracorporeal to intracorporeal anastomosis. When you look at indirect evidence, which Ilya mentioned, they are around the wound complication itself. So for example, surgical site infections and incisional hernia rates are usually higher with midline extraction site. So if you are purist and you look at your data, you would imagine that incisional hernia is less common with, for example, suprapubic extraction site as compared to midline. So there is an advantage in a long run indirectly. I think in the end, I always sort of say you should do what you're comfortable doing and which would result into better outcome in your hands. If, for example, I went through the whole process of right hemicolectomy in female, trying to do transvaginal extraction of the specimen using 3 millimeter ports. If you remember, Karl Storz used to have 3 millimeter instruments. And we did our study way back in 2007 and 8. Really no advantage. A patient does not even know whether they have an extraction site or not, because remember, they are cancer patient. Their main interest really is in less complication and living longer. So I use them selectively. I use them in specific indication. It takes you back to the same principle. Whether, if you remember when we were learning on-table cholangiography, whether we do on-table cholangiography for everyone or we do it selectively. And the answer was that in the beginning, you should try to do them more often so you become good at it. So when you do need them, you are able to do them in difficult patients. There is no point having no skill. And then I say, this is a big guy, it is a difficult tumor, let's try it today. That's the bad outcome. full stop. So learn the skill, that's what I would say, and use them selectively in the right indications. That's the bottom line, I think.
Ну, сейчас вы видите, мы первый ряд
Thank you.
этого шва.
So this is the first row of sutures. So now we are tying it to the thread from the first node of the second row. And now we'll have the second row of the suture, but that's not the end of this procedure, since we will have to have the deep corner suture. We saw it in the trial I mentioned, so it should be done, because in this anastomus we have a weak link where the stapler suture line ends, so we need to reinforce it. This takes only 2 minutes, and it doesn't require a lot of extra effort from the surgeon. One thing to comment on what Amjad has said. So I'm sure that we have advantages for the patient with a short mesentery when you have expanded megalectomy, and to have intercorporal anastomosis and to go through this learning curve, you should have even smaller or even less severe cases intercorporally, so that we develop the skill properly. Sure, I agree with it completely. So before you do it for those who have big advantages and where it's difficult to do, it's better to learn how to do it on more similar cases. So we should do it to everyone to learn how to do it. And the learning curve, by the way, for this anastomosis is also well studied, and it's 20 procedures, so it's not that much. And I can see that in Stanislav, everything is read for anastomosis. So maybe we should have a look at the deep corner suture. So we'll show it, and that'll be so we'll be done with that. Could you please wait a minute or two so that we show both options, the manual and with the use of the circular machine. By the way, all my surgeons make anastomosis with the right procedure intercorporally, so I believe this should be a basic laparoscopic skill, and this is something you should master. And I believe that's what they do by all active intestinal surgeons. So we were the first to start big laparoscopic colorectal procedures, but we are behind in terms of intercorporal sutures because we had equipment for all of this. Okay, so we are done with the anastomosis, and now we'll have the deep corner suture I mentioned, and that will be it for our operation. And we'll give the floor to Stanislav. Here is the place. Here you can see the staple suture, and we reinforce it with the P-shape suture. Ilya, I'm here. What's your take on using equipment for closing this hole? So we have seen it. Yeah, they use this delta-shaped anastomosis. Well, it looks like being quite basic, and as upper GI surgeons say, it's quite reliable. For the right side, it hasn't been used long. I have found 2 publications on this, and frankly, when I see the staple sutures crossing each other, I need to somehow cover this with zero sutures, because otherwise I believe this is the weak link in the anastomus. And we haven't had enough delta-shape sutures for right procedures, right-hand procedures. We don't have enough experience. I know that Alexei has performed it on a number of patients, and I believe, well, I wouldn't use it. Okay, thank you. Thank you for your beautiful operation. Thank you very much. You're ahead of time. That's great. Let's go to Stanislav. Thank you. Thank you very much. Thank you. Very good operation. Congratulations. Thank you.
Еще? Ну что, мы с вами?
Okay.
Или вы с нами?
Да, мы с
Are
вами.
you with us? Yes, we are here. How are you doing?
Ну, у нас все по плану. Мы тоже
Well, it's fine, as planned. We are also ahead of schedule, by the way, so please recognize it as well.
мы удалили препарат.
We have removed the specimen.
У нас
Everything is ready.
основные условия для формирования
We
анастомоза.
have all we need for anastomosis. We have mobilized the left side, the left flexure, and we have enough length for connection, downward connection. And when we removed the specimen, we had a cut, and we installed a head for the circular stapler. So we looked at the vessel, no bleeding here. So we have this two major conditions performed. So this will give us peace of mind. Now let's have a look at the position of the colon. So it's in the left lateral channel. So let's find the low mesenteric vessel. And so we put it this way. So this is the head and the intestine. We use a Medtronic circular stapler. So we have a 3-row suture stapler here. So we'll try to use it. Here, my assistant has already installed the circular equipment through the stump. So, hands up. And what's the diameter? 28. We like diameter 28. Good, it's ready. Let's go closer. Hands up, hands up, hands forward. So we need to tell our crew what to do. So there are many beautiful nurses around, and sometimes they look at them and not at what they're supposed to be looking at. Let us start it.
Давайте. Руки вверх.
Go forward, hands up. An important thing is that this is a lady, so that's a woman, our patient. So we need to be careful here. Hands up, connection, good. So you shouldn't have an impression that I'm shouting at my staff. So this is a standard procedure, so we are calm here. Okay, let's go back here. Let's look at the intestine, a little bit lower. Let's proceed further on. Let me have a look here. Okay, good. Let's go down. Good. Good. So this is the anastomosis line. The vagina is far away. So we have kept the pause. So now let's apply the sutures.
Ну и, соответственно, мы всегда анастомозы.
Well, anastomosis, the lower anastomosis for the rectum are always tested. So we use this bubble test. So you can call it whatever you like. So we should understand what we mean by this. So now we can open.
Ага, хорошо.
Good.
Выходим.
Let's go out.
Вот вы видите, аппарат у нас извлечен.
So we have removed the equipment.
May I
We
ask a
have
question?
anastomosis.
Кишка лежит хорошо.
You can see that we don't have any excessive. So we have a question. Okay, Amjad, you have the floor. Amjad, the floor is yours.
Yeah, I just want to ask him, do they check the vascularity of the left colon before anastomosis using ICG or marginal artery bleed? If you look at the bowel color here, maybe it is my eyes, but it looks that this is a color differentiation between the very end and the bowel just proximal to it. Maybe it is just bruised. What do you think? Do you check your vascularity using ICG technique or looking at the pulsatile blood flow?
Хороший вопрос, Амджад, спасибо. Мы, конечно же, использовали...
Thank you very much, Amjad. We have used the ICG technology. We have some articles on this. And this time, we are not using this equipment to verify this using fluorescence. This is ICG. We put the head extracorporally. We have used the margin vessel. We had arterial bleeding, so we have pulsation. So what you mentioned, so the different color of the intestine. So I believe that's the camera. So if you go down, follow, so you can zoom in, and you can see that the color is quite fine.
Yes, yeah,
So,
no, it's okay. It's okay. You're
yeah, I
absolutely
agree.
right. I use them in a very selected cases. I don't routinely use it, but I agree. If you have a pulsatile blood vessel, which you have seen, then this is good enough. It was just the camera effect. Thank you.
Да. Спасибо. Спасибо большое.
Thank you very much, Amjad. Thank you. Thank you very much for keeping your eye on us. This is really important. This is noteworthy, indeed. We should check the blood supply in colorectal cancer, in oncological surgery. This is really important. This way we'll avoid many life-threatening complications. Thank you very much, Amjad. Colleagues, we can show the specimen to you.
Давайте переключимся в 62-ю больницу.
Так, подержи этот кончик. Нас видно, да?
Okay. Can you see this? So this is the specimen. Mesocolectomy.
Ну, я думаю, что
Well,
можем признать качество удовлетворительным. Еще раз.
the quality is satisfactory, I would say.
Все, да? Мы заканчиваем тогда. Всем спасибо.
So, okay, thank you.
Спасибо, спасибо вам.
Thank you.
Давайте перейдем к трансляцию Станислава.
Okay, Stanislav.
Сейчас будет выполнен пузырьковый тест.
So now we'll have the bubble test.
Раздуваем.
We are inflating it.
Я пережал кишку.
I have clamped
Сейчас я немножко его...
the bubble. I'm pressing it.
Ну, вроде как проблем никаких нет.
I cannot see any issues here.
У нас получился низкий анастомоз.
Well, that's low anastomosis, the mid-third of the vagina, and that's enough. So I will conclude this by having a preventive stoma. So we believe that in these cases, we should make it. Artem, what's your take on it? Sure. Will be elastoma or tonsilostoma, elastoma. And anastomosis. Do you try to make it end-to-end, or do you have side-to-end, or some other types? Well, we are open to any options. The only thing is that when we try to use nose technology, when we remove the specimen through a natural hole, then we can have it side to end. So we can go with the head intercorporally, and then we use the linear stapler to close the bowl. If you put in the head extracorporally, I don't see any advantage of side to end, because we can use the circular suture. That's it. We are done. And I cannot show you the specimen because we have already provided it to the morphology department. And I can tell you that the specimen looked quite good. And these pieces were not the mesorectal fascia, so we went out of the layer laterally on the side walls. So this is even better. Hopefully that, but morphologists will be happy. Thank you very much. Thank you, Stanislav. Thank you much. That's a great operation. Amjad, I believe you have a comment. You are welcome.
No,
Amjad,
thank you.
You are welcome.
Yes, thank you very much for the nice demonstration from both operating theaters. Well done, both of you. And like you said, if it's a TME or near TME, then a loop ileostomy is a preferred choice for our practice as well. So this is as standard as you said. Thank you for demonstration.
Ну, а мы можем перейти дальше. У нас дальше по плану лекция профессора Амджада.
Okay, let's proceed. Let us invite Professor Amjad to talk about training for young surgeons.
Okay. Right, thank you. I'll just try to share the screen if I can. And okay. I come out of it. Okay, well, first of all, thank you really very, very much for asking me to come and witness some beautiful operating and see the progress, which is always very nice to see. And thank you for some familiar faces. I know Kirill and Ilya from Georgia are both here. So good to see you both, and good to hopefully that you are doing well. I was asked to talk to you about modular training approach in laparoscopic colorectal surgery. I think this is something which is being practiced intuitively around the world without making it sound like a modular approach. We tend to teach our trainees in a very structured way, where we could actually teach them in what I call small diets and ask them to reproduce the operation. This is what the modular approach is all about. So thankfully, training landscape has changed. With laparoscopy in particular, this has become very, very convenient to teach and train people. Today is the perfect example. We are sitting halfway around the world, and we can witness some beautiful operating and interactive discussion between the colleagues. And this is what is made possible by advancing techniques and technology. This is a very famous, as it were, picture from 1970. This is a cardiothoracic surgeon in Texas, USA, Dr. Cooley, who decided to demonstrate his coronary artery bypass technique. And all the trainees used to come and witness this. Now, if you spare a moment and have a look here where the operation is being done, some of us are hanging around here talking to each other. So you can imagine that they have a very little chance to learn anything that is going on here. So thankfully, things have changed. This is the new way, this is the new world where people can sit in far remote areas and teach and train people. And this is true with laparoscopy and for that matter, robotics, so to speak. So when people talk about learning, I'm just going to give you 3 or 4 slides about the concept of learning and how people learn and what you need to retain information. This is a very well understood, very well talked about 4 cycle of learning, as it is described as. Most of us or most of our trainees, when they start, they are usually in this bracket where they are unconsciously incompetent, which means that they are really not aware of what they need to learn and how they need to learn. From this step, from this box, as it were, you need to come into this box where you know that what you need to learn. And this applies to the trainees, people who wish to become a laparoscopic colorectal surgeon or trainees. They really need to be in this box to know that what they need to learn, but they haven't got the skills yet to acquire it. And that comes down to trainers like all of you guys sitting around this conference to make them skillful, as it were. And then the idea is the trainer need to be here, and the trainer need to shift between the two. When you become very good, you saw today Ilya showing a CME technique, and most of us focus very, very hard when we're doing the dissection around the superior mesenteric vein. And it is fascinating just to watch that he could talk, he could change hand, he could change instruments, and he was just doing it with unconsciously knowing how his hand come in particular angle where the instrument goes on the superior mesenteric vein. So he was really here in this box when you watch him operate. But as a trainer, you really need to be in this box, because if you, as a trainer, you are here and you can do it without telling people why you are able to do it, then it's very difficult for the trainees to learn anything. So as a trainer, you need to step out of this box and come here and tell them that what effort needs to be done, what effort needs to be made for people to learn this. How do you describe conscious competence? Obviously, competence or conscious competence is performing the task in safely and within the reasonable time frame fashion. This is just the general definition of competence. But conscious competence comes from conscious competence comes from here, where you can perform a technique, but you really have to think why you are able to do it in this way. And unconscious competence is what I just alluded to. You just saw our colleague demonstrate this very, very nicely. So when you think about learning, this is an important pyramid to remember, how people learn. And this is really important for me, because if you think about it, conventional learning before the surgical training is happening around the top of the pyramid. People lecture you about something, you go around and read about something, and then as soon as the audio visual component come into it, or you come to the conference and watch the expert do it, your learning is around here. If you take it further down and goes down to group discussion, like today, for example, people talking to each other, exchanging ideas, telling us what makes it worth doing it, whether we need to give them immunotherapy, whether we need to give chemotherapy in locally advanced colon cancer. He spoke about MSI instability, for example, and you learn something, you go back and you read it and you get better. Then you have to practice. When you practice something that you have learned, your learning happens at a much higher rate, 75% of the time. But remember, when you get to this stage where you are teaching and training others, your learning is much faster. So in some ways, whether we like it or not, being a trainer makes us a better surgeon. Being a trainer forces us to be a better doctor, a better person, because in order to train others, we need to know this back to front. So this is what I call the pyramid, as it were. what do you need to retain what you have learned? This is a very interesting graph, and without putting it into the graph, we know this. For example, you memorize something, it takes about 3 to 5 days before it disappears for average brain side, right? And you could see how the forgetting happened, the projected forgetting curve as it is, you know how it happens. But let's say I memorize something, but then I do the first revision or first repetition of what I have learned. This could be in the form of reviewing the videos. It could be in the form of going into operating theater and practicing that. You could see how the curve tend to be slightly flattening out. You need to you retain this information much longer. And as the repetition increase, the retention increase. And that's what is the real key, the purposeful repetition in order for you to retain the information that you've been taught. So this is really for the trainees, if you're listening into it, why it is important to videotape your operation, why it is important to go and practice what you've been just taught. We spoke about modular training a long time ago. This is 2011. You know, I was in Portsmouth, the initial part of my consultancy, and people were interested to learn laparoscopy. But the problem was that you have a lot of trainees and you have finite number of cases to teach people. And people say, well, unless you teach me 100 cases, I'm not able to learn this. So we thought, okay, what if we divide the operation into modules or steps and then teach surgeons accordingly? So one trainee would do a couple of modules, the other trainee would change position and do the rest of the 2 modules. And the idea was to see that whether A, you can train people, and B, when you are training people like this, do patients have bad outcomes? So we looked at that. This is Anil Hemandas, who wrote this paper very, very long time ago with me. And if you look here, we did about 227 cases altogether consecutively in the timeline. And these are laparoscopic procedure, right hemicolectomy, left hemicolectomy, rectal dissection. And then if you look at here, what were the number of modules being available, you could see the proportion of these done by the trainees. The right hemicolectomy, left hemicolectomy, all the modules, 96% of the training modules were done by the trainees. Of course, when you come to rectal dissection, the TME part was done by the consultant, but you can see significant proportion still done by the trainees. So this was the nutshell of that. Prospective data for 4 senior trainees who were at the time with me. So 2 would scrub for each case. We did 227 consecutive cases. And I've given you the nutshell of this. Each training module, what is the advantage of doing laparoscopic colorectal training in a modular fashion? Each procedure is broken down into number of modules. And within each module, there are segments where there are simple steps, you know, how do you clip inferior mesenteric artery? What clips do you use? How do you identify hypogastric nerve plexus, for example? And the idea is that when proficiency or competence is gained in some segments and modules, the trainee moves to the next step. It's easier for the trainees to understand the operation. It makes it very easy to give them feedback, which is very, very important. This is a classical example of right hemicolectomy module, 2 modular operation, patient setup, port placement, exposure, managing small bowel, vascular pedicle isolation ligation, medial to lateral dissection. And then module 2 would have the rest of this, So one trainee would do this particular part, the second trainee would do this particular part, and when they become competent, they switch the modules, and then you maximize the training. This is the left hemicolectomy module, very, very similar. It's important to realize that. At the time when we were looking at it, people thought that maybe there is a difference in how the trainees learn from you. So this is HST are your resident or fellows or senior resident, if you want to call them. We call them specialist registrar. And at the time, we were running national training program, and we had established consultants who were coming to our hospital and they wanted to learn the operation. Their median age was 55 years, while the trainees' median age was 34. So there's a big difference between the 2 groups. In the same time, you would see that NTP trainees are the consultants. These are the trainees. These are the number of cases done in each half. Conversion was very similar. Lymph node yield, median, similar. R0 resection rate, major morbidity, and length of stay was similar. Because there was a common denominator, and the common denominator was the trainer and the program or the training program that was being taught to two different groups. So people can learn this at different stages. Then everybody said to me, it's all very well when people work with you, you can hold the camera, you can hold the tissue, they work in a nice environment, so their outcomes has to be good. So I thought, okay, the 4 guys or a girl that I showed you did the modular training, they became consultant, and I asked them to give me the data of the first year of their consultant practice. So this is their cumulative data for those 4 people. And you would agree with me that their outcome were very, very similar to when they were working with me. If you look at the R0 resection rate, length of stay, and everything, very, very similar. So it is possible to learn this. It is also possible to take it away and practice this. So conclusion from that particular paper was that modular training facilitate quicker learning and better understanding of procedure. Obviously, standardization of operative technique make it easier to teach and to learn, and there is no difference in clinical outcome and procedure is performed by an expert or supervised trainee. This is a similar paper looking few years further. This is 2012. We looked at impact of national training program on our trainees. You know, this is expanding it a bit further. And this is 3 groups of people. You know, this is people who were my trainees. These are national trainees, the consultants who are coming in here. And this is the procedure done by the consultants themselves. Very, very similar outcome when you compared all 3 groups. The conclusion from this is just a cancer resection data, R0 resection rate, 96, 98%, lymph node yield the same. The data suggested that there was no impact on the trainees for learning laparoscopic colorectal surgery, even when you're training senior guys. So how do you measure progress objectively? You know, I can teach people and I can make some nice comments, but do I have any evidence? Do I have any objectivity to it? And this is very, very essential if you teach trainees in an objective way. This is one such tool. This is a national training program tool called Global Assessment Score Sheet, which the trainer fill. For example, if somebody would have done the operation with me, I would be doing this scoring at the time for each module, whether they performed it or whether they did it proficiently. And this has to be done in real time at the end of the procedure to have the meaningful data. And the idea behind this is that then based on those scores, you can almost calculate a proficiency gain curve when people average score become median in every module. So in this case, there are about 21 cases. So it took 21 cases for people who were learning laparoscopy colorectal surgery national training program. These are the borrowed slide from NTP. The advantage is this, that each module you can measure. So this is not surprising that, for example, theater setup and anastomosis and exposure would be learned very, very quickly. You could see the curve flattening out very, very quickly. But when you look at other steps of the operation, vascular dissection, mobilization of the colon, dissection of splenic flexure or mobilization of splenic flexure, it takes a long time to do this. So then you can focus, if my trainee is struggling constantly in this step of the operation, then there is no point asking him or her that let me do this very, very quickly, and then you can do the rest of the operation, because there is no learning for them. So you better say in your learning agreement that you would be doing this operation or this step. This is another advantage. You can map the trainees and find out how the curve is flattening out. As a trainer, you know, I know that you guys are running the training program in Russia now. I would be interested in trainee D and address the problem somewhere here rather than at the end of 25 cases. This is important to remember. So what do the trainees need to do? Obviously, they don't need to do this because you are giving them information and the information is leaking out. This is the forgetting curve that I showed you. You know, number of days and the memory log. With each repetition or review, the curve becomes flatter and flatter. So the trainees, when you are teaching them something, they need to reflect, they need to review the videos, they need to review the information you have given them. There are different types of trainees. Artem asked me to focus on this and sort of give you an idea of what are the different types. You know, you can have people who are shy and they are quiet. It doesn't mean they don't know it, but they need to be encouraged. There are people who know everything. They would tell you that they have done this with Professor so-and-so. This is not a problem at all. There are some who need to be heard. There are one who are very quiet. There are others who want to embarrass the trainer. They want to make sure that show the trainer. So there are different types, and you need to figure out as a trainer, what is the trainees type that you are dealing with. This is important to remember as well. You know, your confidence level are very, very high when you are not very competent or when you are at the beginning of your experience. So as you become more experienced, your confidence level also go down because you realize that this is not that easy. And when you become expert, then your confidence level starts to go up. This is very important to learn as a trainer when you are teaching somebody, because they be having a very high confidence and you can leave them alone and then they would have a catastrophe. So what makes a good trainer? Not all surgeon makes a good trainer. This is important as well. Some of us can do the procedure beautifully, but it is very difficult to teach people. Some great surgeons actually are very poor trainers because they find it very difficult to explain or to have a patience to stand and watch people do it. This is important as well. This is just a diagram to show you what are the attributes of a good trainer. You know, but they are just a number of things that you can look at. You need to be able to speak to the trainees. You need to assure them. You need to tell them what needs to happen. You need to explain the task, what is on hand, then demonstrate how this needs to be done, and then watch them do it, then watch them practice it, compliment, correct if they have mistakes, and then also keep giving them positive reinforcement. This is important as well for them to remember. So how do you become a good trainer? Teaching technical skill and other factors, like including psychological factors, leadership techniques, and human factor, which are non-technical skill acquisition. These are important as well. The concept of conscious competence, as I spoke to you, is very important for the trainer to realize that they need to be constantly explaining to people why certain technique work in a certain way. And then this can be applied to other specialties. I call this is actually Jameel Ahmed, who is a consultant in Northampton, a former trainee of mine. He came up with this idea of called PDF approach. P is for planning, D is the dialogue during the operation, and F is the feedback that you have to give to people. I think this is a very easy way of remembering, and this is a very structured way of remembering. So this is his idea of how you teach people. So what does planning involve? Planning obviously knows that you need to know your training well. You have to discuss about the case that is on hand. You should set up the objective for that particular case. For example, if the trainee talked to me and say, you would know at what level they are. I spoke about a trainee, for example, who struggled with splenic fracture. Then my objective would be, or their objective would be in that operation, to focus on doing splenic fracture mobilization under supervision. You have to communicate with the team. You have to tell the team if there is a training case, this might overrun, or they have to be patient. Theater settings are important, but at the bottom line is this, that no matter what we do, we have to ensure that the patient safety is on hand. People don't have bad outcome while they are being trained on. So planning is important. Dialogue during the operation is very, very important. I think this is the key that I'm still learning. I'm not very good at it. You need to give them very clear, common, and concise instruction of what to do. The language has to be very, very clear. You have to give them instruction of how their performance can be improved during the operation. This is really important not to overload them with a lot of instruction. This is something called cognitive overload. If I have too much information given to me, I would stop thinking. I would just follow the instruction. This is important not to do that. You have to deconstruct the operation. You have to direct them. You have to pause and give them chance to ask the question, encourage, and then give them the positive feedback too. So this is another way of remembering it. Step-up approach. Stop if there is a problem. Talk to them. Ask them, do they identify the problem? And then ask to them, what is the best way of getting out of it? Explain to them, why would you like them to do things in a structured or different way? Make sure they understand what you have explained, and then ask them to proceed if it is safe. So what does explaining mean? Explaining mean is very simple. Have their understanding. Ask them, what do they understand? What is going on? Where is the problem? There is no point just keep giving them instruction and they just follow it like a robot without having a reflection on this. Ask them what they would like to do or what they would like to propose to make it easier for them. And then identify any technical problem or challenges that may be coming through. Proceed if it is safe. Why feedback is important? Feedback is a very important aspect of being a trainer and the trainee. When I give feedback, I usually ask my trainees, ask them, how do they feel the operation have gone? Because it is very important for me to get the insight on the trainees. You have to encourage reflection. You have to encourage that they need to reflect, critique the performance. This is a very difficult thing to do as a surgeon. We are very, very peculiar tribe. We don't want to be critiqued by our colleagues. But the true learner is the learner who still wants to be critiqued because they want to improve. Be honest in your feedback. Don't say things that only pleases the trainees, or don't say things just to make them feel very small. Be honest. Behave like a role model. Obviously, it is important. And develop learning point agreement. This is a very well-known cycle of feedback. We all know about this, that you have to sort of start with discovering the issues, analyze causes and consequences, create options, commit to action, and evaluate well. The focus really is going round and round and to develop this. So conscious competence, this is sort of coming toward the end of my talk. Conscious competence is a key for us to understand. It is a key thing both for a surgeon and a trainer. You need to have empathy, you need to have patience, excellent communication skills, leadership quality, so they trust what you are teaching them. You should be able to organize your operating list and the training program in such a way that the trainees don't feel rushed. You need to be aware of what potentially can go wrong. I always say preempt the problem, don't chase the problem. If you are chasing your problem, you probably would be able to deal with that, but then usually the horse is bolted. It is important not to do that. And the idea behind this is that all of our training program would result into specimen bit like this. These are a different specimen done in different part of the world, done by the different trainees and the trainers. But one thing is very, very consistent, which is the surrogate marker of our quality. And that is something that we really should not compromise on. So in conclusion, my colleagues and anyone who's listening through the Zoom call or YouTube channel, my conclusion is that learning and teaching requires structure and standardized approach. I think both trainees and the trainer have equally important role to play. Repetitive, purposeful practice holds the key. Also, objective, formative feedback is vital for people to realize if they are improving or not. And I genuinely believe that modular approach of training maximize training opportunities without putting our patient at risk. I'm really grateful for all of you to ask me to come and speak again. I'm happy to take any question or comment if you have.
Ребята, а есть возможность задать вопрос?
So, do we have an opportunity to ask a question? Yes, of course, you can do it.
We meet almost every day last 2 weeks. Can I ask
Yes.
one question? Does your patient know that his surgery will be performed by trainee, but not by consulting?
Yes, that's a very important question. So the part of the consent process is your operation, the part of your operation would be performed by the supervised trainees. But I am the covering consultant. I am in operating theater. I am not in my coffee area asking them to do this. And I hold the ultimate responsibility for your outcome. So they know this. And this is part of the consent process.
But if patient doesn't agree, what should you do?
Yeah, no, that's a relevant question, because in the end, it has to come with patient consent. So if certain particular patient would tell you, no, I have not come from Manchester to Poole to have this operation done by you, I want you to operate on me, then it's absolutely fine to keep that into consideration. But like I said, it's a question of how you put it across to them. There is a very small proportion of people who actually have refused, and I have ended up operating on them, because then you have to honor that. Because as a clinician, we have a duty toward our patient, not necessarily saying, if I don't let my trainees do this, and if you want me to operate on you, you have to come as a private patient. This is not something that we offer. This is not something that we do. They get treated the same way, whether they are a private patient or in NHS patients.
Okay, thank you. And best wishes from our team. Do you remember Marina?
I do. I do. And it looks like you are making them work hard. Thank you very much.
Thank you.
Thank you, Alexei.
Уважаемые коллеги, я предлагаю поблагодарить профессора Парваиза за прекрасную
Distinguished colleagues, let's thank Professor Parvaiz for his brilliant presentation.
Да, конечно, конечно.
Yes, of course.
Yes, Ilya.
Hello. Nice to meet you, Amjad, and
nice to see you.
It's a great honor for me to be your trainee, your pupil in surgery. Not only in surgery, in philosophy also. And I know that you like some philosophy questions, and I want to try to ask it to you.
Sure.
So you showed us this beautiful diagram about Kruger diagram, yes?
Yes.
About the confidence. So we learned from you that if you are a good surgeon, it doesn't mean that you will be a good mentor. As for me, I suppose that you are the best surgeon, colorectal surgeon, and best mentor for me. But where can you find yourself on this diagram? As if we can speak about you as a mentor. What is your confidence level as a mentor?
Right. Okay. So I think this is a very relevant question. It is a question which is beyond the question, effectively. If you ask me the face value of it, something which I teach all the time, my confidence level are very high. But certainly when I'm teaching, and I'm teaching on a particular patient, for example, or a particular step, then my confidence level depends on who I'm teaching to. So for example, if this is why this is an ongoing relationship between you and your trainees that is reflected in teacher-mentor or mentor-mentee, training episodes. So when people work with me and they work with me long enough, my confidence level and their confidence level built as we proportionately go along the curve effectively. At the start, my confidence level is at the bottom of the curve when I meet somebody new. And people who do not know their limitation, their confidence level is very high. Potentially, some of them could be very high because they think they can do this very fast. And some people would have the confidence level very low because they have a very low self-esteem. They think they have to learn everything. They don't move unless you tell them to move. So the nutshell of what you're asking is that as I grow older, as I grow more experienced, I realize more and more that there is so much more I have to learn how to teach. There is so much that I have to learn of how to manage the trainees. You know, it is not just the skill acquisition. It's not like just to teach you how to clip the IMA. It's the question is which patient you want to clip the IMA. You know, what is the case selection? What is the cancer oncology principle behind it? There is so much more learning that needs to happen. And I'm growing older and I'm running out of time, as we all are, thinking that I hopefully would have enough time to at least learn this concept. So I think it is what you sort of put across to me, the skill set level confidence improve very, very quickly. So for me to teach the skill, I'm very confident I can teach people because I've done this hundreds of times, let's say. But whether I'm putting across to them the philosophy of cancer care, I'm putting across to them the philosophy of learning, my confidence is not that high because I'm learning myself.
Thank you very much. And one more question, please, Amjad. What is the main lesson that you learned from your trainees being a mentor?
Yeah, I think the lesson I have learned from my trainees is that, you know, they are the goalpost for me. You know, for me to judge myself, how good technical surgeon I am, I really don't look at, you know, people's praise. I look at into the eyes of my trainees. So when my trainees tell me that this is a good enough operation, and when my trainees can demonstrate by themselves that they are doing the operation that I'm trying to teach, this is the goalpost for me. You know, this is the goalpost I set for myself. So effectively what I've learned all these years from my trainees is that they hold the key for me to improve. You know, I could have started and done after 100 cases, thought I have cracked it, I'm very good at it. But actually I didn't. And I kept asking the guys or girls I train and say, what do you think of it? And they would challenge me. They would ask me where the Waldeye's fascia is. They haven't seen it. You know, I can't make it up. So I have to make that much effort to demonstrate Denevalius fascia, the hypogastric nerve plexus. And I don't progress unless they are satisfied. So I really have learned this, that for me to teach people have made me a better person, a better surgeon, because I have to keep going back at learning and reflecting, which I'm still doing, by the way.
Thank you very much, Amjad. Thank you. Thank you.
Глубоко уважаемый Амджад Парваис, уважаемый профессор.
Amjad Parvais, Professor Parvais, I would like to sincerely thank you for participating in our Congress, in our Festival of Endoscopic Surgery. Now, you've done a brilliant presentation devoted to training in minimally invasive surgery. This was very important for each of us, both for young surgeons that are only starting minimally invasive surgeries and for the experienced surgeons who have been here for quite a long time. Thanks a lot. We would like to welcome you and to thank you sincerely for participating in this conference.
Thank you very much for the kind invitation. Thank you.
Спасибо большое, Илья.
Thank you.
Продолжайте, пожалуйста.
Ilya, Kirill, now you can continue your conference. Thank you. The next presentation will be done by the speaker from the Institute, Petrov Institute, and Alexei Petrov will be presenting. Are you here with us? Yes, I'm here. Hello, I hope you can hear me. So, you will present a multi-center randomized trial, the immediate results of rectum resection after cancer, after mechanical preparation of colon, compared with medical preparation. Hello, colleagues. First of all, I would like to thank the organizers for the opportunity to represent the trial. And besides, we actually have a New Year campaign. We will present 2 trials instead of 1. They are very similar. That's why we'll speak about 2 trials. So the first has already started. The others are in process. And speaking about our ideas regarding preparing the colon before the surgery, here we have some field for maneuver. We have some opportunity to choose. And, actually it's rainy in our city, and in spite of quarantine, we are using our personal cars. And every car owner knows that when it's raining, the main question that we ask ourselves is, do we need to wash our car or not? Because if you do, it will rain and your car will be dirty again. And different car holders saw it differently. Some of them do not wash their cars when it's raining. Some of them remove dirt mechanically, others use some chemical agents to prevent further dirt appearing on the car. And normally when this is a large car, people do not actually take care of the beauty of their frame. They do not wash their car at all. And if other people have more sophisticated cars, normally they try to remove dirt somehow. Normally they remove it mechanically. So now we actually can make a reference to preparing various parts of intestine. So probably we prepare colon and rectum a bit differently. Speaking about colon, regarding mechanical preparation, and here I'm speaking about peroral automatically active laxatives, we normally reject this mechanical preparation and we do not prepare colon at all. And speaking about rectum, we use mechanical preparation because in most cases we are forming stoma, and for the stoma to be better, to avoid any discharge from the rectum, we ask our patients to have preparation of their rectum. So could I please request the organizers to switch off parallel sounds, because actually it's quite difficult for me to speak. So routine, the mechanical preparation is not used with peroral antibiotics, and peroral antibiotics are used within trials only. So what do we say? That in principle we reject routine use of isolated mechanic preparation of intestine. We actually have a lot of scientific data, 17 randomized trials where mechanical bowel preparation was compared with no mechanical bowel preparation. We did not see any differences. I'm speaking about colon. I'd like to remind you about it. And starting from 2011, so actually 10 years have already passed, Cochrane review has recommended to reject mechanic bowel preparation. And these guidelines was also present in guidelines on fast recovery. They also recommend not to use isolated MBP because there are no advantages, and this is additional load both for the personnel and for the patient. It can result in renal problems and impaired electrolyte balance. Speaking about the use of mechanic bowel preparation and peroral antibiotics, why is it a bit different? The matter is that in this case, mechanic bowel preparation is used not only to remove the contents of the bowel, but also to distribute antibiotic in the lumen evenly. Some trials were conducted, about 2 dozen randomized trials. They are very heterogeneous, and it's quite difficult to compare them in terms of groups of comparison and drugs that were used. But still, in 2014, Cochrane review confirmed the advantage of using MBP together with oral antibiotics. This is not present in the guidelines yet, but in 2019, mobile trial was published. This trial was conducted in Finland. It was well organized and the sampling was sufficient, and they did not see any advantages. Actually, in this case, the endpoint was the frequency of wound infections. So one problem is that data are quite heterogeneous, and the second problem is related to the isolated use of oral antibiotics. There are 1 or 2 randomized trials that also let us understand that these potentially can be a good way, but still it should be studied. So when we look at the spectrum of possible ways for preparing the bowel, do nothing, use MBP, MBP plus OA or OA only, we can say that isolated MBP is not recommended. Isolated use of oral antibiotics should be studied. The use of MBP and OA seems quite promising, with some remarks. So, being guided by this predisposition, we decided to conduct 2 trials, and we prepared groups of patients for them. They were a bit different. So we want to understand how efficiently it is to use MBP with OA, and we think that it's worthy to compare the new method of treatment with the routine practice. So regarding the colon, we compare absence of preparation. We're using it now, and I think that most centers are using it as well, and MBP plus OA in the trial group. Speaking about the rectum, routinely they use isolated MBP, although actually there are no such guidelines for colon, but for rectum it seems quite reasonable, and we will compare this group with MBP plus OA. So for colon, the groups of comparison, no preparation and MBP plus OA. Coloprep, this is the working name of our trial, it will be changed later. And regarding the rectum, this trial is ongoing. Actually, it used to be called RectoPrep, and now the abbreviation of rectal preparation for resection, the abbreviation is REPCAM in Latin letters. These trials have already started. First patients have already been included, so now we're getting ready, and when we describe all the technical aspects and when we describe all the sheets, all the details for doctors from our centers, we will invite other centers as well, and very soon we will launch a similar trial for colon. And I think that as a result, altogether, we will be able to get a good result from this REPCA trial, and we will receive the answer we need. Many people may ask, why do we need to conduct these trials? There have been 19 or 17 randomized controlled trials. Let's use their data. One answer is that we should check it ourselves. You know, it's quite dubious, and I'm quite skeptical, actually, regarding these results. I do not think that we're different from patients or doctors in Finland, for example, but the data are quite controversial, and the main thing is that the antibiotics, this chemical agent that is used for cleaning cars, for example, and in this case, this is antibiotics that are used by our Western colleagues in most cases. These are kanamycin, metronidazole, gentamicin, neomycin, and none of them is registered in Russia as an agent for preventing surgical complications. So what do we have as a result? Today, we cannot administer them routinely as a component for bowel preparation. And if we want to conduct a trial, then to include one of these drugs, we should follow the norms and requirements to the publications that are trying to extend the sphere of application of a drug. And normally these trials are conducted by pharmaceutical companies because this is a very specialized issue. It is very labor intensive and very costly. So speaking about the search for antibiotic that will be used in our trial, that is one thing. And secondly, we should be able to recommend this antibiotic because this is label use. This is the use in accordance with the guidelines. And in this case, it is recommended to use this drug to prevent surgical site infection in colorectal surgeries. And according to our data, the only such drug registered in Russia is rifaximin. So we decided to use it because it's the only drug that was registered. And if we speak about mechanic preparation with rifaximin, actually there haven't been such trials yet. So can we recommend rifaximin for routine use or not? We should study it. There are no such trials in the world. That's why these two trials are unique and they're so important for Russia because we do not actually have any other options apart from rifaximin. Speaking about our trial, our primary endpoint was the frequency of wound infection within 30 days after surgery. The secondary endpoints included anastomotic leakage and other complications. they're quite understandable. Speaking about the volume of sampling, the frequency of complications and wound infection was taken from all previous experiences as 12%. According to other trials, we can expect that the frequency of purulence will decrease by 50%. So we think that it will be about 6. Superiority margin is 0. Standard indications of power and alpha. And taking this into account, we defined the volume of sampling, and all the methods gave us similar figure, about more than 600 patients. So this was our target volume sampling. It's about less than in code. And we know that there are actually other centers that are ready to participate. And we expect that within 2.5 years, we will be able to include 622 patients into both studies. So how can we define the patients that should be included? The criteria of inclusion are quite extensive. And actually, when we speak about rectum study, that is below sigmoid segment, and when we speak about colon study, that is above this segment. But we will not be able to include the patients that administered antibiotics during 30 days, that have stoma, or that have contraindications for MPP drugs, OOA. These will be patients with impaired, with actually bowel obstruction, because there can be some problems in this case. We will not be able to include patients that need bowel preparation. In any case, if intra-op colonoscopy is planned, or patients with any tumor complications, such as perforation or occlusion. So what is our plan? Before the patients are included, the trial is registered on clinical trials. PrEPCO trial was registered there as well. And we think that it's very important to specify the rules of the game in the very beginning, before including the first patient. After that, in every center, screening is conducted. So patients that actually can participate are checked for compliance with inclusion-exclusion criteria. After that, randomization is done. And it's also important, we are now specifying the way it can be done. Antibiotics are taken 3 days before the surgery, so the patient should be included into randomization at least 3 days before the surgery for the patients in both groups to receive adequate preparation. After that, surgery is done. And as we mentioned, in both studies, the groups are a bit different. Coloprep, colon, some of them received nothing, others received MBP plus OE. Rectum, all patients receive MBP anyway, but in control group, these will be MBP without anything else. And in the trial group, these will be MBP plus OA. What does MBP include? These are drugs on the basis of macrogol. You can see the scheme on the screen. It's standard rifaximin. We actually follow the guidelines in this case because we do not conduct the trial on the norms of pharmacological study to extend indications. This trial is a research work that compares 2 types of bowel preparation. So rifaximin will be administered in the dosage of 400 milligrams once in 12 hours, 3 days before the surgery. After that, the surgery is done, and after the surgery, we monitor the patients. We assess primary endpoints. And in this case, the observation will last only 30 days. And in our opinion, the primary endpoint, actually here we selected the definition that will be extended on all centers. This is infection that includes 1 layer of anterior abdominal wall before the peritoneum, and that has the following signs.
Выделяемые из раны, в котором обнаружены микроорганизмы. Что это означает? Если из раны ничего не выделяется и все хорошо, признаков воспаления нет.
If there isn't any discharge from the wound, that's fine. We don't have any infection. So if we have a discharge, then we'll look what it is. If it's pus, then it's clear. if we have concerns, we don't know what it is, we have some further analysis. So we believe that path discharge and setting would be a very clear criteria to assess the primary endpoint. So after this assessment and data collection, then we'll answer the question in a month, whether we have a reduction in the wound infection rate. This data will be published, and hopefully we'll be able to perform it by all the rules, and then we'll be able to publish this in good journals. We invite everyone to participate in this trial. You can see our contacts. So you can send me a WhatsApp message or an email. And I believe that before the new year or after the new year, we will add new centers. So we can start discussions before the new year to discuss the provision of this medication and some other issues. So I believe that within 2 years, we will reach our target. Thank you very much for your attention. Thank you, Alexei. That's a beautiful presentation with a lot of animation. Thank you very much. We wish you success in your trial. Colleagues, do we have any questions? Do we have any questions? Ilya?
Нужно включить микрофон.
Please switch on your mic. Yeah, I'd like to thank you. By the way, Alexei, they're expecting you in the operating theater. So really hope that other centers will participate, because this is not difficult to participate in this. And I hope that this trial will let us stop reading the news from other countries. We'll have our own evidence base. And we believe that participating in this process is a good cause. So hopefully others are going to join. Thank you. Let me remind you, colleagues, this is our second trial. So we wish, the third one. Yeah, we wish you success. Good luck. Thank you. Ilya?
Ну, вот, безусловно, классная идея, мне кажется, как и все идеи, которые происходят, которые рождаются у команды Алексея Михайловича. Мне кажется, что всем нужно максимально присоединиться, и Алексей Михайлович великолепно все сформулировал, новость нужно было самим делать, а не мультипликироваться. Спасибо моей, наверное, самой любимой менторской команде, в которой это люди, у которых я учусь, и призываю всех тех людей, кто планирует заниматься этой хирургией, занимается, активно сотрудничать с Институтом Петрова и с отделением Алексея Михайловича. Спасибо большое, ребят, классно все.
Alexei Petrov and Alexei Karachun. Okay. Talking about intracorporal anastomosis. The type of anastomosis, will it be a limiting factor, like the need for interoperational colonoscopy? Will it limit people from participating in this? Because we know that intraoperational intracorporal anastomosis ask for very good bowel preparation. The trial will be randomized, so the patients will be split into different groups. The type of anastomosis will be fixed, and the choice will lie with the surgeon anyway. And if the surgeon should believe that for his operation they need preparation, then the patient will not be part of this trial. So this will be a conclusion. So those who had intercorporal anastomosis, so they didn't include the patients because they should have preparation. So we see that overall mechanical bowel preparation is not recommended as a potentially harmful procedure.
Кирилл, тебя не слышно. Включи микрофон.
Kirill, switch on the mic, please. Thank you. Colleagues, if you don't have any questions of Mr. Karachun and Mr. Petrov, let's proceed. The next speaker will be from the State Center of Coloproctology, Mr. Achkasov, and also Mikhail Alexeyev. So, you're welcome. Hello, colleagues. Let me start my demonstration. My name is Mikhail Alexeyev. I'm head of proctology department. Thank you very much for inviting me to this conference. So, fluorescent angiography. In my speech, I'll share with you some global experience and our own experience, which is very big and the biggest in Russia, I believe. So some results of the randomized trials we have published in colorectal disease and other journals. Anastomosis leakage is an important issue. Colorectal anastomosis are built, many of them, and we have seen one of these operations, and the number of articles is growing, but the problem hasn't been resolved. And why so? There are many risk factors. Maybe not all of them are well studied. And so the definition of the leakage. So in the past, it wasn't unified. And now we have a well-known definition which lets us the same thing in different centers. And we also have 3 levels, A, B, and C. And so we have, so usually they use type B and C, and for C you need reoperation. Risk factors. There are many of them, 3 big groups, and well, we can impact only the last one, the surgeon factor. And the important thing is the intestinal blood supply. So we believe that this will pretty much determine issues or absence thereof. Now we are using a subjective method. We are based on the color of the bowel and pulsation and also bleeding from the vessel. And opinions have differed. Some said that maybe the blood supply wasn't very good, but the operating surgeon was happy about it. Maybe we're not that happy about it. But so this is a subjective thing. We need more objective methods, like fluorescent methods, which will let us standardize all this. Sure, there are other things like flowmetry, region contrast methods, spectroscopy, but they are all expensive and difficult to use. In colorectal surgery, for the last 10 years, I believe, we have used fluorescent angiography. We use it for visualizing tumors, metastasis in liver, and other things. So we will focus on the blood supply today. And to use this method, we have used and are still using ICG. Unfortunately, the registration in Russia may expire. So ICG is put into the vein. It quickly spreads, and in 2 to 3 minutes, you can see the glow to understand whether it goes to the area where you are going to have anastomosis. And this will determine whether there will be enough blood supply to this area or not. So here you can see fluorescence. So the place the surgeon picked is supplied by blood pretty well. That's not always the case. So the surgeon thought that supply was good, but fluorescent angiography showed that 4 centimeters proximally is there. So that's where they should reject, otherwise they'll have issues with anastomosis. So why we performed our own randomized trial? So it all started with Bila-2. It was published in 2015. This is a multi-center randomized prospective non-comparative trial, 139 patients. We had colorectal left colectomies or lower anterior resections, and the level of leakage is low, so only 1.5%. And this is very good. At that time, the paper review showed about 10 trials, and all of them were not randomized at that time. Some didn't have a comparative or control group. So you can say that the leakage rate went down twice. And we have seen several meta-analyses. One of them was in 2018. So fluorescence imaging was used, and colorectal cancer and rectal cancer. Another analysis, more than 500, also colorectal cancer. Reduction in leakages after fluorescence angiography, and one more meta-analysis published quite recently, about 500 patients, but this is the lower anterior resection. Also, we can see fewer leakages. We can see the results of the first randomized trial results, 240 patients, 2 arms randomized. The reduction in leakage is twice, from 9 to 5%, but the groups are small, so we are not talking about statistical significance here. The trial we've been expecting, Pillar 3, follow-up on Pillar 2, the lower anterior resections. The results haven't been published, but I found them in the clinical trials gov. Here we can see 175 patients in each group, less frequent leakage, 9.5% to 8%, but this is not significant. One more comparison of trials. We participated in this, a big sample. Fluorescent angiography reduces leakages for males with advanced age, obesity, and low anastomosis. And so considering this conflicting results, we decided to run our own fluorescent angiography related trials for colorectal anastomosis. We had our meta-analysis. We saw more trials here and more patients, 1,220 in the core group and one randomized trial. And at that time, we can see the reduction of leakage in colorectal and in rectal cancer. So good results for this. We had our own trial. We had a pilot. 52 patients had fluorescent angiography before anastomosis, and we assessed whether the position was properly identified, and then we had X-ray for anastomosis within 30 days to have the type A leakage identified as well. So the changed plan for resection for every 4th leakage wasn't identified in this group. 3 patients in total, 5.8%, and this was X-ray leakage. The results of the pilot. were followed by a randomized trial. We had two arms, fluorescent angiography and without it. And they also had the X-ray contrast anastomosis survey, 400 patients in total. In the major arm, they changed the position, the plan, or every fifth changed the plan, and they reduced leakage from 16% from the control group to 9% in the major group. So this is the table. We published it in colorectal disease. So why we reduced the rate of leakage? We didn't see the reduction of clinical leakage after fluorescent angiography, but we saw the reduction in X-ray leakage due to low anastomosis. Maybe fluorescent angiography can help us find ischemia and have more reliable anastomosis. We also had a multi-factor analysis. 20 factors were used for this analysis, and one of them was fluorescent angiography. And we also considered sex, male low position, and young age. And we consider this increases leakages. For fluorescent angiography is a prophylaxis method for leakage. We built a monogram. This is a tool to forecast the occurrence of leakage for a specific patient. In this monogram, we had 4 factors which are important independently. This monogram had good predictive power, and this monogram has very good negative prognosis significance. So if the chances of leakage are low, then it's 90% probability. And if the patient has low anastomosis, maybe we can avoid preventive stoma. And in conclusion, I'd like to say that based on our data, fluorescence angiography is a good method. It can be used in intraoperation navigation, and based on the results of our trial and our analysis, we can see that this method is objective for identifying the perfusion of the colon. We need it for sure. It can be a preventive measure for leakages of anastomosis. And so we are waiting for ICG registration to proceed with this method. Thank you. Thank you very much. Colleagues, do you have any questions? Alexei? Thank you very much. So, I have a lot of emotions here. Well, we are the only country in this regard who banned the usage of this medical drug, which is used worldwide. I believe it's good. It has an issue. It's a lymphotropic. It's not tumorotropic. But I believe that's the first step in the right navigation surgery when we have tracers to the endothelium of vessels, arteries, and nerves. So maybe in the near future we can use traces for various structures to be able to have a good fluorescence. When the arteries are red, veins are blue, metastasis say brown, and so on. So this is really promising, and we really like it that you have used this for your trial. This is great. Thank you. Thank you very much, Alexei. Colleagues, I cannot see any other questions. We are a little bit behind our schedule. So the next speaker will be Sergei Yefetov, head of coloproctology department of the First Medical University. Sergei, can you hear us? Yes, I'm with you. I will talk about use of the nose technology in colic cancer. You're welcome. Thank you very much, colleagues. We have talked about changing my topic a little bit because we talked about nose last time and before that. That's why this time we decided to talk about lymphodissection in the right and left part of the colon, and we'll talk about the differences in approaches depending on the size. So this on the side. This discussion has been on for a long time, and lymphodissection was postulated in 1909 by Jameson and Dobson, and there they determined the major groups of nodes. So you can see great illustration. You can see the lymphogenic metastasis pathways, and this was split into groups. To the right, you can see our fantasies when we imagine the colon spread, well, how it was developed when it was a primary tube. And so to understand how blood supply works here, we can see the two major arteries, only two of them, upper and lower mesenteric vessel, and they are responsible for the lymphatic system collection in the left and right parts. And in this Jameson-Dobson work, they showed some principles of lymphodissection. And for a long time, we've had new works which give us new guidelines and anatomic guidelines for dissections. And as a result, the left side colorectal treatment are better than for the right side surgery. And this is based by this work and also big systematic review and meta-analysis showing that the left side cancer treatment is better based on meta-analysis. Why so? The authors of the meta-analysis talk about embryonic development, expression of genes, and different types of growth, and different clinical picture, but they don't talk about lymphodissection for some reason. Okay, let's go back to this time. We should remember the classical work by Werner Hohenberger called Standardized Surgery for Colonic Cancer. And for the first time, he says that complete mesocolic excision is a key thing in having good results for treating colorectal cancer. But we should ask the question, can we standardize this today when every day we have new and new data on our patients who have colorectal cancer? Let's talk about some anatomy. Okay, let's take the axial crosscuts of mesorectal of mesentery. So we can see the right part fixation and the left part fixation, and we can see the lymphatic nodes of different parts of the colon. So what shall we pay attention to? So when we have the cancer of the left part, we are dealing with the medial margin of the mesentery where it's fixed to the aorta. And here, for the right part, the lymphogenic spread of tumor is in the middle of mesentery. If we start from the small intestine and go to the rectum. So for the right part, we need to delineate this using some specialized techniques. Let's have another look at this. So this is the lateral margin. This is clear because that's where mesentery is fixed to the bowel. At the medial margin, so here we can see the colon ends, and it goes to the mesentery of the small bowel. And here we have upper arteries of the mesentery. So what is the proper guide for us, the vein or the artery? So many say that veins should be, the vein should be used as the border. And some say that you should use the upper mesenteric vessel to have proper dissection. So, with time, the complete mesocolic excision terminology has merged with the topic D3 lymphodissection, which is used in the East. Why should we use personalized approach? Because for every patient, we should have the individual selection of the margin for the surgery. If we look at the vessels for the upper mesenteric vessels and see how it is located, then we can see at least 6 different types, and they are shown here. And here you can see the 3D reconstruction of vessels. Okay, is it important for the dissection? Well, hypothetically, it should work like that. So if the artery is above the vein, then the lymphatic nodes, which are at the foundation of the colic artery, they should be seen by the surgeon and removed by the surgeon in the operation. But if we use the left, or rather, if you use the superior mesenteric vein for lymphodissection, then a part of the colic vessel under the vein with the cells around this vein and the artery with the nodes, they can stay, lymph nodes, they can stay with the patient. Is it important or not? Before we read this article, we only assumed that there is something behind it. And the group of Japanese authors had an interesting study comparing the results of 160 patients with artery above the vein and 160 patients who had the artery below the vein. And this is the propensity score matched analysis, and the patients were picked really well. And so if the artery is below, then, so this is the previous slide, lower option, 5-year survivability was 18% worse than in the case when the artery was above. And the same holds for 5-year no relapse survivability. And this difference was important. When we have multi-factor analysis, the same authors say that if you look, so the position for the right side cancer, the position is as important as TNM stage.
Are there any differences in lymph node dissection in real life? Let's look at the interop picture in this slide. Here we will see that initially the surgeon did lymph node dissection and crossed the artery in the place where the outer margin of superior mesenteric vein was located. But after that, it turned out that the basis of either colic artery since 12 centimeters from this place. It is interesting to note that we conducted our own trial on the anatomy of Russian patients. We compared it with the patients with similar localization of cancer. Gene Cancer National Center. And it turned out that Oriental patients, and compared with Russian patients, it turned out that patients with complicated anatomy are quite frequent in Russia when this artery is below the vein. The patients that received worse results were described in the trial of Japanese doctors. So, when we position CME with D3 lymph node dissection, we specify that the dissection line should follow the anterior surface of superior mesenteric artery, and we should take into account that irrespective of rectum arteries and their position regarding the vein, we should see the surface of the artery in the operating field to fulfill extended lymph node dissection in case of right colon cancer. And what about left colon cancer? Well, at first it seems that everything is a bit easier because the median border of complete mesocolic excision is at the surface of the aorta. And we can completely separate mesentery here. And we can completely remove the mesentery of the colon. And why cannot we use the term of D2 lymph node dissection together with complete mesocolic excision? Please look at the picture in the bottom part of the screen. Here you can see that as soon as we shift the dissection line towards intermediary lymph nodes, at the surface of the aorta, we leave the part of tissue with lymph nodes that can contain metastasis. This is a part of mesocolon. We cannot say that this is complete excision. No, this is non-complete mesocolic excision. This zone is located at the base of inferior mesenteric artery, but not everything is as simple as we wanted, because in the left colon, the variability of vessels is quite high. So we can speak about 5 different options of rectum arteries location. And when we have patients with colon cancer of various localizations, we should conduct specific type of lymph node dissection. Of course, if you want to conduct vessel-sparing surgery, and if you want to conduct the colon resection that is necessary from the oncological standpoint. In our clinic over the last 2 years, we have calculated the number of lymph nodes that are removed using this technique, and it turned out that on the average, every patient has from 20 to 60 lymph nodes removed. It depends on the location of tumor in the rectum and on the stage of the disease. On the web, we can frequently find videos that show the way lymph node dissection is done for patients with rectum cancer or sigmoid colon cancer. And we can see these videos where the basis of inferior mesenteric artery is crossed by a cotton device with preliminary clipping, but we do not see the place where it stems from aorta, where it goes away from aorta. When we started analyzing the length of inferior mesenteric artery from the place of aorta, it turned out that this distance can vary. That's why the main milestone for us to be sure that we conducted extended lymph node dissection, that we remove all the apical group of lymph nodes, should be the base of inferior mesenteric artery, where this artery is moving away from aorta. Why is it important? There is an interesting article in Japanese. It was written in 1991. This is Sata and Sata, and they reconstructed the lymph ways and lymph nodes that are responsible for the rectum. It turned out that the main groups of lymph nodes that should be considered apical ones are located not only on the surface of the artery, of inferior mesenteric artery, but also on the surface of the aorta. Besides, they take lymph from the colon. So, how important is it? There are 2 clinical cases here. They show that metastasis in lymph nodes, this is group 253 of lymph nodes, and this is not a myth, this is a reality. So these patients are hospitalized for further treatment. This is a patient. This patient received surgical treatment due to sigmoid cancer in one of oncological hospitals of Russia, but after that, they saw tumor at the anterior surface of the aorta. Disease progression was diagnosed, and chemotherapy was started. However, with this chemotherapy, they've seen growth of this metastatic lesion, and at some point it started involving aorta and inferior vena cava. PET-CT showed that this is metastasis of colorectal cancer, most likely in the lymph node system, group 253 of lymph nodes. This patient addressed our clinic. We conducted oncological consilium, and a team of coloproctologists and vascular surgeons removed this metastasis. Prosthesis was placed, so aorta and inferior vena cava were replaced with a prosthesis. How reasonable is it to conduct such surgeries? The matter is that previous similar resection was conducted 13 years ago. So it was conducted by coloproctologist team. This was Petrovsky Surgical Center, and a huge metastatic lesion of aorta was removed. This vessel was replaced with a prosthesis, and in 12 years, this patient addressed us repeatedly due to cancer of pancreas tail, and she was operated on due to different oncological disease. So more than a year has passed from the second operation. This patient is alive without any signs of metastasis or recurrency. So I'd like to move on to the conclusion of my presentation in case of left sigmoid colon cancer. The picture and the principles of lymph node dissection are quite clear. We know where the colic vessels are. We know where the intermediary vessels are. These are the branches of inferior mesenteric artery, and we know where the apical lymph nodes are. They are at the basis of low mesenteric artery and aorta, and on the surface of the aorta. Now let's look at the right colon. So these are the results of trials. This trial was conducted in our clinic. This is international trial, T-REX study. Here we can see intermediary and apical lymph nodes, their number, and the frequency of metastasis in various groups of lymph nodes. So this picture is quite interesting. Let's compare the frequency of apical lymph nodes in right colon cancer and the frequency of metastasis in intermediary left lymph nodes in case of left cancer. This picture is almost similar. So we considered that probably we do not understand the way lymph nodes can be divided into groups in case of right colon cancer, because we never speak about the basis of superior mesenteric artery. We only speak about the basis of colic branches that are intermediary for left colon cancer. So what if the true classification of lymph nodes should be a bit different? If the zone of D3 lymph node dissection is located at the basis of superior mesenteric artery, so this zone cannot be actually reached in routine practice. And of course, we do not actually want to do any super large resections. But what does it show? When we speak about D3 lymph node dissection within the border of superior mesenteric artery, we can achieve maximum removal of lymph nodes. That is quite possible in surgical practice. So we remove the group of D2 of lymph nodes. And in case of right colon cancer, we can shift it from D2 to D1. In this work, we can see the lymph nodes not only of the left colon, but also of the right colon. And these lymph nodes are located along superior mesenteric artery, and they are located upwards towards its bases. So, taking into account the huge amount of data that we can receive regarding our patients, we need to think of personalized treatment for each patient. And the subject of lymph node dissection is still discussed in all international publications. It shows that we have not reached consensus regarding terminology. And in this regard, it's quite difficult for us to assess the differences in the results assessment. Most likely, we need to use the artery rather than the vein as the endpoint of lymph node dissection to be sure that we conducted it in a complete volume. And the differences in results of treatment can be associated not only with the site of colon tumor, but also they can be related to various approaches to dissection in case of right and left colon cancer. Thank you. Thank you, Sergey Konstantinovich. Yuri Gennadievich, your mic is off.
Нет звука, Юрий Геннадьевич.
No sound.
Professor Dorov.
Professor Dorov. Hello, Andrei.
Hello. So,
thank you for joining us, Sergey. Thanks a lot for your brilliant presentation. We're a bit late now, so we do not actually have time for questions. Thanks a lot for this session, Alexey Mikhailovich. Thank you. And now we should move to the session on treating inflammatory bowel diseases, pelvic floor prolapse, and we will finish with the oncological section number 1. Thank you. Thank you, Kirill. Yes, thank you. I would like to thank all our colleagues, all our chairpersons and presenters for these brilliant presentations that we've seen in the morning. And I would like to thank Yuri Gennadievich for the brilliantly organized 7th Moscow International Festival of Endoscopy. Thank you, colleagues. I wish you a good session. Thanks a lot, Artem Leonidovich. Before moving forward towards our next session, we'll have our promo video from our sponsors. So I would like to thank all the presenters and everyone that participated in the first session. Distinguished colleagues, now we will have a few minutes for this promo video. Created this promo video. And thanks because this promo video actually. So while the promo video is on, you will continue. I will move to another room and you will have How long will the video last? 8 minutes. So you can get a point that we need to follow a bit will play this co-sponsor copy, but you're not actually interested in their video. Okay, but I just have to another room because the meeting has already started, so I will leave you now. And everything is great. I'm really happy about it. I would like to thank you for everything. Thank you for a great job.
Experience the evolution of freedom of movement.
How can we know that
from the trusted name in cordless ultrasonic dissection devices?
You will be informed.
Introducing the redesigned Sonicision curved jaw cordless ultrasonic dissection device. The cordless design reduces the challenge of managing cords in a sterile field and provides freedom of movement and mobility during your surgical procedures, contributing to a safer and more efficient OR. Available in 4 shaft links to help meet your specific need. The Sonicision curved jaw cordless ultrasonic dissection device enables secure vessel coagulation and efficient dissection in open and minimally invasive surgical procedures. The tapered design of the curved jaws enables precise access to tissue planes in confined spaces. The intuitive dual-mode energy button is designed to improve focus on the surgical field and procedure. The Sonicision curved jaw device has an improved reusable generator that is now autoclavable and enables 1.5 times more procedural uses than the legacy device. The improved battery can be used in twice as many procedures. The redesigned charger features a user interface that provides easy-to-interpret battery charge status and battery end-of-life indications, enabling efficient battery management. The non-sterile nature of the battery also removes the need for sterilization and streamlines preparation for reuse, and provides an 88% increase in battery capacity, which may mean fewer procedural delays due to mid-case battery exchanges. The Sonicision curved.
Сейчас я всех вижу. Сергей Иванович, добрый день. Я вас до этого просто не было видно в зуме.
Я звук не включил. Да, сейчас могу с вами поздороваться тоже.
Армен Асканович.
Всем добрый день.
Andrei, how are you?
I'm fine, thank you. I'm fine.
Situation with the Belgium level?
We just had a lockdown for 6 weeks and now it's any better, yeah. So we can only start to operate and so on, but we had a tough time for 6 weeks. And again, infections are going down, but very slowly. So we're looking forward to the vaccine. But a lot of people are afraid to get vaccinated. It's going to be tough to convince everyone to get the
Осталось 2 минуты.
Алексей Игоревич заходил?
Сейчас мы попросим включить. Остается 1 минута. Остается 30 секунд. Артем Леонидович, мы сразу на вас.
Thirty seconds left. Twenty seconds left.
10, 9, 8, 7, 6, 5, 4, 3, 2,
3, 2, 1. Hello, dear friends. We're continuing our program. We have the second part of our colorectal day. It is devoted to treating inflammatory diseases of bowel, pelvic prolapse, and parastromal hernias. Here we have Professor, Doctor of Surgery from Leuven University Hospital, Andrea Dor. He is our good friend and a well-known European surgeon, author, and one of the surgeons that actually initiated the surgery known as laparoscopic ventral rectopexy for treating rectal prolapse. This is a very popular surgery. Almost 90% of articles are devoted to the results of this intervention, and we will be able to listen to him and discuss his lecture. Sergei Ivanovich Akchikasov, head of surgical department from Coloproctology Center. I do not even need to introduce him. He is a Russian surgeon, coloproctologist, and oncologist. He will be moderating this session. And Armen Vaskanovich Vardanyan is here with us as well. Armen is Chief of Surgical Department for inflammatory bowel diseases from Coloproctology Center. We will also have Alexei Moskalyov. He will speak about diverticulosis. And we will listen to a recorded lecture of Igor Belyansky. He is a very famous American surgeon, hernia expert. He will speak about optimal approach to treating parastromal hernias. Unfortunately, due to time difference, he did not manage to join us on air, but we will have a chance to listen to his recorded presentation. Dear friends, now I'd like to give the floor to Andrea.
So I hope you can see my screen. Thank you very much, Dr. Goncharov, for having me in this virtual meeting in Moscow. I'm going to address a little bit the history of laparoscopic ventral rectopexy and where we are heading to. As you know, I think it's a progressive understanding that rectal prolapse is not one disease, but it's rather like a spectrum from internal prolapse to patients who have a rectocele and internal prolapse to patients who clearly have an overt rectal prolapse. You will find young patients who have a congenital problem and are straining problem, but then most of the people have a weakened pelvic floor, and you will see combinations of prolapses which make the repair even more complicated. And of course, it's a rather female pathology. But I think this is very important to understand, that you have like a three-compartment concept. So whenever you have a dissenters in one of those compartments, it's going to have an influence on the middle and on the anterior compartment. And so that's very important to understand if we correct with the lap ventrectopexy, that we also are able to correct also the middle pelvic compartment. And here you clearly can see in this old lady total rectal prolapse and uterine prolapse. And here is what's happening. So you see a patient with a total rectal prolapse on this difficography, and at the end of the straining, you see that small bowel loops are protruding further this prolapse. So you should correct not only the rectal prolapse, but also the enterocele. And that's important that we do understand the anatomical basis, so the different levels of support of the middle pelvic compartment, which is the uterosacral complex, the rectovaginal septum, and the perineal body. And clearly, level 1 and 2 can be corrected by the lap ventrectopexy. It's very hard to correct level 3 with only an anterior approach. But we do know that when you look to patients with total rectal prolapse, that about 42% of them will have an enterocele. So you need to deal with that. So we need to restore anatomy. We want to improve anorectal function. We want to avoid functional sequelae. And of course, you have two types of approaches to rectal prolapse. You have the perineal approach and the abdominal approaches with different kinds of rectopexies. When you look to those minimally invasive transanal approaches or perineal approaches, we do have the LOMs, and we can also resect and do an Altemeyer. But when you look to recurrence rates, even in expert hands, for the primary, it's about 40%, 20 to 40%. You never can use it as a secondary intervention, because then again, you see that the recurrence rates are above 50%. So you can use these techniques for the frail patients, but not for young dynamic patients. And on top of that, and we demonstrated that in '96, what you do is either you plicate or you resect, and you put like a straight tube on a weakened sphincter. And those are the consequences, that incontinence is going worse. And this is due to the fact that you reduce the functional reservoir. So if you want to optimize the functional outcome, you should leave the rectum in. And that's what you're doing with abdominal mesh rectopexies. But in every kind of rectopexy, Ripstein-Welch, you needed to extensively mobilize the rectum to hook it up in a higher level. And as a consequence of that, we found that in all those older series, you had postoperative constipation ranging between 30 to 60%. And this is due, probably most is due to autonomic denervation, because you completely mobilize it. And as a result of that, you induce rectosigmoid inertia. And this, of course, gives you then post hoc rationale why the resection rectopexy in that regard is working better than just doing a rectopexy in itself. So this forms clearly the background where we were thinking on lap ventrectopexy. So we need to keep the rectum in. First, we do avoid sigmoidal inertia, and we do know from difficographic studies that the antisusception starts in the front, and it also impacts the middle pelvic compartment. And so we want to correct the leading cause, which is the full thickness intussusception. You want to correct concomitant enterocele, preserve rectal ampulla, avoid autonomic nerve damage, and make it a safe and easy operation. And this is what it is. So you do only a very limited dissection into the rectovaginal septum, and by the unique position of the mesh there, you hook it up to the sacral promontory. There are no blood vessels there. By here fixing it at the level of the deepest part of the Douglas to the rectum, you inhibit intussusception. And it gives you the possibility, at least for level 1 and 2, to reinforce that. So you can treat both things. Here you can see how it works. So only be prudent, because the hypogastric nerves run very close when you open up the sacral promontory. So be aware of that. So that's important when you free the sacral promontory. Then you need to make an inverse J-formed incision, but at the deepest part of the Douglas. So you need to reduce the prolapse. And that is primordial. If not, you're going to lose your way. So reduce the prolapse firmly before you then make the incision on top of the prolapse there. Don't start here, but first reduce it, and then you open up the rectovaginal septum. The incision is along the uterosacral ligament that you can see there. And you make on top of it an incision, and you go through and through all layers until you find the naked muscular coat of the rectum. And then you leave all tissue adjacent to the vagina, so that you have another interposition between the mesh and the vagina, the dorsal aspect of the vagina. And as you can see here, we don't do any lateral dissection. So the autonomic nerve supply to the rectal sigmoid remains intact. Then you're going to decide whether you need to resect the Douglas fold to get a good adhesion of the mesh to the muscular coat. And those are the points of essence that really you stick the mesh to the rectum. We now today use a kind of medical glue to facilitate the fixation of the mesh so that it remains flat into the rectovaginal septum. Today we also use a kind of screws to facilitate the fixation of the mesh to the sacral promontory. So this is then done. Then you need to look for the middle pelvic compartment to reduce the enteroceal. Here you see a patient after hysterectomy. You can use those lateral borders and fix it to the same mesh. Of course, when you have a complete eversion of the vagina, that's not enough. In those patients, you need to add a formal colpopexy with another mesh on top of it. So today, what are the indications? External rectal prolapse, high-grade internal rectal prolapse, especially with fecal incontinence, some patients with ODS, complex rectal seals and enteroseals. And here you see an example of a complex rectal seal. And indeed, you could go for a perineal approach. But as you can see at the end of the straining, the patient also got an internal prolapse that blocks it. So this is an easy case to treat with a lap rectopexy. So let's look to the long-term and the outcome, not only in regard to recurrence, but also functional outcome and mesh-related septic problems. Indeed, we do have some recurrences, and most of the recurrences happens at the dehiscence of the mesh, at the anchorage, at the sacral promontory. You can see it's quite decent numbers. We look to a large group of external rectal prolapse patients, and it's about 8% at 10 years interval. So it clearly mimics outcome from other types of mesh rectopexy. The question is then if we, by restoration of static pelvic anatomy, also improve function. You know that all those patients with total rectal prolapse will become incontinent. It's multifactorial, but probably the stretching of the muscular floor is one of the main reasons. And indeed, and this is from a landmark article back in 2004, you see that we saw a significant improvement of Wexner scores at 1 year interval and with a follow-up of 60 months. So we found improvement in 90% of patients. And that's the reason that in every patient with fecal incontinence, we do a diff echography. And even in those patients with a hidden prolapse that clearly starts to open up the anal canal, we're going to propose rectopexy. And here you can see that improvement and curage of incontinence in intra-anal rectal intussusception, so no overt prolapse, is rather the same. Here is our cohort analysis of nearly 1,000 patients. Again, you can see a significant improvement in about 80% of the patients. And we do know that if you would opt to start with sacral nerve stimulations, that those patients with high-grade intussusception do worse than those patients who don't have an intussusception. Again, in this paper, high-grade internal prolapse, significant different outcome in regard to the working of sacral nerve stimulation. So therefore, we propose this algorithm that if your patient has a high-grade intussusception and incontinence, you start with a ventral mesh rectopexy, you wait for 1 year, and only in those patients with persistent incontinence, you're going to go for PNE and sacral nerve stimulation. And one of the key elements here, even when you put a mesh in the front, that the rectal capacity and compliance capability of the rectum remains the same. So that's the clue in sparing continence. And then we were amazed to find out that when you do the laparoscopic ventral rectopexy, that you saw a reduction in constipation. And this was, of course, not for slow transit, but especially for obstructed defecation. And this has been the reason to look more in depth to this type of surgery for also to treat patients with obstructed defecation. And here you can see in this UK paper that indeed, with patients with rectal seal, you see the same improvement as patients with total rectal prolapse. However, when you look to the overall picture, it's less impressive than for incontinence. So we found an improvement in about 70% of the patients. Here you can see where we plotted every study in and look to the improvement of obstructed defecation and fecal incontinence for external rectal prolapse. And clearly for fecal incontinence, the improvement is significantly better than the improvement you find for obstructed defecation. There is one randomized trial looking to the posterior suture rectopexy versus lap ventral rectopexy. However, at the 1 year interval, they hadn't seen any difference, although there was already a difference in recurrence, but not reaching a statistical difference. But down the line, at 6 years, you can see that in every aspect of defecation, lap ventral rectopexy was superior than the suturepexy. And again, in regard to recurrence rate, not significant due to the small number of patients, but again, a trend towards a difference. So clearly, lap ventral rectopexy is superior than suture rectopexy in this. But if we want to use it as really an operation for ODS, it has been overrated, and we need to fine-tune the indications. And one of those examples is if you see that the rectum before the intussusception is like gliding over the pelvic floor, rather than having this configuration, those patients are not responding well to lap ventral rectopexy. So we start to more and more understand what's going to be the patient who will respond to treatment with lap ventral rectopexy. But it has been overrated as a functional operation. And the knowledge gap is that we do not know what's the relative impact of the anatomic findings and the dysfunction of the pelvic floor. This brings me to the last point there, that we also need to look to mesh-related complications. As you can see here in this large series, it's about 3%. And again, you can see a difference between polyester and non-polyester. So it makes a difference what type of mesh you need. And this has been one of the position statements. And again, we do know, and that's important to underscore, that mesh morbidity is far less than in transvaginal procedures. Suture material, try to avoid the non-resorbable sutures, and polyester should be avoided. When we look to all series here, mesh erosions occurred in 1.3%, and chronic mesh infections in 0.2%. So indeed, it's very limited. And this is in complete contrast to the transvaginal prolapse repair, where you find within 1 year, 10% of erosions, colpopexies about 5%, and we do have less than 1% now. Again, when you look to this Finnish study, where they prospectively followed all the patients, you can see 5 vaginal erosions. Again, they had some vaginal perforations at surgery. So there is a warning there. If you perforate the vagina, abort, don't place a mesh in that situation. There is a systematic review. Mesh erosions do occur, but it's very limited. It's less than 2%. And it's not nil for the biological mesh. And the biological mesh will result in far more recurrences. So where are we now after 20 years? Also, the Americans now say that there is a strong recommendation, but still there is low quality evidence. It has gained some widespread global acceptance due to its impressive results relative to the cure of prolapse, recurrence rates of about 8%, and also function. And that's very important. So we can improve incontinence and we avoid constipation. I thank you very much for your attention. Thank you.
Thank you, Professor.
Спасибо большое, Андре.
Thanks a lot, Andrea. We haven't seen you for a long time, actually, due to coronavirus.
Hello, Andrea. We haven't seen each other for a long time. We are really beyond the schedule. And just a short question from me. So you have accumulated huge experience in these operation surgeries. Are there any situations when you expect bad functional results of these surgeries and where you will say no to mesh retroflexy and do resectional treatment?
Yeah.
Maybe a combination with solitary ulcer of the rectum.
Yeah.
Or are there situations when you would not recommend this intervention?
So we have seen some occasional patients who have also prolapse and some endometriosis. Endometriosis can be very hard then to open up the rectovaginal septum. So in those patients, we aborted that. You can have seldom some patients who have a history of diverticular disease. In those patients, I would go for resection and suturepexy in those patients. I'm very afraid to offer this operation in patients who have internal prolapse, obstructed defecation, and pain, because those tend to have IBS kind of constipation, and we try to avoid to offer them any surgery. And as you know, for solitary rectal ulcer, whatever you're gonna try, in some patients it helps temporarily, in other patients it doesn't help at all. We don't have a clue what's really happening there in most of those patients. So again, very reluctant to offer this kind of surgery in this kind of patients.
Спасибо большое за ваш ответ эксперта. Сразу
Thank you
чувствуется.
very much for your expert response. We see that you have a really huge experience in that. And the next presentation is by Dr. Goncharov. Will you be commenting your video presentation yourself? So the topic is a robotic retropexy in rectal prolapse. Right, while the surgery is going on, please play the video. We wanted to show you this surgery in real time, but there are a lot of COVID limitations and it would be difficult to find such a patient and for it to be representative for this conference. However, this topic is of much interest. Andre, if you have time, please stay with us. But of course, you decide. I think that.
Perfect. I'm gonna stay for this video. Thank you.
Да, и мы попросим вас комментировать и давать свои.
And please comment on it and express your expert opinion on that. I'm not an expert in this field. My experience in rectopexy is just a little bit over 20 surgeries. The curve of education has just been completed. We have performed several open surgeries and several laparoscopic ones. This patient is quite typical, but that's why it is of interest. A woman, 41 years old. She suffered from pain in rectum. There were blood discharges and there was prolapse. She had some psychosomatic impairments as well. And although she was in several hospitals, in several inpatient facilities in Moscow, they did not identify prolapse, but they identified a rectum ulcer, which was treated conservatively. They took biopsy, and the patient was discharged without any improvement from the inpatient facility. And when she came to us, we knew about the particularities of prolapses, and I asked the patient to strain herself, and we saw external prolapse of rectum, about 10 centimeters. And we saw eroded mucosa and several ulcers on the surface. We prepared the patient. We examined her. We did not identify any other pathology. The surgery for thoracal one assistant, we use a Da Vinci SI system. It presupposes 3 ports and one 12-millimeter port for optics and 12-millimeter port for help. On stage 1, we mobilized a sigmoid intestine and fixed it not to get into the pelvis, for it not to fall into the pelvis. Sometimes it can be done with the stapler. And we also fixed the uterus, just the way we do it in gynecological surgeries, just to work properly with our 3 operating hands. When we inspected the Douglas space, we saw a hernia-like sac which was filled with the colon, with the jejunum, what we see as enterocelli when we do defecography. And this is a defect which requires elimination during the surgery. The uterus is fixed. And then I wanted to ask Professor Dore, as for men, do you perform surgeries in the same way, or are there any differences?
in male patients, you have two different types of prolapses. You have prolapses that start very high, and then you do the same type of operation, but you stop at the level of the seminal vesicles. But most of male have like a smaller prolapse, which starts very distally. And in those, you do an endoanal procedure.
Спасибо. Ну, первым этапом этого вмешательства, как
The first stage is identification of a promontory. So we need to see the nerves. We are very interested in and then so there is the tunnel which is formed to insert the mesh. We are very interested in the right ureter here. Deep mobilization is not required on the posterior surface, and limited mobilization of the rectum is more than sufficient here. Professor, do you use a monopolar coagulation, or do we need harmonic, or maybe?
No, we just use monopolar energy and open it up on scissors or a grasp. Clearly like this type of surgery, yeah.
Ну, то есть, что роботическая, что лапароскопическая хирургия.
Both in robotic and laparoscopic surgery, there are no differences in approaches. They are similar. And my opinion is based on a small number of surgeries, and I think that laparoscopically there are no problems, and robotic installation only has the advantage of convenience, for the surgeon, but it's not as significant as in a total mesorectomy in men. Even though there is quite much work performed and robotic operations have been assessed, and they do find some advantages there. Professor, I know that at your university there is one or even several robotic installations. Do you continue to operate laparoscopically? I know that your robotic installations, they are just in the next room, or do you use robots? So do they have advantages?
We still do it laparoscopically because the robots are overused also by the urologists and also by the gynecologists. So we just starting up a program of robotic resections rather in the oncologic field to do like a CME, as has been explained. That could be one of the advantages to have a robotics there. And for some complex pelvic resections together with the urologists, like a rectal cancer together with a prostate cancer, that we do with the robot now.
Скажите, вот здесь идет очень высокая мобилизация брюшинного листка с дугласового пространства и оголяется фактически задняя стенка влагалища очень высоко. Нужно ли это для того, чтобы выполнить адекватную ректопиксию? Или можно этот разрез брюшины дугласового пространства сделать ниже, в области ректовагинального перехода, который мы идентифицируем при подтягивании за прямую кишку?
Andre?
Here, I think it's easier when you first redress the prolapse completely and go there in the deepest point, because now you are starting on top of the Douglas fault and it's far away before you're gonna reach the rectovaginal septum. If you redress it, it's easier. So instead of having your one arm lifting the cervix, we grasp the rectum and the Douglas fault and then make the incision there. But at the end, it's going to be the same, of course.
Мне тоже показалось, что здесь больше
Me too. I thought that more time is spent here for mobilization, and we don't really need that to place the mesh in the correct place. Maybe, but another thing here is to mobilize enterocelli, that kind of pocket of the peritoneum, and then saturate or duplication of the peritoneum in this place in order to remove this deep pocket pouch. I had an impression that in mobilization, when it is mobilized, then it gets higher. The peritoneum pouch gets higher, but we'll look at it in the final stage. So maybe we could go initially lower because we would have to cover less distance.
Скажите, пожалуйста, Андре, если...
Andrea, if at this stage there is trauma of vagina, a full trauma, what do you do? Will you suture and continue the operation?
I would
will you stop?
stitch the trauma, but would not place a mesh, and then probably would go in this patient to suture a resection rectopexy. Later on, if she still needs it, you still can do a mesh later on, but would not position a mesh when you have a breach, neither towards the rectum, certainly not, but also towards the vagina, not. Because you will find out later on that they develop an erosion to the vagina, nearly always.
Скажите, пожалуйста, а как-то сейчас, какую сетку вы выбираете?
What mesh do you choose in your practice?
We still use the polypropylene mesh from the early days. And I guess most of the meshes, if you don't use polyester, it's not a problem. It's all the same. But the mesh should remain flat into the rectovaginal septum, that you don't get any kinking, that there are no rough edges that shear against the vagina. That's important.
Еще добавлю по
I want to add that the patient was operated in the first days of March this year. And one of the advantages of our watching the operation not only in real time but also later is that we already have the follow-up and we already know the result. Andrea, how far do we need to, how low do we need to go? What's the limiting point?
So, of course, you should never go intersphincterically, but whenever you see the pelvic floor at the side walls, for sure you're deep enough. And then normally we let it depend a little bit from the indication. If you want to restore a rectostele, then you have to go very deep. If it only is like a kind of total rectal prolapse, then you don't need to really go until the pelvic floor, because it's at the level of the intussusception that you need to block it from the intussusception. And so that's the upper part of your dissection.
Вы всегда оголяете элеваторы?
Do you always get naked to the elevators in mobilization, or is it not required?
It's not always required. We don't see them always. It depends. It's really case dependent. But if you can reach them easily, then it's okay. Yeah. But we don't suture to the levator. We suture to the rectum or to the lateral aspects of the rectum, but not to the levator. We are afraid that if you suture the levator, that is going to tear out when they strain. But that's first.
Скажите, вот вы сами заговорили о функциональных
You have
результатах.
mentioned functional results, and you have already managed to do the follow-up and see the results in this patient. At the beginning, you said that the main clinical manifestation was pain. Did pain disappear? Did it go away? And what do you think of what Andrea said, that patients with pain, so he would do retropexy carefully in patients with pain? Thank you for the question. I think that if she didn't have such clear external prolapse with multi-layer, so prolapse of quite a big cylinder, if there was rectocele and pain, then we wouldn't have we wouldn't have proposed that operation to her. It would have been harmful and would have led to a very long history with that patient. She would have had continuous problems. And so, is she still in pain? I can say that when I saw her for the first time, it was a patient with a very pronounced psychosomatic. Yes, you said it in a very delicate way. We understood that she wasn't an easy patient to deal with. So, is she still in pain? In August, she returned for examination, and it was a tall, a beautiful, not stooping like before, a woman wearing high heels. I didn't even recognize her. So I guess that she is doing fine. And we examined her and we sent her to your center for a defecography. And it works very smoothly in your center. And we didn't do anything with ulcers. We didn't even administer any, nothing. So symptoms disappeared, blood discharged went away, and mucosa was regenerated. Unfortunately, not all patients, especially when we don't operate for prolapse, but for rectocele or obstructive defecation, ODS, it's not always as effective for these patients. Many have problems in rectocele and ODS, and they still their problems still continue. As for external prolapse, then this operation leads to quick and very reliable effects. We like it. And so you assess this functional result as good, right? She doesn't have incontinence. Well, when she answers questions, she didn't do the VAS questionnaire. I didn't see that data anyways. But as for her impressions, she became a different person after the surgery. This is the main thing. This is the main assessment. It means that the goal was reached. If we look at functional results more carefully than objectively, I think that, yes, we can get some good findings. We are now checking the depth of mobilization. As I see, this is the middle third of the vagina. It's about 1 centimeter. From vagina vestibulum, from vagina atrium, and usually deep mobilization is not really required. And maybe we don't see all the details that the robot sees with 3D images, where we can see all the veins and sphincter complex. We use quite a simple method to determine the width of the mesh. We just apply a ruler and cut out the needed fragment. Andrea, how do you define the transplant? Patients are different. They have different width of the intestines. Is it a standard one? Do you cut off just a standard mesh, or do you?
We use a standard mesh, but then we adapt the form of the mesh according to what we need. So you measure a little bit the width that you can cover the rectovaginal septum. Then when you need to hook on the middle compartment, we make 2 like extensions, like ailerons. And then it all depends, the length, the width. You can just adapt it to the need and where you, and the reason for the operation. Yeah. I think the main advantage of having a robot to do that is for the mesh fixation. So to avoid all those difficulties, we now use the glue. And I hope within time we're going to show that the glue is as effective as suturing, but that makes time sparing. But of course, if you have a robot, the suturing is facilitated by the robot, especially in the deepest part. Of course, there it can be very hard with laparoscopically, not to the left, but to the right, because you're blocked by the bony configuration of the pelvis.
Мы используем при лапароскопических операциях на самых сложных, глубоких.
In laparoscopic operations, in the most difficult, deep, such as we used extracorporeal tying of the node and sticks, which accelerates and solves problems related to space. We do the first such as extracorporally and then intracorporally.
Here, what we would do is to incise, to split the Douglas, so that you clearly can see that the mesh goes directly there, because now you placate it to the back, but then you need to take rectum, Douglas, mesh. But as you do it here, it's okay. It's perfect.
Интересно, что гинекологи, когда делают очень схожую процедуру,
Gynecologists, when they do a very similar procedure, they fix the same transplant, but they fix it to elevators, and they're afraid to fix it to the rectum when they do the back part of the mesh. And our situation is reverse, actually. Yes, we are afraid to damage the vagina.
Андрей, как вы считаете, вот этот вариант операции, это часть...
Andrea, this operation, is it part of what gynecologists do, or is it the same operation that gynecologists do, or is it different?
It's quite different, because what they do with their colpopexy, they denude the vaginal dome. They also dissect within the septum between the vagina and the bladder. And they never go that deep into the rectovaginal septum. And I guess it's a little bit different. Yeah, it's different. It's different.
Мы используем в данной ситуации.
In this case, we used on margins of the mesh, such as we try not to get the wall of the intestine, and we use a proline such as in the intestine itself. Andrea, do you think the choice of materials plays, what's the optimal choice of materials here?
Today we start to use slow resorbing monofilament. You're a little bit afraid of multifilament and non-resorbable, like Hetibond or something, because then if you go through and through, you can get a thread sinus or a chronic infection on the thread. But this is perfect because if you go in lateral, you should know that the rectal wall there, especially in rectal prolapse patients, is rather thick. So the chance that you go through and through is very limited, yeah. And I think it's important, as you show here, that the mesh remains flat, and that's the most important part, I guess, to avoid on the long run erosions.
А какой вариант фиксации, вот вы думаете, оптимальный к промонториуму?
What fixation would be optimal to a promontory, a staple or sutures?
I guess there, of course, you should use non-resorbable, and then you can opt by stitching. And today we use some small screws that go in, and it works very well. It works better than the previous tackers or the previous hernia staplers because it didn't have a good grasp there. So in those times, we first tacked it and then put another stitch. Today, we are confident in those small screws because there also is like a kind of protection that keeps the mesh there. And with 3 or 4 screws, it's done. Yeah.
Мы использовали протак степлер, герния-степлер, но, откровенно говоря, не очень понравилось, не выглядело надежно. Поэтому шьем, не раз швом, бондом к промонториуму. Если вдруг произойдет повреждение прямой кишки, Андре, вы сетку не располагаете, да? То есть операция закончится просто ушиванием или какой-то другой вариант?
I haven't got any translation.
Right, Andre, and when do you...
Right. Yes?
If it happens, the rectal injury during the surgery, what do you do? You suture, place mesh, not place mesh?
If you have a rectal injury, we gonna suture it immediately in 1 or 2 layers, and we gonna don't put a mesh. We will not go for suture rectopexy or something. We're gonna leave it like that. Explain to the patient that we wait 3 months and then do it again. But it's seldom. It's extremely seldom, and that's probably in those cases that it occurs is in patients with endometriosis. Because in those patients, you cannot glide along the rectal coat because they got inflammation due to those small spots of endometriosis there. Very easy to go into the muscular layer and then to have a breach.
Андре, пользуясь моментом, что вы с нами.
Andre, using this opportunity, I'd like to ask you another question. If there is rectal prolapse and slow transit on the colon, will it influence your tactics somehow?
So that's a very good question. First of all, it's rather seldom that you have slow transit together with total rectal prolapse. So the most of them got obstructed defecation. You can have that forms of obstructed defecation that it slows down the complete transit. So offering those patients only sigmoid resection is not a solution. So normally what we do is we make it staged. So we first fix the rectal prolapse and do a ventral mesh rectopexy. We wait for 6 months. Again, treat them conservatively. Again, do transit times. If you then have still a slow, then we could do a subtotal colectomy on top of it if they have normal sphincters. Because that's one of the problems with those patients with total rectal prolapse, that they have not that dense sphincters anymore, and you can drop into from slow transit constipation towards incontinence. So it's a difficult problem.
Какого пациента вот вы возьмете
на... What patient will you take for colectomy? What should be the evidence of slow transit to operate on such patients and do colectomy?
So at least we should have a normal sphincter function. We should have a patient that can avoid the rectum after the rectopexy, and we should have twice a very prolonged colon transit time. We use some markers, and you should have at least 2.5 to 3 times the normal transit time, and twice. So we do a double control prior that we propose surgery in those patients, and it always in consultation with a functional gastroenterologist. Never the surgeon alone that take that decision, because very difficult patients.
And what tactics do you use for patients with slow transit? We know such patients. They really want to have their colon removed.
We sometimes start with an ileostomy prior to give them a totocolectomy. Yeah.
Well, actually, it is stated in American guidelines that it's possible to do ileostomy. This is a functional treatment to assess whether colectomy will help such patients or not, because we know that we can do colectomy with ileal anastomosis or ascending rectal anastomosis, and this patient will not develop recurrent constipation. So American clinical guidelines state that there is an option when it's possible to discuss these tactics with the patient. I do not really like it. I think that it's not human-friendly, actually. We have accumulated experience, about 100 patients that have had colectomy due to slow transit constipations. Our opinions have changed a lot. At first, we conducted these surgeries quite frequently, about 10, 12 surgeries per year due to slow transit constipations. After that, when we realized that these category of patients are difficult to diagnose, because it's necessary to state that their clinical symptoms stem from slow transit rather than other impairments, because if the patient has slow transit constipation and other impairments, then functional results will be bad. So we should work with such patients really thoroughly. After that, during some time, we realized that we're afraid of discrediting functional results in such patients, so we rejected these surgeries. Now, we are trying to stay safe. We select these patients very thoroughly, and we see indications if the colon is longer. It is related to sigmoid colon fixture, and in that case, we examine such patients. We see changed transit in such patients, and in that case, we do colectomy with ileorectal anastomosis or endorectal anastomosis, but actually there are very few patients. We are trying to treat them conservatively. Thank you for your answer. So the mesh was fixed to promontorium. Additional suture is used as well. This is quite an important stage of the surgery that makes us quite concerned about it. And what about your coloproctology center? How frequently do you conduct rectopexy in this form, or you use other methods in your institution? And what's your opinion about this surgery? Sergey, the question is for you. Now, we have a thesis study conducted by Mr. Birukov. He is trying to assess the efficiency of rectosacrovaginal pexy with a mesh. He's accumulating experience, and Andrei Dor in his lecture said that this is a very complicated problem that has a lot of pathogenetical mechanisms, and we're trying to understand the place of this surgery in rectal prolapse and where we need to conduct the surgery from perineal side, where we need resection and where we need to use fixation. So now we're accumulating quite a lot of experience, and I hope that very soon this thesis will be defended. and it will assess long-term results as well. Because actually it was noted that functional results during the next year for such patients are good, but unfortunately, after that, they can be discredited. So it's so important to accumulate experience and monitor such patients. So once again, I want to say that we conduct such surgeries quite frequently. There are a lot of such patients, and we need to clearly understand who needs what kind of surgery in patients with rectal prolapse, because it's impossible to conduct one surgery for a patient with a disease that is polyetiological and that has various pathogenesis mechanisms related to it.
Сейчас выполняется закрытие дефекта брюшины нитью вилок.
So the defect of peritoneum is being closed. This is the lock thread, our sponsor. So we can thank them for having invented these threads. They facilitate our work. Andrei, well, I don't know how to ask this question. Well, 1 year ago, accidentally in China, I met Professor Long, and actually his opinion is very different. He states that it doesn't work, that, well, we know what surgery is preferred by Professor Long. What do you think about long surgery in patients with prolapse, internal prolapse?
The problem with STAR and TransSTAR procedures is that indeed you can treat internal prolapse, indeed you can treat rectoceles, but the functional outcome is not predictable, and you will end up with not a lot, but to some patients with non-treatable urge, and it doesn't go away in all patients. And so that's the reason we want to avoid this. And of course, you could use it in the patients who has a functional megarectum, because by using a STAR, TransSTAR, we reduce the capacity. But most of the patients do not have a megarectum. Most of them also have insufficient sphincters. So if you then reduce the rectal capacity, you're gonna end up with urge and urge incontinence. So although it's an easy way to treat it from the inside, today it's a little bit abandoned. It's the same operation like doing endoanal Delorme's. You can do that also. You can do the Brazilian TREMS procedure, which is all a kind of the same, doing resection or plication of the rectum from the inside. But again, I like the idea to look to the long-term functional outcomes and to have like a more tailored approach. And I guess that's the way to go. LAPFIER is not a fix for every patient, like the Longo operation is not a fix for everyone. And maybe we should try to find out what are the subgroups that indeed you can use one or another type of surgery.
So as I can see, you are not dissecting the extra part of peritoneum, of pelvic peritoneum. Yes, this is plication. And we can go further to collect this peritoneum. When we dissect it, stretching can occur, and sometimes we can see the thread. So we're a bit late, so probably we can finish it now. Probably I should give the floor to our next speaker. Well, probably yes, because we're late, but you have commented everything. We answered all questions. So probably we have some questions on the chart, but I cannot see it right now. So I do not see any questions on the chart right now. So let's move forward. Thanks a lot, Andrea.
Thank you.
We were very glad to see you. Thank you for your comments. They were very valuable for us. So it's a rare opportunity for our spectators to see this legendary surgeon and listen to his comments regarding this interesting and complicated issue. So actually, we were lagging behind, 20 minutes behind. Now we're 5 minutes behind. And I'd like to give the floor to our next speaker. Hello, everyone. Now I will switch on screen demonstration. Artyom Leonidovich, this was beautiful technique. I really liked the way you used the robot. It looked great, and I hope that very soon we will also have this kind of toy, and we will also start demonstrating our technique. You know, my task is so difficult. I have limited time, and I should tell you about the opportunities of laparoscopic technology in ulcerative colitis and Crohn's disease. And I decided to speak about some practical aspects. I will have some theory as well, but here we have very serious experts, and I think that even young surgeons know that laparoscopic technologies are good, especially in case of ulcerative bowel diseases. We will start with ulcerative colitis. Of course, we are aware of these facts. Laparoscopic technologies are associated with fewer complications and durability of hospitalization and cosmetic effects. It's clear. But what else is important for us? When we speak about ulcerative colitis, in most cases, these patients are young, workable, and they are really motivated to live without stomas. And we can actually fulfill all the stages laparoscopically. Although there are some urgent situations such as peritonitis and perforation, in that case, open surgeries will be our priority. But all the stages can be done laparoscopically without total mesorectal excision. And what is interesting here, we still have a myth that laparoscopic surgeries for patients with comorbidities, with metabolic impairments, with severe form of ulcerative colitis are not good, but actually it's not true. And there are a lot of works that confirm it. I would like to speak about several of them. So this is an early publication of 2009. Here there were 7 articles with laparoscopic colectomy in severely ill patients with ulcerative colitis. Mortality was very low. Complications were quite variable, from 16 to 37%, and the surgery was quite long. Still, we should mention that the group of patients in this work was quite heterogeneous, and they were not always compared with the open surgery group. So it's very difficult to speak about the advantages, but once again, I would like to emphasize low mortality and morbidity. Now let's look at later publication from the USA. A lot of patients. This is a register. 342 patients were operated on laparoscopically, 112 colectomies, and it's interesting that laparoscopic surgeries were associated with fewer complications compared with open approach. And of course, it inspired many surgeons to use laparoscopic methods on a wider scale. Another article of 2017, this is a serious center, and at once they spoke about disadvantages. Surgeries took longer, an hour long on the average, and of course this group was very heterogeneous. Open surgeries were more frequently used on men with comorbidities. However, we should also emphasize the advantages: fewer complications and less hospital stay. I would like to speak about mortality once again. So on the whole, these patients were very difficult, and most frequently patients die in post-op period due to the indications for the surgery that were established quite late due to their severe state. And this is a huge register with a lot of patients. And I want to mention that on the whole, this mortality was similar for the open and laparoscopic group. And in this register, we see very representative material. So what are the problems? The main problem when we decide to use laparoscopic methods for treating patients with ulcerative colitis is the fear. So when we see this exhausted patient with albumin, that is 19, with anemia, of course we have a feeling that I will just open his stomach and remove the colon. I will do it fast. Well, actually, of course, the surgery lasts longer, but it's only 25-45 minutes long, and actually it's not much. Speaking about contemporary anesthesiology and reanimatology, this will not actually influence post-op period. Besides, we have very clear data that on the whole, post-op complications are not higher after laparoscopic interventions. Moreover, mortality is comparable, and another important point is fertility. This is really important because quite frequently we have young girls that, of course, want to have babies later. They want to be able to get pregnant, and open surgeries in most cases actually make them infertile, and natural fertilization is not possible for them. Of course, IVF will be possible after that, but this can be quite difficult, especially taking into account some financial problems in our country. Now I'd like to move on to the practical part, how we do colectomy. This is a difficult patient with ulcerative colitis. And here an important point is not to do total mesocolon excision because there is no need in it. We're trying to go very close to the colon. We preserve all the nervous plexus at the bases of major vessels. And almost always we start the surgery from the left colon, and we're trying to have this window right after sigmoid colon. And through this window we can see the posterior wall of the colon, and we can go down to the level we need. Almost always this is the level of promontorium where part of the colon is crossed, and after that the surgery is continued in the proximal direction. So this stage is quite simple, almost no bleeding, although sometimes there can be serious problems related to significant perifocal inflammation in the colon mesentery. And sometimes we even have to do conversion. And we continue the surgery as an open procedure. This is a classical situation. We achieved sigmoid colon, we crossed the rectum at the level of promontorium, and after that we mobilize the mesentery just to make it more mobile, and resection is done close to the wall. So you can see the way the mesentery is crossed very close to the wall. So we can preserve all neural plexus, all neural endings. We minimize the problems related to sexual and urinary function, and this colectomy is continued proximally. Here the amentum will be removed. I know that frequently we argue about this amentum, many surgeons leave it. We do not have actually any evidence base in this regard, and my subjective opinion is that it can actually result in further problems on the second stage. So routinely I remove the amentum. It's more convenient for me, and actually literature data does not show that it is bad. So there is no evidence base now, and that's why we conduct this resection of greater amentum. We connect the left flexure and continue resection. the transverse colon. This is the left flexure, minimum bleeding. Everything is done as planned, and actually the duration of surgery is comparable with the open procedure. Another video, this is colectomy as well. And here I'd like to point out that perifocal processes can be very significant. So this is right colon, this is sigmoid colon, and we can see significant inflammatory changes in the right colon. So here there is adhesion to parietal peritoneum. It means that the organism tried to cope with this inflammatory process. So it covered this place with the peritoneum. For us, this is not an argument for conversion. Of course, if the intestinal lumen would have been opened, we would have to converse to the open procedure, but still, here we managed to do it, and you can see that very light traction on mesentery results in this bleeding. But still, we followed our normal method, so we did not reach major vessels, but trying to get into the space below the colon. We managed to do it as well without any problems. So once again, we are reaching the posterior wall of the rectum. It is crossed by the cutting device. The place of crossing is selected beforehand, and of course we are guided by sigmoscopy that is done before the intervention. So we understand where most changes are. Speaking about the distal part of sigmoid colon and rectum. And we use the assistance of our endoscopists if needed. We ask them to come to the OR and select the resection place together with them, but normally we do not need it. We can reach the level of promontorium and cross rectum. On the whole, after that, resection follows a standard plan. So many experts say that our surgeries should be absolutely similar. And here we can see that the resection is continued under the intestine until the left flexure. After that, we resect greater omentum. So we resect greater omentum and we move to ileocholic artery and vein. And I'd like to point out that this is the only aspect when we cross ileocholic artery and vein at the place of their origin, because we want to give mobility to small intestine mobility so that the second stage with reservoir formation would be easier. We do not spend time on the second stage to cross ileocholic artery and vein. That sometimes can result in stretching of small intestine mesentery, and it does not allow us to descend small intestinal reservoir into the small pelvic. So we do it at the stage of colectomy. And at this stage, we also mobilize small intestine mesentery till duodenum, and as a result, one stem ileostoma is prepared. The second stage, proctectomy. There are some details here as well. And all the proctectomies are done laparoscopically. It's very important. We're trying to preserve mesorectal tissue. This is closed rectal dissection, or bad TME, as it is referred by our colleagues. So we're trying to preserve mesorectal tissue in this patient. So we decrease the risk of complications in early post-op period regarding anastomotic leakage, and actually there is evidence base that supports it. Of course, there are no randomized trials yet, but still, we have a feeling that in these patients, we see actually better state in case of anastomotic leakage. This is rectal wall, remnants of mesorectal tissue on the rectum. We're trying to go very close to the rectum, just as close as possible to preserve all mesorectal tissue. We do not always succeed to do it, especially in young people with narrow pelvis, because if we preserve all mesorectal tissue, when we go to low ampular department, the space is very narrow and it's very difficult to visualize it even laparoscopically. So sometimes we have to do conversion and remove mesorectal tissue. So this technique is not as simple as it seems. It's a bit easier to do it on women, but in men, it's not always easy. But in this case, we managed to do it. We completely preserved mesorectal tissue and we crossed rectum. So now we will check it from the side of the rectum. And the rectum will be crossed. 2 cassettes were used here. After it, we will descend the small intestine reservoir and we will form reservoir rectal anastomosis. I'm trying to speed up because I know that we're late. Another video that I wanted to demonstrate is quite short. This is our interesting experience where we conducted laparoscopic colectomy on a pregnant woman. Actually, we have experience of colectomy on 4 pregnant women. But in one case, we managed to do it laparoscopically. So this is uterus with a baby. And we managed to fulfill this surgery laparoscopically. The pregnancy was 16 weeks long. At the moment of intervention, it was quite difficult to work in the small pelvis because uterus was hanging over the rectum. It was difficult for us to mobilize it, but we tried to follow this technique. So we tried to go as close to the part of the rectum as possible. And this resection was difficult for us, but we managed to do it. Of course, we were worried about this patient. It was quite actually scary for us to hold the uterus with rectum, but we managed to do it with classical colectomy. And I can speed up now because all the remaining procedures will be similar to the previous videos. So these are the results. Operative time, 135 minutes. It's comparable with open procedure. Minimum blood loss. Post-op bed days, 7. Everything was fine. This patient delivered a healthy baby, and after that, laparoscopic procedure was done and stoma was closed. Everything is fine now. Now I'd like to move on and speak about Crohn's disease. I will try to be concise, speaking about laparoscopic surgeries, and actually here I would like to speak about difficult patients with infiltrates in peritoneum. Is it reasonable? Yes, it is. So there are 2 works that I would like to comment on. One work of 2015, this is Chinese work that analyzed laparoscopic and open surgeries. If we look at the patients that were included into this group, we will see that these are all patients with various intestinal fistulas and infiltrates, and these are the results. Post-op complications were significantly lower in laparoscopic group, and post-op bed days were also fewer in this group. A very interesting analysis regarding mortality rate. In the open group, there were 4 patients that died, and actually, I have gone for a long time. I haven't seen patients with Crohn's disease that died, but these are the data. This is Chinese article, so prices are in Senbai here. And the economic efficiency is very serious here. In other large meta-analysis, more than 1,000 of patients with Crohn's disease, 2 laparoscopic groups were compared: laparoscopic surgery for common patients without complications, and laparoscopic surgery for patients that had some complications, that had interintestinal fistulas. 13 procedures, no difference in terms of post-op complications. The duration of surgery was longer in the group of patients with some complications. That was quite logical, but actually this works was quite heterogeneous, and the operation lasted only 17 minutes longer. That's not significant. Post-op bed days. They are more numerous in patients with complications, but only by 0.8 days. So, on the whole, laparoscopic interventions for these difficult patients are quite reasonable. And this is the proof. This is a brief video. Our patient with complicated Crohn's disease, infiltrate in the right iliac section, terminal part of right iliac colon. We can see mesentery, we can see fistula between a loop of ileum and part of infiltrate that actually is termed into ileocecal zone. First of all, we opened this fistula to understand the anatomy of this infiltrate. This is not an oncological patient, so almost always we try to laparoscopically divide different organs that were involved in the infiltrate, because in case of infiltrates and Crohn's disease, it can be quite difficult. This is entry into the pelvis, and the ileum as adhesion with the intestine, and this is abscess. It was opened actually several years ago. We would have converted, but in this case we decided not to do it. We took this swab for microbiological analysis. We treated this area of abscess with betadine napkin, and we decided to continue laparoscopic intervention. Of course, I'd like to point out that the infiltrate was quite stony, and after that we saw involvement of sigmoid intestine, mesentery of the sigmoid intestine. There was a fistula, and here it is. And we are trying to approach it from different sides. We are returning to the lateral part. Once again, we are trying to avoid infiltrate from the pelvic walls, from parietal peritoneum, from peritoneum of the pelvis. And on the whole, we are managing to do it, but at some point we understood that the terminal part of ileum was separated already, and we are in the infiltrated mesentery of sigmoid colon. So we are actually ascending this part of sigmoid colon. We saw the fistula between sigmoid and small intestine, and we decided to divide this fistula, but we realized how much we can mobilize the distal part of sigmoid intestine laparoscopically. So the fistula was opened. These are significant scary changes, and we managed to do it after mobilization of the infiltrate. So this fistula is divided, and we realized that mobilizing this stony infiltrate in the distal part of the sigmoid intestine would be quite difficult, and here we decided to stop. Well, it was not actually a conversion. We used mini laparotomy approach to the lower part of the stomach. And this is revision with open approach. This is terminal part of ileum, and we can see that the mesentery covered it completely. This is complete stricture. And proximally there was another part of narrowing. And in about 5 centimeters, this is the place of the fistula that we divided. And we decided to resect this part of sigmoid intestine because infiltrative changes in the mesentery were so significant that it was not possible to understand whether there is communication with sigmoid intestine or not. So we resected it. And I'd like to mention that laparoscopically, before opening it, we mobilized the left part, we mobilized the flexure because we realized that probably we would have to do resection. And to avoid stretching, we did laparoscopic mobilization of the left part in advance, and we resected sigmoid intestine. This is the infiltrate that involved major vessels and superior rectal artery, but we did not go there. We actually went closer to the rectum and we managed to do resection. We formed sigmorectal anastomosis, and due to the abscess in peritoneum that was opened, we finished this surgery with ileal and ascendostoma, and on day 6 this patient was discharged on normal post-op period without any problems. So, what are the results of my talk? Of course, laparoscopy is our priority. If it's possible, we should do laparoscopy. Colectomy should be done with preserving all mesocolon. If possible, we should not reach major vessels. Proctectomy without total mesorectal excision, and infiltrate is not a counterindication for laparoscopic approach. That's it. I don't know whether I was in time or not. Actually, I did not monitor the time. Thanks a lot. I think that you're quite late, and we're late as well.
So if you don't mind, we will move on. By the way, they use yuans in China, not yens, you know? Okay, sorry, my mistake. Thank you very much. A very difficult topic, and it's true that there are no studies which have a lot of evidence, and you have accumulated a lot of experience, and we believe you. And now I want to give the floor to Alexei Moskalev, and he will speak about factors defining effect of elective surgery in diverticular disease. The floor is yours. Good afternoon, dear colleagues. Now we can see your presentation. Why did I choose this topic? Recently, we have been having quite a paradoxical situation in surgery of diverticular disease. There has been narrowing of the field of indications for elective surgeries in diverticular disease, and at the same time, the number of surgeries that are carried out for diverticular disease has increased 4- or 5-fold in the last years. Narrowing of the field of indications happened due to new epidemiological data. 20 years ago, we thought that the main indication was prevention of surgeries, because there is a very high risk of recurrence in patients who have had acute diverticulitis, more than 30%, and each further attack increases the risk of non-elective urgent surgery, and the concept was taken that there is a need when there are no counterindications to carry out the surgery after the first attack in the risk group. So to perform this operation for prevention. And the risk of, what do we have in 2020? The risk of a recurrent attack is low, 10 to 15%. Risk of development of life-threatening complications is less than 4%, and each further attack means a lower risk of urgent operation. Also, new schemes of anti-recurrence therapy are implemented, which broadens opportunities of conservative therapy, and decreases drastically the number of surgeries. On the other hand, the number of surgeries is going up, first of all, because our laparoscopic approach has been getting more and more popular, because these surgeries are considered to be really good. If you do this surgery for prevention, then it's not that long. Frequency of conversions is quite low, less than 10%. But mind that so this is true for patients who have had elective resection, which means that a patient has had one attack of acute diverticulitis at quite a young age. Median age is 58 years, while median age of patients having common surgery is 70 years or more, and normal body mass index commitment of surgeons to laparoscopic surgery has made us change our attitude totally to diverticular disease operations. And taking into account all advantages of a laparoscopic approach, such surgeries can be performed more often. What is important here? Results of laparoscopic surgeries are the following. There are twice as few complications and 3 times as good functional results, which was shown by meta-analysis. If we don't look at it, if we don't analyze it in groups of patients specially selected for that, then we will see the full picture. And it has become clear that by and large, surgeries for diverticular disease have early post-op indications twofold, and in some groups in elective surgeries the frequency is 40% in regards to small complications, but still small pluralous complications sometimes reach 40%. As for remote results, it's not that easy either. According to different data, 1 patient in 4 has pain after the operation. And more than half of them say that they are feeling as if no surgery has been carried out, and some of them even require documents related to their surgery. There are also data that up to 20.5%, in 20.5% cases, there is a risk of diverticulitis recurrence after such a prevention surgery in some groups of patients, especially in that where the distal third of the sigmoid was preserved. Another problem is hernias. They appear 3 times more frequently than in surgeries for non-complicated colorectal cancer. And this is clear because the frequency of purulent complications is 4 times as big, which leads to such results, and also systemic weakness of the connective tissue that we see in diverticular disease. Let's look at the results of DIRECT trial, which was completed 4 years ago, and remote results of it have been now analyzed. This study was carried out in Holland, in a country with a very high surgical culture, and they got very curious results. 15% of failure of anastomosis. When I started to analyze diverticular disease, it was 18%. So from the viewpoint of complications in regards to anastomosis is dangerous. 21% needed repeat operation, and 17%, not 10, not 12, but 17% of cases, and even more, they had a post-op hernia 1 year after the intervention. Still, this intervention drastically increases the quality of life for such patients after elective operation. Abdominal pain is 3 times less frequent, and recurrence is much smaller as well. We're speaking about acute diverticulitis. What are the main aims of elective operation? We need to understand that the first task we're setting is elimination of the inflammation process lesion center. And then we count on improving of quality of life and so on. But for a patient, it's the other way around. Number one for them is increase of quality of life, not having to take medication anymore, no limitations regarding travels abroad. Gastroenterologists and other specialists there, they have some fears in this respect. So focuses are different there. By and large, there are 3 aspects that allow us to reach good results. Number one is correct determination of indications for the operation. For me, it's number one, because a surgery that has not been carried out by indications will only worsen the functional results and can increase pain, even when there are no complications. Number two is definition of optimal volume of intestine resection and prevention of early and late complications. In more detailed analysis of all unfavorable adverse outcomes, I would put exclusion of irritated intestine syndrome as number one. Only when we are sure that chronic inflammation, constant inflammation is the reason for the clinical picture in the patient, only in this case do we have the right to forecast a good result. If it's not there, then to tell the truth, to prove to the patient or to your colleagues that you are that brave and just be guided by your intuition, I don't think that this is the correct thing to do. And I'd like to say that symptoms of manifestations of inflammatory focal area should be identified and documented. Sometimes we can guide ourselves by clinical picture, but here there must be much more information, and history of the patient must be documented and their inflammatory attacks. Risks of surgery and post-op complications should also be identified, because again, the risk is quite high here. We divide indications for elective surgery into 2 groups. Number one is non-efficiency of conservative therapy that we have in chronic diverticulitis and chronic paraintestinal infiltrate. And there we need always help of our colleagues, gastroenterologists, who manage the patient. And number one is no rationale for conservative therapy. Fistulas usually do not close spontaneously, and in strictures, we know that chronic process leads to obstruction problems. According to our data, frequency of recurrences, even if there is conservative therapy, is 17%, and we have identified that in the group with symptoms of diverticular destruction, it's higher, it's 3.5 higher, 3 times higher. What are these symptoms of destruction? When a patient comes to you and with a question whether they need elective surgery, you need to ask them for documents regarding computer tomography that was done when there was an attack. This is the most informative study from the viewpoint of forecast. those who are supporters of ultrasound, I can tell them that for me, this is something which makes me sure. I'm speaking about CT. We can use more difficult, more complex measures. For example, this is one of the signs, indirect signs of destruction of diverticulum. It's change of shape. In ultrasound study, we can identify signs of destruction of diverticulum because we see a fistula which does not still manifest itself. And long-term, more than a month, discharge of purulent matter from diverticulum. But for that, you need to do 2 colonoscopies a month for this patient. The remaining 3 symptoms are indirect. And the main sign is destruction of diverticulum. And we can see the phase of flare or acute attack of diverticulitis. The next part, after we have determined what we were to determine, is specificity of elective surgeries in diverticular disease. Some surgeons think that this intervention can be done just like in colorectal cancer, and it does not lead to any problems. But we need to understand that there are different purposes there. Patients are in different life situations, and here the purpose is to improve quality of life, and the functional result from the viewpoint of the patient is number 1. The main element of this intervention is necessity to avoid bandage of superior mesentery arteries. There has been one study, more than 100 patients were involved in the study, and it was stated that such intervention improves drastically the functional result. First of all, in what concerns abdominal pain. Abdominal pain is almost 3 times smaller when there is no ligation of inferior mesentery artery. Defecation disorders, constipations, not regular bowel movement, and so on. And this concept was not accepted by all of the people, even though the evidence was the level of evidence was quite high, but usually it was not accepted by general surgeons. Recurrence after elective operation, I want to remind you that it is 4 times as big when anastomosis from the distal third of sigmoid colon is done. And I would now like to get to the section which is about resection margins. 20 years ago, we accepted a very clear algorithm which allowed us to create an overall paradigm approaches in elective surgeries. I want to stress it, elective ones, not urgent ones, because in urgent surgeries, there are totally different approaches and we have different tasks there. First of all, saving life. Here we determine resection margins from the viewpoint of diverticulum disease treatment and not its complications. First of all, we need to assess character of inflammation changes. The whole intestine, which is involved in inflammation, should be resected. Then we need to assess lengths of segments with thickened and rigid intestine walls. And diverticulum should not get into the suture. The nature of inflammation can be easily determined both in open and laparoscopic surgeries. I will not dwell on that. As for specific changes in the intestinal wall, I won't tell you how it happens. Thickening, rigidity of the wall is not observed along the whole intestine, and maximal changes are in the area of inflamed diverticulum, and they get smaller in proximal and distal directions. Here you see resection margins there where the intestinal wall is elastic. How to do it in laparoscopic surgery where there are no tactile feelings? First of all is ultrasound, with which we can identify the thickness and the transit zone where we can cross the intestine. And this study can tell us whether there is a diverticulum there or not. It's seen very clearly during the intraoperational study. But after removal of the intestine, I would have doubts in what concerns forming intracorporal anastomosis, because the best way to avoid diverticulums, which may be hidden in mesentery, in other parts, is to open the lumen. So it's better to do it at the open stage of laparoscopic procedure. So you have opened it, you see the collar of diverticulum, and you can make some conclusions. Remote results, quite good. 1 patient in 5, irrespective of the volume of diverticulum disease, is still progressing. Number of diverticulums is getting bigger, their size is getting bigger, but still it's not the aim in itself. We give priority to clinical manifestations. And we have proved that in using this approach, when we choose the correct volume of minimal resection, we get the smallest number of complications and recurrence of diverticulum disease. And compared to open surgeries, the same picture, same advantages of diverticular disease. We haven't seen any changes in number of complications. As for remote results, we see a very clear difference. Negative assessment of the surgery. They say that the result has worsened or has given no effect only in 5% of cases, which is 4 times smaller than in open surgeries. And frequency of hernia forming was 5 times lower in laparoscopic interventions than in open ones. What I have been talking about, like correct determination of indications, correct determination of volume of intervention, prevention of complications, and I would also add laparoscopic approach. Elective surgery in diverticular disease complicated by chronic diverticulitis and chronic para-intestinal infiltrate, fistula, or stricture must be initially considered laparoscopic. In this case, we have more base to forecast favorable remote functional results of the surgery. Thank you for your attention. Alexei, thank you very much. Everything is very detailed and correct, as always. And I want to remind you that we are a little bit beyond the schedule. We started 10 minutes later, but now we are about 5 to 7 minutes out of the schedule. And Alexei, can you please stay, and we will listen to Artem Leonidovich, because he will continue the topic, diverticular disease. And I want to give him the floor straight away, and he will speak about robotic surgery in elective and urgent surgeries. And he only has 15 minutes for that. But I hope that Artem will cope with this difficult task.
Как вы за 15 минут смогли болезнь коронной язвенной колита рассказать и показать. Здесь у меня задача попроще.
So, thanks a lot. Actually, your example inspires me because you managed to speak about ulcerative colitis within 15 minutes, and my task is a bit easier. Thanks a lot. After the presentation of the previous speaker, many theoretical and practical questions had already been answered. And this is Surgery Festival, so I need to show some videos for our spectators, including students and fellows, to see what kind of surgery it is, because probably they will encounter such procedures in their work. Okay, thank you. I can see it now. Could you show my slides, please? On this slide, you can see the trial that actually shows the comparison of data between laparoscopic lavage and rectum resection. So, it was quite popular to say that there is no need in urgent surgery in case of diverticulum perforation in colectomy, and it was stated that only lavage and draining of peritoneum allows us to decrease the frequency of anastomosis. But one of the last trials has shown that in some cases this technology does work, but the probability of peritonitis rose 3 times, as well as the percentage of sepsis probability. So we should also consider colon resection in this pathology. Could you please show the next slide? These data is related to the sampling of the American Society of Surgeons regarding laparoscopic, robotic, and open technique in treating diverticulum disease. It is shown here that in 2013-2015, more than 40,000 sigmoidectomy were done. 61% were done laparoscopically, 28% in an open procedure, and 9% robotic sigmoidectomy. In this country, unfortunately, we do not have an opportunity to operate on patients with diverticulum disease because it is not included into standards, and it's not included in the quotes. So each time, these are commercial patients or patients who have specific permit for such surgery. And this is another trial, and we participated in it. This is Belgium, the Netherlands, and Italy. They compared Gottman surgery and formation of anastomosis in patients with peritonitis. This is diverticulum disease. They have shown that the advantage of primary anastomosis actually is there. It's better to do it before Gardner surgery. It's not quite usual for us, of course. We are used to obstructive resection in such cases, but still, these results are present, they are interesting, probably they should be implemented into wider practice. It's interesting that primary anastomosis almost in all cases was covered by ileostoma, and actually there is a contradiction with internal conceptions, that inter-abdominal anastomosis actually should not be protected by ileostoma, so in case of leakage will occur anyway. And moving on to the presentation, I'd like to show you several videos. Here you can see the surgery. This is laparoscopic surgery, quite large diverticulum infiltrate with abscess. and all patients received CT before the surgery. This is the main criterion for diagnostics of this disease. As Alexey Igorovich mentioned, we need to spare the mesentery of sigmoid colon as much as we can. We should not ligate inferior mesenteric artery at the aorta side. So here there are two concepts. On the one hand, mobilization within the planes is safer because you can visualize ureters earlier, but on the other hand, there are potential risks here. And we decided not to mobilize. So it's difficult actually to reject this mobilization at all, but still we normally preserve some stump of this artery, and if left colic artery is close to aorta, normally we mobilize it separately, and it allows us to preserve this nerve plexus, and it does not result in significant impairments. So the surgery continues. The infiltrate is divided. Most frequently, we mobilize and divide infiltrate with monopolar coagulator. Unlike oncosurgery, when we would have to resect this infiltrate with abdominal wall, here we can use electric suction device and continuous irrigation, and we can divide this infiltrate. So in this case, we are trying to prepare the ureter to mobilize and visualize it before the intervention on the infiltrate. We understand that abscess can open. It happens quite frequently. And in that case, we will not have much time for finishing the surgery. In this surgery, as it was also shown, we frequently use ligashou. We cross the intestine with endogeum. And in this case, stoma was formed, and reconstructive laparoscopic surgery was done within 3 to 4 months. Similar case. On CT, we can see diverticulum that was destroyed, and we can see abscess here. This is quite huge infiltrate. And as the previous video showed, here we entered the plane again, but after that we turned upwards to preserve the stump of inferior mesenteric artery, but we also wanted to return to the plane above the ureters and gonate vessels. And here you can see that we quite actively used ligashou.
Здесь, наверное, на этом видео сохранена левая ободочные сосуды.
So these are left colic vessels. We divided them, and after that, the infiltrate was mobilized. We've seen perforation on CT, and the clinical signs showed that most likely abscess will develop, so we actually decided to leave it till the last stage of surgery. We put napkins in the infiltrate zone, and after that, using monopolar coagulation, we divided this infiltrate. We used these cotton movements. Finally, the abscess opened. But it did not really stop us. This is not actually an indication for conversion. We removed the pus. We used napkin with betadine to treat this area, and after that we continued this surgery. So we finished mobilizing this infiltrate. Experience has shown that when these abscesses open during surgeries, in case of time destination and in case surgeries are not long, we do not see any repeated abscesses or any purulent septic complications in post-op period. We used Legashu from our sponsor company to cross the mesentery at the level of superior ampullar department. And after that, the specimen was crossed. When we were conducting our first surgeries, we used to remove the specimen through the incision for the stoma, but I think that this is not a good practice. Because as a result, the approach is quite extensive and hernia can be formed in the early time. That's why it's better to separate, to remove the specimen separately. And after that, or if you plan to have a stoma for this patient, it's better to form it separately.
И здесь операция, то, что вот Алексей Ильич говорил, ну, такая плановая, скажем так.
And as Alexei said, this is scheduled surgery due to diverticulosis, infiltrate, and stricture are present here. There is some obstruction in this patient. This surgery was done 2 years ago. We monitored the state of this patient. This patient frequently comes to us, and the patient is happy about the surgery and intestinal function. There are no neurological or sexual disorders. But more frequently we operate on oncological patients, so we enter these planes as usual, but we try to leave these terms. We try to go above them. So probably it is better to use synthesis in this situation. And actually, I was wondering about the experience of Armen. When these fragments remain in mesorectal tissue in pelvis, there will be no blood supply to these parts, and as a result, these parts of fat, do they result in drainage or in abscess, or this fat can actually stay there as is? Artyom Leonidovich, I want to say that almost always we conduct the surgery the way I showed it, and indeed there is this possibility of long-term drainage due to lymphorrhea in drainage system, and sometimes we actually see this active exudation during 1 week or 2 weeks. But regarding the inflammatory problems due to this fat in mesentery, we did not see them. You do not restore pelvic peritoneum in this case, and actually this fat is sucked from the side of peritoneum. Yes. So here we've seen some aspects of mobilization in case of left hemicolectomy with vessel preservation. This is quite typical. I think that we should follow the planes, not to injure the mesentery. Could you please switch on the video? And here you can see approach to reconstructive surgery. This is laparoscopic surgery after Gartman surgery. In this case, laparoscopic Gartman surgery was done. So there was a video with pus, at the first stage, and we see minimum number of adhesions in the pelvis. Inferior mesenteric vein was preserved. This is important for us to get into appropriate planes, to mobilize the intestine in the plane. That's why we do not take the inferior mesenteric vein. The intestine is dissected from the side of peritoneum. At first, we tried to mobilize it in the open way and suture it after that, but in that case, there is a lot of blood and liquid in the peritoneum, so it is more difficult to work. That's why we use one cassette. We dissect this intestine, and after that, we conduct mobilization. Almost in 100% of cases, this is mobilization of splenic flexure. We create window over the pancreas, and in this case, we also try to preserve more fat on pancreas on these zones to avoid complications. And our main goal is to get the transplantate and to get the graft, and we have to select the part of the intestine with significant diverticulums. So we prepared the bowel. It is significant. On pre-op stage, we also do CT, laparoscopy if needed. And here, we can see the stump in the form of a tube. So it's quite difficult to introduce the device there. We need to mobilize it to clear it from the scars from the mesorectum that covered it a bit. So it is cleaned. And this is the remaining of the previous surgery. And here we have a very even platform for the anastomosis, and we form rectal anastomosis. Protective stoma is not needed here. And after several leakages, we started suturing this anastomosis with several sutures to be on the safe side. So this is our humble experience. 220 patients were received by our hospital. They had diverticular disease. Most of them were treated conservatively. And we have our commercial ambulance. 130 patients were received by commercial ambulance. 50 patients needed surgery. 27 were resected. In 15 cases, reconstructions and other procedures were done. Resections were done with primary anastomosis in 59% of cases. Laparoscopic resections, 73% of cases, reconstruction, 53% of cases. Robotic surgeries were only 3. And these surgeries included colovaginal and coluterus fistulas. So, summarizing the results of my presentation, I can say that laparoscopy and minimally invasive technologies can be used for patients with diverticular disease, including patients with complications. The principles are a bit different from colorectal cancer. Thank you. Artem Leonidovich, thanks a lot. I've just learned that we will have a presentation of Professor Bilansky. It was pre-recorded and it will last 25 minutes. So I would like to ask at least one question that is so important for our practice. I would like to ask it of Alexey Igorevich and you. So elected surgery, after Godwin surgery, we do restoration anastomosis, probably with resection of part of colon, because this colon can have a lot of peristomal diverticulums and it should be removed. So what indications will you be guided by when you introduce preventive ileostoma after restoration anastomosis? And whom do you want to ask? You, first of all. Stoma is administered in cases we do not manage to fulfill one of three requirements in surgery. And first of all, if there is a probability that the verticulum will get into the suture. The second, when it is not reasonable to extend the section margin of the intestine. And mobilize left flexure to do the anastomosis between the sections where the intestinal wall is elastic. And thirdly, significant inflammatory changes in the stump itself, I mean the stump of the rectum. Of course, it can significantly increase the risk of leakage. If there is divergent colitis, whose probability is much higher in diverticular disease and mesorectum changes. So when the source of inflammation is preserved, but trying to remove the whole ampulla of the rectum is not reasonable, so anastomosis should be used to prevent complications. Artem, what's your opinion? Well, we try not to form stomas. So it's quite seldom when we have patients with infiltrate in the rectum. So most likely this is another disease or remaining suture material. We always try to make anastomosis on the healthiest parts. If the left part is not enough or the left part was changed, then it's possible to turn the right part. So in case of reconstructive surgeries, in diverticulosis, we use them. And over 3 years, we used such surgery for 3 or 4 patients. We used the right part because left part was not suitable for anastomosis. Either stomas are not administered in scheduled reconstruction. And actually there was no need in post-op elastoma due to anastomotic leakage in these patients. So the opinions are so different. This problem is really complicated and it hasn't been solved yet because, as I understand, the issue of elastoma is always the decision of a surgeon. And probably it's not even scientifically based when we speak about preventive elastomas, and most frequently it is done just to be on the safe side. But probably sometimes it plays a major role as well. But I propose to move further. We have 20 minutes left, and now we will listen to a recorded lecture of Igor Belyansky. He will speak about robotic interventions in peristomal hernias. It's a very interesting lecture for us to hear. Thank you.
Thank you very much. Please play it.
Hello, my name is Igor Belyansky from Annapolis, Maryland. I was asked to talk about peristomal hernias. I'll specifically talk about sugar baker repair and modified sugar baker repair and how we do it here in Annapolis. So when we talk about peristomal hernias, they are quite common in patients with stomas. Literature really depends, but I think a rule of thumb, if a patient has a permanent stoma, there's over 50% chance that at some point in their life they'll develop a hernia around the stoma. And peristomal hernias are technically difficult to repair. They do have a higher recurrence rate associated with them, as well as higher surgical site occurrence or wound complication rate associated with them. And there's a variety of other morbidity related to stoma complications, such as retraction and protrusion. I would have to say, honestly, after years of doing peristomal hernias, the best peristomal hernia repair, in my opinion, is trying not to repair a stoma, because there's always going to be, feel like, a little bit of something that those patients may not be completely fully happy about after the repair. How we fix those problems nowadays, and originally laparoscopically, but now more and more, at least my practice has been changing to robotic surgery, and I'm able to do more advanced procedures through small incisions, utilizing this as a tool. Again, robotomy is a tool. It allows me to better reproduce what I do through an open approach. And I can manage more complex and larger hernia defects through small incision now robotically as compared to what I used to do laparoscopically. Again, this is my opinion, and this is just what I'm telling you based on my experience in the past. So when talking about Sugarbaker repair, described by Paul Sugarbaker, who practices Washington, D.C., Dr. Sugarbaker described lateralization of the stoma and holding it with a patch. Thus, there are forces now that press the intestine ventrally and lateralize. And still a high recurrence rate quoted in literature, but can be up to 15% recurrence rate after Sugarbaker repair. So let's talk about doing a Sugarbaker repair. So this first case I'm going to show is a transabdominal approach to someone who actually previously had a midline incisional hernia as well as parastromal hernia. This was a keyhole type of repair in his mesh in the retromuscular space. And so we went back in here, and this is 2 ports here to establish space. And then there was some adhesions laparoscopically. We were able to develop take the adhesions down and place those 3 lateral ports here, so ports opposite the stoma. And then the video now is playing what happened inside during the surgery. The adhesions already taken down here. You see a parastromal defect here, not very large. You can close this either robotically, laparoscopically, depending how comfortable you are suturing laparoscopically. And then the next step is use of the 3/0 monofilament stitch to suture or lateralize the stoma laterally. So this way, this I think an important step I like to do prior to placing the mesh. And when you place a mesh in Sugarbaker repair, one of the things to consider is what happens, to mesh closely laying next to the valve long term. And in my opinion, again, if there's ever going to be any erosion, it's not going to happen on this surface, but it's going to happen right here at the intersection of a point where the intestine travels from abdominal space to the space between the mesh and abdominal wall, and the point of tension is going to be right here. So you have to really technically pay close attention to this. And I think suturing and lateralize the stoma prevents this kind of angulation and decreases the chances of mesh erosion. Again, this is a very technical part of this procedure that's just very hard to teach during the lecture. So here's the intestine, and what essentially you do, there's no keyholing here. You just suture the mesh, or you tack the mesh to the underside of the abdominal wall. So, and what I try to do is usually get at least a good 4 to 7 centimeters of coverage over of the area where the intestine and the mesh, the intestine travels between the mesh and abdominal wall interface. So what is modified Sugarbaker repair? We also refer to it as a Poli repair. Eric Poli is a surgeon out of Pennsylvania. Dr. Poli have described essentially combining a transversus abdominis release dissection with the principles of Sugarbaker repair. Again, the mesh is not come, and the cut in the stoma that is not moved, but what happens is actually the stoma is lateralized in a retromuscular space, and the mesh is placed to in the same space, in a tar space where the intestine will travel from lateral to medial, and in a retromuscular space traveling superficial to the mesh. And so what you do here, the first step of transverse abdominis release, this is a cadaver demonstration, is the weak stoma dissection or retrorectus dissection. Here is the rectus abdominis. This is stoma left lower quadrant. Again, this is a model. This is a cadaveric dissection. This is the posterior rectus sheath, and you can see the transverse abdominis muscle contributing to posterior rectus sheath. The next step is transversus abdominis release to get in the retromuscular space. So you have to do this release all the way around the stoma. And this is what it looks like afterwards. Again, here's the posterior layer. This is the posterior rectus sheath with contributions of the transverse abdominis muscle. This has been divided here all the way just medial to linea ulnaris, medial to neovascular bundles. And this layer here is the transverse abdominis fascia and, transversalis fascia and the peritoneum. So two layers here. So now you have this large space. And then what you do next is you actually incise the posterior layer. So you incise the posterior layer to move the insertion point of where the bowel conduit enters the retromuscular space. And then what happens is you just suture this toward yourself. And this is what it looks like. So now what you've done with this is you left the distal end of the stoma in the same place, but you move its insertion point into the retromuscular space. Thus, it's coming from lateral to medial, and essentially setting yourself up for a Sugar-Baker type of repair. And this is what it looks like afterwards. Again, the bowel travels from lateral to medial, superficial to the mesh, and this is what it looks like intraoperative. In an open case, you place the mesh here and you let the intestine, here's the mesh, you let the intestine lay down the mesh and then enter the aperture while it travels in the retromuscular space. And again, the distance we usually try to overlap the mesh with is about at least 4 to 5 centimeters. I actually try to do more now that I have done a lot of those procedures. So what about small incision reproduction of poly-modified Sugar-Baker repair? This is robotic. And this one I'm going to show is a transabdominal approach. This case previously has had a recurrence and another surgeon fixed this with a laparoscopic biologic keyhole repair. So this is a recurrence of that. And then the patient presented to my institution, and this is ports now positioned intra-abdominal, the patient's right side, and we're looking towards the left lower quadrant. We see the old biologic mesh. We take it down together with the posterior layer here, the cut edges of the posterior rectus sheath. Working around the stoma itself, actually have to open up the hole, doing the transversus abdominis release. This is what we just talked about, to getting in a retromuscular space. We're now around the stoma, and now the stoma has been lateralized, and now closing the defect itself. And then this is a medium weight macroporous polypropylene mesh, just secured in such fashion where, again, the intestine travels between the mesh and then on the subabdominal wall, and then the posterior layer is closed. So this is a transabdominal approach for an isolated parastromal hernia. What about ETAP access, especially if you have previous midline incision? So I'll show you this video as well. So now this is a patient with a midline incisional hernia as well as with a parastromal hernia in the left lower quadrant. And so what we're doing here is the camera is in the right upper quadrant, entering the right retrorectal space. I got the direct vision that place robotic 8mm port just medial to linea ulnaris. This is linea ulnaris right here. So we'll just play this video here. Placement of the robotic port here. Then looking up, this is the camera port here, and this is the right upper quadrant port right here. Let me just show you the diagram. Again, this patient has lower midline incisional hernia as well as a parastromal hernia, and the setup is such where we have, this is the older robot, we have two 8mm robotic ports. This is my left hand, this is my right hand, and the camera port here in the middle, and we start the dissection in the right retrorectal space. As we proceed with dissection, the first step is a crossing over, where I incise the posterior lamella of internal, where I incise the contributing portion of the right posterior rectus sheath. Thus we enter the space just posterior to this attenuated linea alba. You can see the old stitches. This is again linea alba. This is the right rectus. We incise the posterior rectus sheath on the patient's right side, entering space superficial to this preperitoneal fat, which is associated with falciform ligament, and crossing over and looking to identify the contralateral posterior rectus sheath. And you can see here, the posterior rectus sheath has been identified and incised, and then we identify the left rectus abdominis muscle. So going from the right retrorectus space to the left. So here's the video of the presentation of that. Yeah, the linea alba. This is the midline defect here. Now we opened up the left posterior rectus sheath, and we're dissecting around the patient's left arcuate line, and here's the left linea simulnaris. So the space right here is called space of Bogres. So again, the stoma is going to be right here as we continue to dissect. As we dissect in a retrorectus space, so I'm going to start a bottoms-up transversus abdominis release. And when you perform a transverse abdominis release, the bottoms-up portion, you don't cut any muscle. So essentially, you cut the posterior lamellar internal oblique and transversus abdominis aponeurosis to get superficial to transversalis fascia. So again, space of Bogres, there's a peritoneum here. This is the transversus abdominis muscle. Linea simulnaris, you divide medial to linea simulnaris and medial to neurovascular bundles that are going to be traveling here. Divide 2 layers, posterior lamellar internal oblique and transversus abdominis aponeurosis here, entering space superficial to transversalis fascia and peritoneum. And then as you go up, you start dissecting and incising the sac around the stoma itself. So this is again left rectus abdominis muscle. This is the parastromal hernia. With the stoma going through the left rectus abdominis muscle, so you can see dissection around it. You can also see some neurovascular fibers here, so you gotta stay medial to them. And again, you go from the bottom up, dividing the posterior lamellar internal oblique as well as transversus abdominis aponeurosis to enter the space then lateral to linea simulnaris, superficial to transversalis fascia. So here's the dissection now. We're dissecting lateral to linea simulnaris now, just posterior to the transversus abdominis muscle. And then once you dissect everything, then you have to make an incision in the posterior layer. So again, here's the conduit, here is the aperture, this is the transversus abdominis muscle, the posterior layer we refer to as the transversalis fascia and peritoneum, and medially you have the actual posterior rectus sheath. And then you actually, here you have to divide the posterior layer in order to change the insertion point of where the conduit travels from intra-abdominal space into the retromuscular space. So here it is. Now we suture the conduit to the underside of abdominal wall. And we do this again to lateralize the conduit. So this way it doesn't hang on a mesh, and again, there's hope to decrease that point of tension where the mesh is sitting and separating the intestine from its intra-abdominal contents. So here we are suturing. This is a 3-or V-lock stitch. And now then afterwards, again, we're creating that insertion point and suturing from the insertion point of the stoma into the retromuscular space towards yourself, towards where the old insertion point was. So again, this is the posterior layer here, the conduit. We kind of create a new entry point into retromuscular space and then suture towards ourselves where this looks completely closed now with a new insertion point. So this is what it looks like. It conduit traveling from lateral to medial. The defect then is usually closed. This is a 0 V-lock stitch. And this is the midline closure as well. Because again, this patient had a midline defect as well as a parastromal defect. And all this is, now we're gonna overlap the whole area with mesh. Again, the mesh is, the ballast traveling from lateral to medial. I'm gonna show you how the mesh lays. So again, the conduit, this whole area of the conduit is gonna lay on this mesh right here. So you see how it's been displaced. The conduit is laying on top of the mesh. This is a mesh placement here, just unfolding this mesh. This is a 35 by 25 piece of macroporous polypropylene mesh. That's it. So we've done about 25 modified sugar baker repairs that this is the last few years. 83 of those cases had previous failed repairs. In our series, we have had 2 recurrences, no mesh erosion to date. Length of stay was about 2.2 days and 1 year of follow-up so far, but longer follow-up is needed. And the question is, whenever you do parastromal hernia and you do place a prosthetic mesh next to intestine, the question is, how long should you follow those patients for? In my opinion, the risk of mesh erosion is real. This is something you should talk to the patients about before taking them back to surgery. And what I tell them is the risk is lifelong. And so they understand this before proceeding with surgery. Things that can be seen, and this is some of those pictures from my colleagues and friends. This is not my case, but this is what a mesh looks like post-op day 5 after it has eroded into the intestine. This is a medium weight macroporous mesh, and this is endoscopy through stoma, and the surgeon is looking directly at the mesh through the intestine. You know, we all probably had different patients with mesh that has eroded inside the intestine. This is not from a parastromal hernia repair, but I just want to show you a picture of one of my cases. That is certainly a worry that anytime I place the mesh next to the conduit, what's going to happen to it 30 years from now, 50 years from now? That is a concern. Luckily, a lot of those patients are older, so probably you don't need that long of a follow-up for them, but still it's a concern whether what can happen to those patients long-term. And I think a technique really is important to decrease those risks of complications. This is, again, not my case, but this is what happens when the mesh erodes into the mesentery. And this, we think, happened possibly because there were just special stitches holding the mesh, and it was very tight at the transition point where the intestine was traveling from intra-abdominal space to the retromuscular space. And this presented actually a few months after the surgery. So again, this can happen. This is a nightmare scenario to fix afterwards. So takeaway points, again, for me, I showed you a lot of robotic surgery. It's a tool. If you have access to it, that's a wonderful, I think, especially for those complex cases. You know, the limitations, the contraindications to robotics is similar to laparoscopy. The technique, in my opinion, I think is more important than how you do it, whether you do it through small incisions or open incision. The way I fix parastromal hernias is similar how I do them robotically and open. Nowadays, I try to, whenever I think it's appropriate, I try to do a modified Pauli sugar baker repair. And still sometimes, really, I will do just a sugar baker for the small isolated parastromal hernia. And most importantly, I want to emphasize is if you're going to be fixing parastromal hernias, follow your patients for long-term, because we do not know what are the long-term consequences of those meshes directly against the intestine. Thank you very much. I want to leave you with that thought. He that will not apply new remedies must expect old evils, for time is the greatest innovator. And this was Sir Francis Bacon, 1625. Thank you very much.
Sergey, I don't know who will be able to say thank you to our colleague from the US because it is a recording, but the presentation was really honest and really good. It is a huge problem, peristomal hernias, I mean, and he showed us in a very honest way that on the one hand,
so
if we
indeed,
are
this is
delicate,
a very important
and if we
problem.
don't apply the mesh not very close to the intestine, then there is a high risk of a recurrence. If we are too close to a peristomal area, then the risk of lesion of the whole of the intestine and coagulation and blood circulation problems may also be a problem. And here, a surgeon's expertise is really of importance.
Благодарить всех участников этой секции. Мне кажется,
Thank all the participants of this session. I think that indeed it was very interesting. We touched upon different subjects, and they actually reveal even greater problems for us to discuss during following sessions in 2021. Thank you. Thank you, Sergey Ivanovich, for presiding over this session. I will thank Igor Bilansky through Facebook. Actually, I've talked to him. He is awake. In spite of time difference, I would like to thank DT Group, technical co-organizers that recorded his brilliant lecture. This lecture can give new ideas for us regarding the way we can treat our patients. Let's close this session. Thank you. Armen, Alexei, thank you for your lectures. See you in online and offline. And we're moving forward towards our next session without any breaks. Hello, Seda. Finally, we see each other. Here, dear friends, we have some change in our agenda. Now, Dmitry Gladyshev will present. Well, yes, we will have brief advertiser now. We're not on air, so just 2 or 3 minutes. Okay?
Остается 50 секунд. Да, вы можете сейчас уже включить, запустить демонстрацию экрана.
А у вас видео не запустилось, да?
Остается 30 секунд.
15 секунд, мы за тебя болеем.
Я готов, да. Ой,
Так, а можно, пожалуйста, буквально несколько секунд тишины? «15 секунд». «10, 9, 8, 7, 6, 5, 4, 3, 2, эфир».
We are on air. Hello, distinguished colleagues. Could you please show the presentation on the screen? Thank you, distinguished colleagues. Hello, I'm very glad to welcome all the participants of 7th Moscow International Festival of Endoscopy and Surgery. And I want to mention that traditionally, the surgical days of this festival start from such important area as colorectal surgery, including laparoscopic and robotic colorectal surgery. This year, program director of this area is Artyom Leonidovich Goncharov. I would like to thank him for having gathered here leading Russian and foreign experts in the sphere of colorectal surgery. In your afternoon and morning session, you already heard our lectures and live broadcastings from the ORs. We will have our evening session devoted to new technologies in colorectal surgery. My co-moderators are Artyom Leonidovich Goncharov, Ilya Leonidovich Chernikovsky, and we will also have our foreign expert from the USA, Sam Atallah. I'm very happy to welcome all the moderators today, and I think that Artyom Leonidovich will introduce the speakers of this session, and we will start it. Artyom Leonidovich, good evening. Indeed, we've had some changes in the agenda. Dmitry Vladimirovich Gladyshev will speak about his experience now. He's actively using the DaVinci Xi. This is a new generation DaVinci robot, and we will gladly listen to his impressions of this robot. Hello, distinguished colleagues. It's a pleasure for me to welcome everyone on this wonderful festival of surgical art. Unfortunately, we're not able to shake each other's hands. I think that many people already spoke about it today, and they mentioned it during all conferences, but still we remain friends. We never stop our creative search. We're ready for cooperation, and we're ready to learn from each other in terms of scientific activities and new technologies. In my presentation, I will speak about first experience of using robotic surgical complex, DaVinci Xi. It is not completely about a colorectal problem, although we actually used it mostly at colorectal surgery, but this is an introduction, an introductory information regarding new robot DaVinci Xi that has been present in the Russian market for this year. There are 6 generations of DaVinci robots. The first one was released in 1999. It was DaVinci Standard, and it was approved by FDA in the USA. It was the first robot that was approved by it, and it was used for surgery in colorectal cancer in 2001. The next generation of DaVinci robots is DaVinci S, which was firstly released in 2006, and after that its modification appeared. This is DaVinci SI. This robot is the one that is mostly spread in the world and in this country. DaVinci Standard, but probably just preserved in some places, but this is like an outdated version, but this is the way it actually looked like. Surgical console was not changed. You can see here that it is quite huge. DaVinci S. This is a very significant step forward. I think that many colleagues have seen it and have managed to assess the advantages of robotic surgery. Thanks to this machine, and in St. Petersburg, for the first time, we received this model in Almazov Hospital, and our colleagues started implementing it for urological surgeries, as well as retroperitoneal space, endocrine surgery, and similar surgeries. And you can see that just like in the previous model, actually surgical console remained similar, quite standard. So actually it's not possible to set it for a specific surgeon. And of course it was not always convenient and comfortable. The screen was a bit different, and patient's console. Here contemporary tools are used, but still there were some aspects of using them. This is the most reliable tool, DaVinci SI. So the next modification is SI HD. And here, apart from standard set, there is a laser to conduct OCG navigation. This is a very good function. This is an option for DaVinci SI. Surgical console can be seen on the left, and actually it has changed a lot. So it's possible to modify it by the angle of head slope, by the height of patients. It's possible to modify it, and it's possible to manage the video, sound. It's possible to change the scale of the image. So these are quite important settings that can be changed by the surgeon during the procedure. Patient's console is in the center. It's quite convenient. And we have used it since 2013. We know that it's a very reliable mechanism, very reliable equipment, and I do not actually remember any case when it broke down. But we need to remember that service system is there, and even in case it breaks down, engineers from Intuitive company help us. So an engineer come and change the engine in the left part of the patient's console, even without our knowing about this problem, because they learned about it through the web. And this is an intermediary model between DaVinci Xi and DaVinci Si. This is DaVinci X. How is it different from the previous model? Patient's console has some instruments from DaVinci Xi. This is a hybrid model. It's a bit cheaper than Xi, but it has proven to be quite good. And in terms of price to quality ratio, it's quite good as well, but frankly speaking, I have never used it. And finally, this is the last modification of DaVinci Xi robot. We have started using it 1.5 months ago. The first surgery was done due to colorectal cancer. We did 2 surgeries during 1 day. This was rectal cancer, anterior resection, and right hemicolectomy. The next surgery, so 2 surgeries on rectal cancer patient, and the 5th or the 6th one was robotic gastrocolectomy. What is different here? So it's a bit different from the previous model. You can see that the modification that has not been certified in Russia yet, this is DaVinci single port, DaVinci SP. And I think that it will be used in surgery in this country as well, but right now, unfortunately, we do not have an opportunity to use it, although there has been quite serious feedback. It is used for narrow space surgery, for gynecology, urology, and we have not had such an opportunity yet. DaVinci Xi. This is the 4th generation. It appeared in 2014, and as we heard, only in 2020 it was certified in the Russian Federation. However, Artyom, my colleagues and I saw it in Switzerland on the Congress 2 years ago. So 2 years ago we managed to try it. We tried new Citroen devices that were already released by Intuitive company, and they could bend almost at 90 degrees angle compared to the axis of the device, and several years later DaVinci appeared in Russia as well. So what can I mention regarding the previous models? First of all, early generation of DaVinci robots requires laparoscopic or hybrid approach, or it's necessary to switch manipulators intra-op, because this is multi-quadrant surgery. And it requires the operative intervention within quite huge space, for example, mobilization of splenic flexure and work in small pelvis. As a result, many authors came to the following conclusion, that this equipment is not suitable for wide operating field, although we managed to use it. Thanks to the revolving parts of manipulators, the surgical cart of Xi can provide for quite a huge volume of anatomic access. In case of docking, from almost any position around the patient through the console, and you can select actually the angle of console towards the operating table. Laser is used here, and cannula holder is used as well. The docking time is decreased. In previous generation devices, it was necessary to have wide space between the leverages to maximize the working field. But now the situation is different. They're parallel to each other, and the distance between ports can be not more than 7 to 8 centimeters. It's quite close, although it seems illogical, but still, it allows us to conduct all manipulations without clinching functionality. Well, it's difficult to explain everything on the pictures, but actually these elbows of the robot, irrespective of robot connection, can revolve around their axis towards the left or towards the right. So the steeper angle is created. Due to clearance and high extension of the instrument outside the target zone, the angles can be shifted by 28%. That is much more compared with XI. 8mm endoscope, it can be integrated into any port that was administered in the stomach, for example. So, in the past, in DaVinci SI, well, right now it is like that as well, we can use only one optic arm of the robot to introduce trocar into the stomach, but now it can be done with any arm of the robot. Besides, it's much smaller, 8mm only. Sorry, some technical issue.
Я не знаю, по какой причине, почему-то отсутствует видео.
I don't know why there is no video here. This is the way the handle of XI looks like. This is patient's console. I don't know why the video is not launched. So actually I have to explain it to you without the video. Probably there is some internet connection problem. In the past, we had to manipulate this handle ahead and backwards, but now the management can be done by the robot arrow and by rotating the console. Dmitry Vladimirovich, probably we can switch on the video from another computer, or this will be a bit more complicated. Well, I don't know, actually, probably we have some time limitations. I have 3 videos, and they include all with the videos as well. So actually, I sent this video to your colleagues as well, and they didn't manage to switch the video on either. I don't know why. So these are trocars. This is robotic stomach resection. And in this case, if DaVinci SI is used, this is the top picture. Here the console is from the side of operating table. This is the head of robot. And this is the bottom photo. In this case, DaVinci is on the right of the patient, and the robot's arrow is under the angle of the console of the patient. As a result, we can have more space around the head of the patient, because anesthesiologists are normally concerned about this situation when they do not have access to patient's head. So, this is why it can be difficult to conduct artificial lung ventilation. Here you can see connection of DaVinci XI. In our OR, you can see the position of trocars. On the left photo, laser navigation is used, and it allows us to see the optic drawer connection and laparoscope. In this case, they're located at the same line and they are closer to patient's legs. It allows our anesthesiologists to work quite comfortably. This is full position of the patient, so the legs are put downwards. Speaking about change of the position during surgery. Unfortunately, in this country, the specific platform for the operating table has not been certified. That's why we cannot use the operating table parallel with DaVinci Xi robot. So changing the position of the table, when we want to elevate the head part of it or put it down, we cannot do it together with the switched on manipulator. So we have either to switch them off when it's necessary to change the position of the patient, or we can leave them, and in robotic gastrectomy we used full position with the legs down. Speaking about DaVinci Xi in colorectal surgery, in the left angle you can see single docking. When DaVinci Xi robot was used, you can see that drawer cars are located in mosaic manner. In DaVinci Xi, drawer cars are located within one line. It's quite convenient. 7 centimeters is the distance, and during the surgery you do not need to change it depending on the stage. For example, when we use about mobilization of splenic fracture or rectum fracture in total mesorectal excision, in that case we do not have to switch the robot from epigastrium into the left ileum area. I cannot switch on the video, but I want to mention that all the manipulations are done from one drawer car administration along one line. It's very convenient. So you install this robot, and from the beginning, when you mobilize the inferior mesenteric artery, splenic fracture mobilization, small pelvis, we use one and the same position of the patient. It's convenient. There are several new articles devoted to the comparison of robotic surgery on SI and XI platforms. So we can see some progress here, because the operating time in case of low anterior resection of stomach and sigmoid intestine stomach decreased from 238 to 162 minutes. Due to simplified docking probably. However, in case of robotic stomach resection, well, the authors didn't speak about any positive aspects of SI.
Ну, как иногда бывает, оно вроде бы идет, а на самом деле не идет по какой-то причине. Бог с ним. Таким,
I cannot switch the video on. I don't know why. So on this slide, we showed the connection of DaVinci Xi robot in case of robotic low anterior resection and the option for drawer car placement. What have we done since the 14th of October this year, when this robot was installed for the first time? The initial training took 2 days. During the first day, we trained our nurses and IT experts. We connected the service. During the second day, we talked to our colleagues from Moscow company that is responsible for the installation of this robot. And within 3 to 4 hours, we used the simulator to define all the possible details of using this new model some disadvantages and advantages, how we can connect the camera in the right manner. Well, for example, you introduced optic trocar into the abdominal cavity, and there is a specific button there. When you select the target with a laser inside the abdomen, you can press this button and locate trocars around the optic trocar. So actually the console itself moves a bit, and it allows you to place trocars in the most convenient mode, and we only have to connect the robotic armed trocars and we continue our further work. Since the 27th of October 2020, we conducted 9 surgeries. I will explain you why. Actually, it would have been possible to conduct 29 of them, but as normally happens, we received set for 10 surgeries. So we received instruments for 9 surgeries. You know that one instrument can be used for 10 procedures. So we have only one set, and we will use it this Friday. They are different from DaVinci Xi, not because their working parts were somehow changed. No. Actually, they're quite similar. Monopolar scissors and grasper and other instruments, and the part of console that is installed into the arm was changed. That's why, unfortunately, using them on the previous model is not possible, because the robot generation is completely different and they cannot exchange instruments. They're located in neighboring ORs. And here we have the list. This week we will have 2 operating rooms occupied on SI and XI. Distal subtotal stomach resection was done. Robotic gastrectomy was done. Right hemicolectomy, 2 surgeries, and robotic resection of rectum, 5 surgeries. In 3 cases total, as the rectal excision was done. So what can I say about the surgeries? We have not had any conversions or intra-op complications. The first 2 surgeries were a bit long, because there are a lot of settings in the surgeon console. They allow improve the quality of the video, like warm shades, cold shades. It's also important you can manage surgeon's console with electrosurgical block. It was not possible with the previous model. So a very good platform, AirBear, was connected. You can manage it from the surgical console. If you use DaVinci SI, you realize that it was necessary to stand up, change the modes, and so on and so forth. But here, it's more convenient. And I'd like to mention that the simulator is really good. It allows you to download the videos of surgeries in online mode. Today, these are mostly surgeries done by our colleagues from the USA, and you can see them in 3D video mode. So, you look at the screen and you can see the picture that you could have seen if you were in front of the robotic console. So what conclusions can I make? It's difficult to make any global conclusions actually, but still, the previous generation did not show the advantage of traditional laparoscopy. It is true for colon and rectum, and for stomach cancer surgery, but XI platform simplifies multi-quadrant surgery due to better docking and quite extensive radius affection. And finally, I hope that it can also be reasonable even in spite of quite high cost. Thank you, colleagues. That's it. I think that today many participants saw it for the first time.
connected to this robot, and you are one of the most experienced surgeons in our country in regards to robotic surgery. To use a new robot, do you need a certificate that a surgeon has been trained in using this robot? You said that there were new details in how to use this device, this installation, and do other clinics have this robot apart from your clinic? Number one, as for certificates. Sorry, can I play the video? Of course, if you manage to, then we will be happy to watch it. And then I will answer your question, if you don't mind. All right. Then we're waiting for the video. I think that many people were waiting for the video to see that new installation, that new device.
Я запускаю тогда демонстрацию экрана, да? Да, спасибо. Да, ничего. Коллеги, если это вот первый слайд,
Colleagues, can you see the first slide? Yes, we see everything and we see the video. Great. I don't know why I couldn't play the video at the beginning. It is not our video. We did not create it. It was done professionally. The console, and you see that it can just roll about the surgery room, and it can be connected to any arm of the robot. This is ICG navigation, and it's set a priori. The robot is so well set. There are all the components. We had several ICG containers, and they worked amazingly. Here you see in real time how the robot is getting connected. The green laser is the guidance that allows to get to the optic trocar and install the trocar accordingly. The movement of the arms is performed thus. This is our surgery room in real time. Well, not real time, it's recording. There is one of the first surgeries for rectum cancer. Assistant trocar is in the right iliac zone. The patient is in a comfortable sitting position. The console is right to the patient. You understand that when we're using XI, then we put it next to the patient, but the surgery room is not big. It's actually quite small. And it's difficult for us to manipulate connecting this console on the right, on the left. We had to rotate the surgery table in stomach cancer. But this console allows to perform all the movements quite easily. Sorry for not having inserted it smoothly into my presentation, and now I'll be happy to answer the questions. There is a question from our listeners. What's the cost? What's the price of this installation? Well, it's expensive. It's not me who bought it, it's our government who bought it, St. Petersburg government. There is the company MPI, and I think it's about 200 million rubles. If you want to buy it yourself, then you can go to the MPA company. It is quite expensive, but believe me, in the current conditions of healthcare development, medical institutions are buying it quite actively. We were the first ones, but believe me, we will not be the last ones to buy this equipment. Thank you, Dmitry. Thank you for answers to the questions. I know that in the US, our next speaker is waiting for us. He is going to have an operation, Sam Atala. So Artyom, please introduce our next expert. If we have time for the discussion, we will get back to robotic surgery. Artyom, please present the next foreign expert. Good evening, colleagues. We have Sam Atala. He is a famous American colorectal surgeon who operates using all kinds of robots, and he's a representative of the company which develops new types of interlumen and other robots. And we hope that he will show us his videos, and we will peep into the future with the help of Sam. Thank you very much.
Sam, thank you very much for the kind introduction. It's a pleasure to be here, and I hope that my videos will play. As I saw, there were some technical issues with the last presenter. These things always happen. As I was just speaking in Colombia yesterday, there were also technical issues, and I said to them, you know, what is a Zoom meeting without technical issues and errors? Anyway, so I'm in Orlando, Florida, and I'm going to talk to you more generally about nonlinear robotics. And I'm going to share with you some of the developments we're working on now at my center. These are my disclosures. Can everybody see that okay? Are we okay? Is everything good? Okay. So this all began, I think, with the act of transanal minimally invasive surgery, a technique that I co-developed in 2009 that opened really the gateway into operating and doing advanced transanal surgery. We followed up our techniques with TAMIS for local excision and found that in a series of 200 patients, this was a very precise, a very accurate way to operate within the lumen. And when we looked at our data, it showed this. It reflected that we had low rates of fragmentation and low positive margin rates. Most importantly, this translated into improved clinical outcomes for patients. So the technique and the technology of TAMIS works. It's a good technique. Recently, this year, the American Society of Colorectal Surgeons endorsed TAMIS formally in their guidelines for the management of early stage rectal cancer and recommended TAMIS as a technique to properly locally excise early stage cancers. And this is also now part of NCCN guidelines. And more recently, myself and a co-founder of the technique, Sergio Larache, we published this paper just last month in JAMA, highlighting some of these advancements over the past decade. But this is all old news, and I want to talk to you about kind of where we're going from here. Quick video, this is kind of our platform that we use. It's a gel point in combination with AirSeal. One of the issues that we had was stabilizing the rectum so there was no billowing and that we could get a very stable operating field and environment. And this is kind of how it works. For those of us that are colorectal surgeons, you're familiar. If you're not, you've probably not seen this, but with a pneumatically distended rectum, we're able to identify a lesion, create a beautiful margin around it, and then perform usually a full thickness excision. And this is just a quick video to show kind of how that works. The TAMIS port has been placed, the gel point path, using AirSeal, using straight laparoscopic instruments. One of the advantages of TAMIS was that it adopted existing equipment. We didn't have to have all this specialized, sophisticated instrumentation. This is an ordinary hook with ordinary cautery, conventional instruments, conventional graspers, usually just a Maryland grasper, and nothing special, nothing fancy. It is really the ability to view the operative field so well that allows this technique to create amazing excisions and good quality excisions to minimize fragmentation. Okay, so this is all TAMIS. This isn't intended to be anything new. And what I want to show you in Moscow and all the viewers tuning in is kind of where we're going from here. So TAMIS is great and it works, but it has some limitations, and we need to always be looking into the future of where are we going with things. And the questions that we have, those that do it routinely, are, can we increase the range of TAMIS? Can we perform full thickness excisions outside of the comfort of the peritoneal reflection? Usually we're beneath the peritoneal reflection, a very safe area to operate. How about going up into the more proximal colon? Can we do that? Can we leave the bedside and operate remotely, like in the last previous presenters using Da Vinci models where the surgeon is remotely positioned? And maybe we can then divorce our need of having a skilled second assistant, which if you do TAMIS, you know that it's a two-person skilled assistant at least required to handle and manage the camera and some other aspects. And then can we harness the power, the precision that comes with robotics, that comes with that control, and further in the future, intelligent systems to help guide us through some of these more complex procedures. And that's sort of the topic of my presentation, nonlinear robotics. And what do we mean by that? Well, let's look at where we have gone with robotics over the last 20 years or so. It really started out as the idea of telesurgery. It started out as a military concept of, let's say I have a patient who's injured, a soldier injured on the battlefield, and I'm a surgeon in Moscow or Paris, and I want to operate on this patient remotely. That was the idea of all the Da Vinci now. And then it was transitioned from military to a commercial, where everyone said, well, wait, you know, this kind of has some very interesting applications. Maybe it's better than laparoscopy. And it probably is definitely the case for some procedures. The best example is the robotic prostatectomy. Very precise, the ability to sew the urethra, etc., do the anastomosis. These are great advantages of the robot in a fixed field. But then we said, let's expand its use. Let's do everything possible with the robot. And for 20 years, we kept fighting lap versus robot, lap versus robot. And this was the whole pretext for the robotic laparoscopic battlefield, if you will, that we're always trying to show one technique is better to claim supremacy over the other. Then in the late 2015, 17, something like that, we said, let's stop this nonsense and let's start thinking about robots in a different way. And that is, can we access areas and targets that we otherwise couldn't? And for this, we needed to move away from the design of laparoscopy, which is a linear instrument. Okay, yes, the effector arm has 6 degrees of freedom with a robot, but I'm talking about the actual instrument. And it is that transition from linear to nonlinear systems that is really going to open the gateway for the future of robotics and intelligent systems. We can look even further in this, and these are all from my new textbook, Digital Surgery. But you can see how we're going to use the cloud as part of the interface. We're going to further robotic automation. And a big part of this is nonlinear systems. The cloud, how this fits into things, is very hard to explain in just one slide. But basically, intelligent systems are how they would work to share a common brain. Is, let's say that we have a robot that is intelligent and is learning how to do something. Let's say it's learning to recognize the ureter. Let's say you're working in Moscow. I'm going to teach this computer, recognize the ureter, recognize the ureter. Okay, but now we use the common brain in the cloud rather than in the Moscow computer. And now whatever is learned in Moscow is now known in Orlando. And let's say in Orlando, I taught my computer how to recognize the common bile duct. And it get really good at it with artificial intelligence. Now guess what? That information is translated to the Moscow computer. This, and then imagine a whole network of these, so that the more computers you have learning different things, the more the power, the more the information harnessed. Back to nonlinear systems. So here are some of them, including the Da Vinci, which now has an SP on the left of the screen, the Med Robotics, a flexible design. The Flex Robot used a lot for ENT, also tried in transrectal as well. The Titan SP being used in France mostly. And the RoboFlex, believe it or not, a flexible design designed to get into the ureter and operate within the ureter. This is coming too. For the urologist, they will be able to operate through the ureter and then percutaneously into the kidney, for example, to achieve and fragment stones. What if we can take something, a non-linear, something as tiny as a wire, and bend it in a non-linear way? Neurosurgeons are working on this. Imagine in this dry model, the bottle cap represents, seen there, the cap of the bottle. Let's say that represents a structure we don't want to injure in the brain. And the question is, can I guide a wire around that structure? And it's been shown that you can, using a micro wire, a nonlinear system, by varying the duty cycle, which is defined as the pulse wave, the pulse of energy given over overall time. You can control the bend of something as fine as a wire. This is where we're going. Recently in Science, this was published. Can you operate within the vascular tree using a nonlinear system? Actually operate within it. Well, they showed that you can actually do this. And what they did was they took something that is borrowed from insects. Have you ever seen a roach crawling? It's always on the corner of something. If you turn off the light right now, make everything pitch black, what will you do? You will go find the wall with your eyes closed and you feel the wall. This is called wall following. By knowing where the wall is, you can compute information. If an insect can compute it, and if I can do it with my eyes closed in the dark, so can a computer. And this is exactly the model that was used by some very creative robotic designers to design a system that follows the wall of the heart to go to the target. More recently, the Monarch Oris system has been developed for another nonlinear system of great importance, and that is the lungs, that has bronchi that are very predictable, but have right angles, and so now we can't use linear systems. So this absolutely laparoscopy cannot do. And the models now are using controls and joysticks like a gamer. So your kids and my kids are much smarter than, they're going to be the best surgeons ever. But the idea is that we can control at right angles, and then we can merge information from the optical feed that we always have to robotic insertion data, i.e., if I know my tip is here and this is certain distance, I can now calculate where this should be. And then I can also take electromagnetic navigation information to precisely identify a target. Navigated bronchoscopy is now a real thing. This is not experimental. This is happening. This works. This is a leading example of nonlinear robotics. In my last few minutes, I want to talk to you about where we are at my center using a non-linear or flexible robotic system, if you want to call it that. It's called the Endoluminal Surgical System by Colubris MX. And it, again, uses the same technologies of divorcing the surgeon away from the bedside, where you can operate and manipulate things very similar to Da Vinci with clutch and control and things like this, and a pedal board to push cautery, etc. And this is what the tip looks like. So it's sort of a hybrid between a colonoscope. Each instrument is 6 millimeters, same as the Da Vinci SP, and you have a camera. So there's a camera and 2 working instruments, and I introduce it through a TAMIS port. So this is next step TAMIS, if you want to think of it that way, and we also use AirSeal. I want to show you these controls so you understand what we are doing, okay? So first, there is the main control that I have over the scope. I can move the scope up or down, as you see in the icon, or I can move it left or right. In addition, and separately controlled from that, I can now also move separately the camera. So I can move if I wanted the scope down and up, and then the camera up and down and left and right. So you can see this provides you a tremendous amount of control over the surgical environment. I can also move the entire scope in and out, like driving a car. Like I'm going to drive it forward or drive in reverse, just like a car. Then, importantly, I can also flip my orientation and axis, and I'll show you more about that. And there's also some other instrument controls. So this is what it looks like when you're operating at the console. We are doing live human cases, but I'm not showing you that today because this is still on trial. But in a porcine model, you can see that you have the precision of using scissors, something very difficult to do with standard TAMIS. And you can do a proper either partial or full thickness excision. And we figured out ways to manage the suture, get the suture back and forth to operate and actually close defects within the lumen. Here using a barbed 2 or 3/0 barbed suture. So it's a self-locking suture. And you can see for yourself, this is a very precise way to operate. I've done and pioneered, in fact, endoluminal surgery using straight stick Da Vinci. And I can tell you that what you just saw is very hard to do. Let's get back to flipping the horizon. Just like an airplane flips the horizon. In fact, the control shows you that very similarly. And watch this. Look at the machine. The entire machine flips like a carousel, and you can see on the window on the left that it's showing you that you're airplaning all the way around. You're spinning the entire scope all the way around. The whole machine goes upside down 170 degrees, allowing you to operate upside down. This is what I had tweeted, I guess had captured quite a bit of attention, to just mentally, visually show you that you can literally flip the machine and operate downward. In those that do colonoscopy, those that do work in TAMIS too, we always like the lesion to be down. We don't want to operate when it's up. We like this. And even though I know I'm upside down, even though I know this is really the ceiling, when I release the specimen, it still seems as though it's contradicting gravity for some reason, because you just don't understand how that can be. Your mind has played a trick on you. Of course, that's really the ground side. And now we're re-rotating the scope. Watch the roll go back to left, right. Did you see that on the side? Showing me my orientation, and then I can retrieve the specimen. So these are things that we can't do with TAMIS. And these are sort of the next generation things. 2 small clips I'm going to show you from our live feeds. These are real live cases in patients, and I can't show you more than these right now. But the robotic instruments, they're nonlinear, they're flexible, they're escorted into 2 ports and then locked into place in the robotic device. This is all docked transanally, and this is actually a case from the first live human case performed in North America. So where are we going now with things? We want this. We want to be able to, just a step back, okay? Let's talk about what are the goals, not just for GI and colorectal surgery, certainly is my interest, but more globally, how can we throw everything to the side, have a clean mind and say, how can we approach targets that we now can't otherwise with laparoscopy? And how can we do that? The answer is, in part, a big part of it, nonlinear systems that are able to follow the curved linear path of human anatomy, whether it's the bronchus, the ureter, the colon, all these things, the esophagus, they're all nonlinear. And this is why we need to have devices and instruments that can accommodate that. Then the second part of this is great. Okay, now what? Can I have the level of control and precision that I get from 25 years of Da Vinci and put that into these nonlinear systems? And this is all great. And I want to also integrate artificial intelligence so that I have smart systems. I alluded to that briefly as well. ultimately, in colorectal surgery, can we have a system that navigates high enough up? By the way, the system that I showed you goes to 60 centimeters from the anal verge. Currently, our limit is 15 centimeters from the anal verge. And so this is a very important next step in reach, okay? But can we do that safely and for selected, I'm not talking about cancers, but for selected benign neoplasia, can we perform local excision and obviate the need for a patient to undergo radical surgery? Thank you so much for having me. I'm available on Twitter or by email if you have any questions.
Thank you very much, Sam.
Прекрасную презентацию, и я вот будучи...
Great presentation, and I am an endoscopic surgeon who does intralumen colonoscopy, endoscopy. I can say that in the last years, we see how much intralumen surgery has been developing, and the accent is on creating robotic, flexible platforms for intralumen operation. And there are Lumenzi platforms known in the clinical practice, and also equipment from other producers. And today we have we watched your presentation, and it was like a peep into the future. What? So out of the technologies you were speaking about, which could we use, which are already applied in clinical practice today? Is there anything which is already applied?
Yes, there is. So this one, the one I just showed you the most about is, and thank you very much. I think that I just want to, before I tell you about that, I want to say you're absolutely right. And if you're a young person starting out a career in GI surgery, I hope you see a talk like this and it sends a shiver down your spine of excitement, like when we were starting out and there's a look of amazement and wonder in our eyes. It's going to be so wonderful for those people who are just now starting their career. And I'm so happy that we are in this time. But the ones that are actually out there, the systems that I showed you, certainly the one I showed you is on trial with the FDA, and it's coming along quite nicely. I can't share any more of the data on that. Off-label, the Da Vinci SP, the Da Vinci system with the single port Da Vinci, it's often called, is being used by a couple of pioneers, one of them John Marks, and the other one is an investigator in Hong Kong, Simon Ng. And they are both using it and having good success, not only for transanal local excision, but even TATME and some other things. So there's a big future for the Da Vinci SP, and I've also used it, but in a cadaveric model. And I think there are some pros and cons to each of them. The flexible med robotics one is one that's not really a robot, and it's operated at the bedside, but it has also been used in human trials, and I've used it as well. I think its best application is for ENT, and we're still sorting those things out. The Monarch system that I showed you is in use, is being used. It's navigated bronchoscopy is now a thing. People are doing it. And I mean, this company, not only is it worth a lot clinically and for patients, it's worth a lot financially. And Johnson & Johnson just purchased the manufacturers, all their IP and everything else for something like $4 billion. So a very lucrative market as well. But of course, we're in it to, from our standpoint as clinical care providers and surgeons and endoscopists, we're in it to help our patients, and that's why we do this.
Сэм, спасибо большое. Возможно, есть вопрос у моих
Sam, thanks a lot. Probably my co-moderators have some questions. I can see that there are no questions on the chart yet, but Sam has left his contact data, and I think that any of you will be able to connect him in case you have some questions. I think that you will have them. So, do my co-moderators have any questions? If no, I would like to say the following. Sam, this presentation was really impressive. Robotic system, flexible system, the system's integrated with the artificial intelligence. Very soon we will have nothing to do in the OR. Of course, I'm just kidding. And now we will say bye to you. I know that you will have surgery. We wish you good luck. And now we return from America to Moscow. So we are returning to Moscow from America. And we're moving to Rijik Institute. Now we will speak about hybrid, Lapro, and endoscopic technologies. As I understand, we have two co-presenters. This is a hybrid presentation, so we have two speakers here, Evgeny Surovegin and Alexei Likunov. Could you please show the slides on the screen? And the speakers as well. Can you hear me? Hello? Hello? We have presentation.
Yes, we are here. We are listening to you. And right. So let's.
In 10 to 15% of cases, it's not possible to endoscopically remove it. Hello? Since 2018 till 2020, the Coloproctology Institute has operated 405 patients. I'd like to point out that most neoplasms were lateral granular neoplasms.
При этом конверсия в 10% случаев.
Conversion was done in 10% of cases. In 22 patients, lifting was less than 3 millimeters. In 10 patients due to technical difficulties. In 5 patients due to bleeding. Intervention. Multifactorial analysis showed the size of tumor, more than 3 centimeters, lifting less than 3 millimeters, vascular pattern. So conversion was done of dissection into transabdominal intervention. When it was not possible to remove it endoscopically, normally in our clinic, we invite operating surgeons. After that, sigmoid intestine resection is done. So, sigmoid intestine resection, together with evident oncological advantages, has some drawbacks. First of all, is traumaticity, and secondly, when we remove a segment of the colon, we change the anatomy of colon, and patients have to lose one segment of colon together with the tumor and some elements of valve structure. For example, when we conduct ileocecal resection, right and left hemicolectomy. And in this case, we think that there is an alternative. This is hybrid laparoscopic surgery. Let's speak about the history of this surgery. I cannot say that this surgery is new. In 2008, it was proposed to conduct laparoscopic surgeries in stromal tumors of stomach. However, in 1993, Beck and Karov published successful experience of removing complicated adenoma in patients with colon tumors. In our work, we refer to this method as hybrid laparoscopic surgeries, In global literature, there is no unified approach, and there are several names for this procedure. This is laparoscopic and endoscopic cooperative surgery, laparoscopic and endoscopic cooperative surgery for colorectal tumors, and combined endoscopic and laparoscopic surgery. These are synonyms. They are referred to name two types of hybrid interventions: laparoscopic assisted endoscopic resection and endoscopically assisted laparoscopic resection. Alexey Alexandrovich. Speaking about laparoscopically assisted endoscopic resection, here the main role is played by the endoscopic resection. Submuscular dissection. Colonoscope is used to extract the tumor from the lumen, and this defect can be covered. And normally, the laparoscopic team is responsible for it. In this video, you can see laparoscopically assisted endoscopic removal of colon tumor. So at first, we elevated the tumor, and quite a huge knife was used. The length of carton surface is 4 millimeters. So it allowed us to remove the neoplasm from deep layer.
Что со стороны брюшной полости нашу уже страхует полостная бригада, то есть лапароскопическая бригада.
From the side of the abdominal cavity, we already have laparoscopic team, just to be on the safe side. So in complicated cases, it's necessary to conduct extraction of the tumor. We use this knife to do circulatory dissection through all the planes, although the serous membrane can be intact. After that, there are small flaps, and they can be cut with this knife. The tumor is extracted through the endoscope, and this defect is removed, it is sutured, and it is covered by the laparoscopic team. I can continue. In endoscopically assisted laparoscopic resection, this is FLAX technology. The endoscopic team detects and navigates, and endoscopists also help us to follow the lateral resection margin, and the laparoscopic team conducts full wall resection of the flap of the intestinal wall, and this defect is covered with the use of stapler or normal suturing, as in this video. This is a video of our surgery. We can see that endoscopists have marked the zone of tumor. This is full thickness resection of the intestinal wall with the tumor. So it has finished. Now the tumor is put into the intestinal lumen. It is caught by endoscopic loop, and extraction is done. And during this time, the endoscopic team is suturing this defect. We use double suture. The first one is uninterrupted suture. And a very important advantage of this method is that the endoscopic team is helping us to assess the quality of suturing. They also check the bleeding, whether it's present or not. And they check the narrowing in the anastomosis zone. So the surgery has finished. And I'd like to specifically mention the wedge-type resection of the cecum wall. Speaking about global literature, we can see quite significant experience. In 2020, a systematic literature review was published, and here we can see very heterogeneous data. So the frequency of convergence in different authors was different, from 0 to 27%. Post-op complications from 0 to 36%. Post-op bad day was from 1 to 12. After high-break endolaparoscopic surgery, local recurrences up to 10%, malignization up to 27%. All these trials were not randomized. So these are series of observations. The average number of patients is about 30, and the most negative results, such as post-op mortality, 36% of post-op complications and 27% of adenocarcinomas were demonstrated by the trials where only 10 patients participated. So we can see that the data are very heterogeneous and it's very difficult to form an objective picture. We found only one meta-analysis that was published in 2015, and it allows us to understand what we're actually doing, and it helps us to understand the real situation. There were 707 patients here. So what do we have here? Repeated interventions after hybrid laparoscopic interventions are required in less than 10% of cases, and due to oncological indicators, in less than 8% of cases, adenocarcinoma is established in 10.5% of specimens. Complications less than 8% of cases. Recurrences during 3 years were found in less than 3.5% of patients. So, summarizing this, we can say that hybrid laparoscopic surgeries are comparable with radical resections. In terms of radicality level, however, they are less traumatic. They allow us to decrease the hospitalization time and decrease the frequency of post-op complications. There are some drawbacks as well. It's difficult to organize the treatment process. So 2 teams have to work in one OR, and it's quite difficult from the organizational standpoint. I think that we have managed to overcome this difficulty. And repeated surgeries are needed if adenocarcinomas with invasions below T1 SM2 level is present. And this also is quite expensive, and there are no trials in global literature. So we conducted prospective pilot trial, case control. We compared the results of treatment in patients after hybrid surgeries. There were 31 of them, and patients after laparoscopic resections. There were 21 of them. So this observation was done within a year, and in all cases the indications for surgery were endoscopically for the adenomas of colon that could not be removed endoscopically. These groups were comparable in terms of sex, age, and other parameters such as localization of tumor. And I want to mention that we are just reaching the plateau, and the duration of surgery in both groups were comparable. Post-op bed day, this indicator was different. In hybrid surgeries it was 5, however, in the control group it was 7. In terms of frequency and structure of post-op complications, statistically significant differences were not received. The main results are: 1 resection was done in 3 patients from the one group and 1 patient from control group. Adenocarcinoma was found in 5 specimens of the main group and 6 specimens of laparoscopic resection group. Invasion T1, SM2, and deeper was found in 6 patients in both groups. This is 11.5%. So, the oncologically substantiated resection was needed for these patients only. I'd like to point out that in the main group, patients with deep invasion, all of them were operated on, and resection was done in accordance with the clinical guidelines. We did not find any elements of tumor in the specimen. So, being guided by this, we decided to plan prospective randomized multicenter trial. The data will be analyzed following intention to treat principle. Patients will be randomized into the group of hybrid laparoscopic surgery and the group of colon resection. The endpoint is frequency of R1 resection. This is the main marker and the main parameter of surgeries due to colon cancer. And the difference of effect should be not more than 10%. This trial is being registered on the website you can see on the slide. And in conclusion, I want to say that the logic of medicine development results in a situation when we select individualized approach for each patient, and we also combine various methods for operating on our patients. And in future, all patients will receive the hybrid method that is needed for their specific case. Thank you. Thank you, Evgeny Sergeyevich. Thank you, Alexey Alexandrovich. I would like to thank you for having shown various options of hybrid laparoendoscopic resections on colon. And once again, I want to say that all hybrid interventions can be subdivided into 3 categories: laparoscopically assisted endoscopic resections, endoscopically assisted laparoscopic resections, and the third group is true laparoendoscopic hybrid surgeries, when both teams conduct some stage of this resection, and you have demonstrated all these options in your presentation. And if there is a clinical case when we have a patient on dissection in the submucosal level and this dissection turns out to be complicated, there are some complications, perforations, we need laparoscopic team in this case, we understand it. So the category of patients when we already know that here we will need laparoendoscopic approach. In your clinic, I think that you have the largest experience of such hybrid interventions on colon. Do you have some strict criteria when you understand that this is criteria for selecting patients for laparoendoscopic resection? I think I can start, and Alexey will add. I am a surgeon, and the indications for hybrid surgery are very simple. Endoscopic removal with dissection in the submucosal layer is not possible. You mean at what stage? So this is defined at pre-op stage, no. Well, of course, in outpatient facilities, we can suppose that this intervention may be needed, but of course, finally it is defined intraoperatively. Yes, I wanted to hear it, and I wanted to emphasize the importance of cooperation of endoscopists and surgeons when the decision is taken right here and now in the OR, and you can invite another team very fast. For example, in our department, we do endoscopy and surgery, and when initially we understand that most likely here we will need to use laparoscopic approach, there is no difficulty for us, but not need to invite anyone. But I know that in all the clinics, these can be very relevant. Do you have any questions? I'm asking my co-moderators. I can see that there are no questions on the chart yet. Artem Leonidovich, if you have any questions, you can ask them, and if no, we will thank our speakers from Uzhik Institute. I have a question. May I ask it? Yes, of course. I'm very glad to see you almost in person. This presentation was really interesting and very important because not many people use these technologies in their routine practice in specialized institutions. So you sutured the intestinal wall defect using Willock thread. And we know that this thread has not been registered for intestinal sutures. So what's your opinion? Probably it's better to use Vicryl or another thread that had already been registered and use it for suturing. Thank you for your question. Well, here we used Willock, and normally, more frequently we use VP. I don't know why here we used Willock. It just happened so. It was not on purpose. We more frequently used Vicryl. Well, I want to say that all these intracorporeal anastomosis that were done by our American colleagues or Dutch colleagues, actually all of them are done with Willock thread. Thank you. Well, actually, I can comment on it as well. Although I'm Russian citizen, but I'm outside the jurisdiction of the Russian Federation. And in Ukraine, there is no ban on using these threads. So we've used it for about 10 years on esophageal anastomosis, stomach anastomosis, intestinal anastomosis, and I think that this is one of the first internal anastomosis that has been tried on urinary tract in medical prostatectomy. So I think that we just need to implement some legal changes because, you know, it's quite similar to an old joke that we used to say in Soviet times. I don't see any problems related to the threat. when we speak about absorption time compared with Vicryl, it's just more convenient for laparoscopic surgeon. So I don't even know, and is there any ban on using it when we speak about colon? So there is no permit and no ban. Sergey Viktorovich, I'm very happy to see you. Later, we will return to your presentation. Let's thank our speakers from Rizhik Institute once again. We wish you good luck with your pilot trial. I hope that in future we will listen to further results and will move forward in our agenda. Ilya Leonidovich Chernikovsky will present. Is there a limit for laparoscopic technologies when treating locally advanced forms of colorectal cancer? The floor is yours. Thank you, Seda. Thank you, the organizers of the conference. I would like to thank Yuri Gennadievich for inviting me to participate here today in this remote format. So could you please stop demonstrating the screen of our colleagues from Rizhik Institute, because I want to switch on my screen.
Так, теперь я могу включить свой экран, да.
Okay, now I can turn on my screen.
Это доска. Так. Почему-то я не могу найти свой экран здесь.
I can't find my screen.
Сейчас, секунду, извините. Все. Ну, я сразу скажу, что...
I will say straight away that this presentation is not a new one. We have been doing laparoscopic surgery for a long time. We have been doing multivisceral resections for a long time in a locally advanced colorectal cancer. Can you see my screen now? And I can't hear anything. We see the screen, but we only see your desktop. I will try it once again.
Там Keynote надо выбрать, видимо.
You need to probably choose Keynote. It's in PowerPoint.
Поэтому презентация не новая, но мы, значит...
So this presentation is not a new one. But we will try to remember what we were speaking about. Can you please put it in the full screen mode? It is already. We can see your slides on the left. So you need to switch on demonstration. It is. What about now?
Человек, который редактирует.
We see it as if we were editing it. We see the slides. Yes, no.
А сейчас?
What about now? It is not in the full screen mode. Do you have buttons below? Where there is percentage, there is a button which looks like a wine glass, and if you click on it, we will see it in the full screen mode. It is below on the right, where there is the button play, the yellow one. It is there, we can see it. It is in the menu below. Your screen demonstration has been suspended. That's what I see. I press on something and it doesn't work. We can see your presentation, but not in the presenter mode. Let's try again.
Так. И она у меня сейчас, вот она у меня сейчас у самого в компьютере открыта в режиме демонстрации.
It's opened on my desktop in the demonstration mode. I will now switch it on. Okay, it's great now. It's in full screen mode. Thank you very much. Okay, thank you. Now I need to get back and I can't do that. But okay, no worries. Let's continue with this slide. Share of laparoscopic surgeries in our center is about 80%. It's not the rate that has been mentioned before, but we operate on different columns, so to speak. If we look at different research connected to locally advanced cancer and multivisceral resections for these diseases, we will see that R0 resections were done in 80% of cases. True invasion was in a little bit more than half of the patients, and the most frequent localizations connected to infiltration of the tumor into the adjacent areas are bladder 53, prostate, ovaries, uterus, small bowel, seminal vesicles, vagina, vaginal wall, and abdominal wall. And another observation is that when we have ingrowth of the tumor into the bladder, then there is an error to increase invasion when there is ingrowth into the bladder. And when we do resection of bladder, there is no true invasion in the bladder. The factor which influences the prognosis most of all is completion or non-completion of R0 resection, as this meta-analysis shows. The other factors were not considered to be significant in what concerns forecast prognosis, whether our operation is laparoscopic or open. So the main factor here is R0 resection. Here are the remote results of the interventions, the overall 5-year survival in these patients. The patients we have operated on with the multivisceral resection, it's more than half of the patients. No recurrence, a 5-year survival is 48%. As for laparoscopic surgery in locally advanced colorectal surgery, if we take NCCN guidelines, then if we use them, then we will not operate on these patients laparoscopically because open approach is recommended there. Still, these surgeries are carried out and quite broadly, and more time passes, more often we do them. And my teacher even showed a case of multivisceral resection. It had never happened before, so he showed us resection of rectum as the tumor had grown into the posterior wall of the vagina, and he had never shown such things before. If we compare open and laparoscopic multivisceral resections, there are several research here, and we see that the difference between these interventions was that laparoscopic surgeries lasted longer. Blood loss in laparoscopic approach was less, of course, and there were all other advantages that we know regarding laparoscopic approach. As for remote results, oncological results, then here you can see 2 studies that we have been studying. The first one, the Korean one, Kwang Yong Kim. And we see that the overall survival was even slightly better in patients who had been operated on laparoscopically. It's a little bit less than 0.05. And the other study showed that there was almost no difference between open and laparoscopic surgeries. To sum up the studies that were about comparison of open and laparoscopic multivisceral resections, we can draw the following conclusions. As for R0, no difference. Lymph nodes, no difference. Mortality, no difference. Re-surgeries, no difference. Recurrences, no difference. Time of operation, more when it's laparoscopic, or there is no difference. Complications, less in laparoscopic surgeries or none. Blood loss, less in laparoscopic. Average number of days in patient stay of patients is less. 5-year survival is more in laparoscopic methods. I think that remote consequences is that complications which arrive and surgical trauma, they lead to reduction of overall survival of our patients. All laparoscopic surgeons go through these 4 stages, just like drivers. Stage 1, a driver is driving carefully, and number 2, that person thinks that this person is thinks that he is very expert, and then on stage 1 he doesn't do laparoscopic surgeries to anyone, and on stage 2 he just tries to do it on everyone, and that might be problematic as well. Stage 3, confident carrying out of laparoscopic surgeries, and 4 is professional pilot, and we have such professionals among us. I mean, so again, multivisceral resections, but not many people reach that level, and I think that our goal, we being the wide public, is the 3rd stage, confident driving and confident carrying out of such operations. And we need to understand counterindications to laparoscopic multivisceral resections. To our mind, CRM plus on posterior and lateral walls of the rectum, involvement of pancreas, and in this case we think that we should not do laparoscopic approach here. Tumors that are more than 10 by 12 centimeters. But again, this is a relative counterindication, because if the tumor is big but it is easily removable, then I think it is better to do it laparoscopically, using the approach which is the most convenient for you. But still, the patient will go through it in an easier way if it's done laparoscopically. Acute ileus, involvement of magistral vessels, while there is no confident skill there, and which is also important, paracancrous abscess. If we see it in the patient, then if we do it laparoscopically, that was our 2nd stage. You see that we were damaging the tumor cavity was opened, abscess, and it is so bad in what concerns further results in treating these patients. We have been studying our results, multivisceral resections from 2013 to 2017. We had performed about 125 resections. By then, now the number has reached 200, and these are the results, same results that that our colleagues had reached before us. Most tumors were localized in the right flank, some in a descending colon, and more patients with sigmoid cancers, tumors, and twice as few patients with rectum cancer. Here are the surgeries we have performed. You see that we have carried out panhysterectomy, a lot of them, 22. The 2nd place is taken by resection of the bladder. And number 3 is resection of small bowel. Here is a video, so tumor of rectum with ingrowth into the posterior vaginal wall. I will try to forward it. I think that Sergey will show it in his presentation. Resection of the bladder, short video as well. Usually we are lucky, and sigmoid grows into the posterior wall of the bladder, which is not a problem for resection, and today it's more convenient to resect the bladder laparoscopically than openly, which we do a lot. It is one of our first surgeries. It is quite an old video. And since we started carrying out those operations, we have done a lot of bladder resections, and we have transplanted a lot of ureters. And there was even a case from Yakutia. There was a diffusion from the broadcasting from the surgery room. Resection of a small bowel. I think that today we have about 40 small bowel surgeries. This is a proximal tumor, which is proximal to sigmoid, our old video as well. And the loop of the small bowel is mobilized where the tumor had grown. It is mobilized here. Intestinal vessels, demarcation lines where resection will be done. Superior mesentery vein, colicomedia vein, lymph nodes of group 2 to 3. Non-standard approach to this zone has been carried out not from bottom up, but laterally from the right side, because there was that small bowel loop and we had to take a non-standard approach. R0 resection in 92% of patients. We think that is quite good, just like in other studies, even slightly more. 14, this is the average number of lymph nodes. Only 21% of complications, 3 anastomotic leaks, and no specific complications due to the fact that it was a multivisceral resection. And we have had 87 surgeries. The conclusions are, today 90% level of R0 resections can be achieved with both laparoscopic or open approaches. It's critically important to select patients for laparoscopic multiple visceral resections. It should be carried out by a team of surgeons with a lot of experience, and limitations of a laparoscopic approach in these patients are connected to abscess, the size of the tumor, and situations when you are not sure that you can perform R0 resection. And I want to add one more thing. We have touched upon it today. When we see a big tumor growing into the adjacent structure and where there are no metastases, it is better to start treatment with molecular genetic profile of this tumor. If it is MSI high, then treatment is better to start with a new adjuvant or immunotherapy. Then you might actually avoid multivisceral resection altogether, and non-surgical procedures are getting more and more popular. Of course, we can resect anything when we have experience, but yes, and multidisciplinary approach is crucial. I want to underline it. Thank you very much, and big hello from St. Petersburg. Thank you, Ilya. Thank you for having structured everything in your presentation, and thank you for having shown us the criteria that you have established for yourself as counterindications in using laparoscopic access. And I really like the classification of laparoscopic surgeons by categories. If our co-moderators or speakers have questions, please join in. I think that it's not really classification of surgeons, but of evolution stages. Great presentation. Everything was very clear, very thought of, almost like Lina's. Thank you very much again. No questions from listeners yet. And I think that we will now get to the last presentation for today. It is like a cherry on the cake. Sergey Baido. You know, while we were trying to understand whether you were a foreign or a domestic expert, you know, we think that you are a domestic one, and we are giving you the floor. So, presentation about laparoscopic concentration.
Thank you. So I request you to switch off the presentation because I cannot switch on my screen demonstration before the previous speaker switches it off. So I'm addressing the technical team. Yes, we're waiting.
Они нас слышат?
Can they hear us?
Все нормально, посмотрите.
So it should be fine now. Sergey Petrovich.
Вывелось?
Can you see it now? Yes, we can see your slides, we can see you. Well, colleagues, first of all, I would like to apologize because this presentation will not be revolutionary. The material you can see here ends up with the observations of 2017. The reason is that we have summarized the results of 3-year survival in these patients. In some cases, we have 5-year survival, and in some cases, 3-year survival. So we decided not to include our data for the last 3 years. Speaking about pelvic evisceration, or there are actually different terms for this state. I know that evisceration can be used as well. It is used in our St. Petersburg school, and in English literature, normally they prefer using the term exenteration. I think it's the matter of taste. But please remember that this surgeon, Alexander Brunswick, conducted the first surgery in 1948, 3 years after World War II, and he had operated almost 850 cases. So this is a very huge experience, and he is one of the titans of pelvic evisceration. Speaking about Russian experts, today there is Kirill Shorts and other colleagues who has done hundreds exenterations. But when the Soviet Union collapsed, the largest experience on pelvic exenterations actually belonged to David Tagoevich Gatsadze. I think that many of you know his son, Ilya. We're friends, and actually this person is urologist, but still, in the USSR, he had an unprecedented experience, about 100 exenterations that he conducted himself. Speaking about minimally invasive surgery, we can say that here, just like in endoscopic surgery, the priority belongs to the French. Dr. Christophe Pommel from France, in 2003, reported about pelvic exenteration for the first time. This was not colorectal cancer, this was cervical cancer. But I want to say that speaking about pelvic exenterations, probably the primary reason does not have any surgical importance. It's important for the forecast of tumor, for some biological aspects of tumor. But when we speak about the intervention technique in urothelial carcinoma and squamous cell carcinoma of the cervix, quite seldom we need to conduct such interventions in endometrial cancer and colorectal cancer, but the technical aspects are similar as a rule. The place of exenteration. Even in contemporary guidelines, it is represented for urothelial carcinoma, cervical cancer, and colorectal cancer. In this presentation, we included our personal observations from 2012 till 2017. And I'd like to mention that we selected our patients. We selected only the central recurrence. So, if there is lateral recurrence with the involvement of periosteum or lateral pelvic structures, then, frankly speaking, we do not see any prospects for intervention with pubic bone resections. There are colleagues that conduct surgeries even in these cases, but in our practice there were no such patients. And of course, there should be no signs of remote metastasis following various methods of examination. And the patients that can receive pelvic exenteration always receive PET CT, although it does not always help us. All the patients that we operated on were operated after primary treatment. Normally, this treatment included surgical treatment, radiation, or surgery and radiation, and this surgery was done in 8 to 14 months after the primary treatment. And once again, I would like to refer to Professor Gotzadze. Actually, this slide was taken from one of his presentations. So I just want to remind you the types of pelvic exenterations and the schematic view on sagittal section. So here the patient is woman, and on a male patient it will be a bit different. The border will lie on prostate and seminal vesicles. So these patients that we examined over 5 years, there were actually 18 of them, and you can see them on this slide. It's very difficult to stratify these interventions because each intervention, well, maybe it's not unique, but still, we can actually divide such patients into groups. We have several thousands of them only, because you see that here we had very few patients, only 18 of them. But these patients were very heterogeneous and the interventions were different. So, where can we start from? Technical features. I was so frequently speaking about ergonomic location of ports, because speaking about long-term difficult interventions, this is especially needed and very obvious. Normally, we use this form of port location, and I'd like to emphasize that in the left and right ileum area and above the navel, these should be 10 millimeter ports if you use 10 millimeter open systems. And in left subcostal space, this port is used in case of cervical cancer, because this is the only case when it's possible to introduce a specific device for infection in the upper part of stomach. Why is it important to place ports on the left and on the right above the navel? This is shown by this slide. When the laparoscope is shifted from the port above the navel to the left intercostal space, we see complete view of right intercostal space. Right ureter was mobilized. Lymph node dissection in the iliac zone, in the obturator zone, is more convenient if we use this localization. And speaking about right iliac artery, we can also move laparoscope, and the surgeon is on the right. Now we can see the obturator fossa with the obturator foot, and the dissection in obturator fossa is always difficult after radiation therapy. So it's not like we irradiated the patient and we operate on them from week 6 to week 8. In several months after radiation therapy, fibrosis develop, and it's so difficult to operate on such patient because the texture is very stony. So it will be very difficult to take organ complex or lymph node vessels. So, surgeons do not like talking, they like watching videos, normally this is a brief video, anterior exenteration. You can see that as a rule, this is always about significant adhesions because these patients have massive radiation therapy. Lymph node dissection and dissection of organic complex in the ambral planes is quite complicated.
Сергей Викторович нам слышит, если мы?
Can he hear us? So we have a technical problem. I think that there is a problem with the internet connection. There is no broadcast now, and we can wait till it recovers. We will wait for the second connection. Colleagues, have I returned? Well, we can hear you at least. Okay, and what about my slides? Now we can see you as well. So, we're waiting for your slides. Okay, so we have watched the video already, and now I would like to demonstrate the next video. This is a patient 1 year. Sergey Viktorovich, could you please switch on the slides once again? We do not see them on the screen. Okay. Screen demonstration. I need to repeat it. Yes. Can you see it now? Yes. So in this case, I wanted to demonstrate a brief video. Well, I don't know how to call this procedure. This was laparoscopy due to different reasons, actually. 1 year ago, this patient had laparoscopic pelvic exenteration. This was total exenteration, but anus was preserved and fecal transducency was preserved. Non-peritonized vessels are peritonized completely. This is the loop of descending colon. This is the superior part. This is os pubis, I mean the pubic bone with absent bladder. And although this patient has had radiation therapy and this intervention was quite huge, here we do not have significant adhesion process. Speaking about the direct results of interventions, it's quite difficult to compare them because the patient's groups are very heterogeneous. So even in these 4 large groups of intervention, we've seen significant validation in terms of intervention time duration. So it's difficult to compare these heterogeneous groups. In all cases, and I want to say that now, our experience of pelvic exenteration includes about 40 cases, not only these 18 patients, and we always manage to reach R0 resection margin. And I think that it goes to the merit not of the surgeons, but of honest selection of central recurrences. Immediate results, post-op complications, severe complications, 3 to 4 grade on clavia and dindo, are seen on the slide. 1 patient died from this group, and actually this was the only patient in pelvic exenterations that died, and this mortality share was calculated on these 18 patients. She died due to thrombosis of popliteal artery due to interventions, and after that multi-organ disorder syndrome developed. and I did not amputate her extremity in time. This patient was 33 years old and she died. So after that, we made some conclusions regarding patient's positioning. I will speak about it later. So I think that this slide is most important. I want to mention that we have had 10-year experience. My first laparoscopic intervention was done in 2011, and I want to say that for the first couple of years, I reached plateau and I almost gave up because you spent several hours in the OR, but as a result, not everything is good. I mean that after some time, most of such patients start to progress. And I want to say that this slide is important. 3-year survival rate was calculated for the whole group, and for some patients we calculated 5-year survival already. Over the first year, we lost 1/4 of such patients. And in the end of the second year, a bit more than 1/3 of these patients were alive, and 3-year survival in this group is a bit less than 1/4, like 1/5 of all patients. Analyzing the subgroups of these patients, I can say the following. In this group, there is no local recurrence. No local recurrences after exenteration, but all patients that did not survive had progression. They had remote metastasis. And in spite of all the algorithms of thorough examination, still, it was not possible to catch them. And we saw metastasis in lungs, on bones, and only one patient had a recurrence in para-aortic lymph node zone. It was outside lymph node dissection zone. This patient is alive. We removed the lymph nodes and the para-aortic zone was irradiated. In all the remaining cases, we saw progression. It shows that neither PET-CT nor PET MRI allow us to answer the question whether these patients have metastasis or no. But why do I continue moving in this direction? I want to say that the quality of life of the patients, even of the ones that died eventually, the quality of life was quite good compared to the quality of life before the surgery when they addressed the clinic. Because once again, I would like to emphasize that these patients had complications. They had multiple fistulas, rectovaginal fistulas and varus fistulas, urinary fistulas. And this surgery can also be perceived as sedating one. So what is a good news for this colorectal session? All patients that are alive had colorectal cancer. So of course, squamous cell carcinoma is the worst one in terms of biological forecast. Speaking about long-term survival for such patients, colorectal cancer. Even if there were metastases, this cancer was treated, and in some cases, liver or lung resection were done, and multiple chemotherapy was administered, and some of these patients are alive, and some of them not only have stable disease, they actually had 5 years without progression. What are the difficulties of pelvic exenteration? The duration of surgery. In the beginning, we had 11-hour surgery, and today, I want to say that I actually prepared these slides a long time ago. I introduced some amendments, but still, I smile when I see some slides because in the past, pelvic exenterations were so difficult for us. And I just wanted to take this slide from my colleague's presentation regarding surgeons' evolution, because we did exenteration last week and 1 week before the last week, and these surgeries were not unique surgeries during that operating day. So today these surgeries do not last longer than 4 hours, and in the past we had to reject all other surgeries and do one exenteration during the whole day. Now we can conduct one exenteration and 2 to 3 medium interventions. The second problem is RSI, repetitive strain injury. This is muscular pain that results in case of small repetitive movements, and in laparoscopic surgeons that is especially manifested. Besides, static load on our venous pumps result in various problems such as hemorrhage. And for the patient, it can be quite difficult. This is non-physiological position, Trendelenburg position, with various compression complications related to bony structures of sacrum, acromial processes of clavin bone, and others. And for the surgeon, the most difficult criterion
Так, у нас, похоже, вновь проблема с тем, что вылетела трансляция.
I think that connection is lost once again. So we're waiting for Sergey Viktorovich to return to finish his presentation. Let's wait till he joins us again. Probably have some comments.
Maybe Ilya, Artyom have comments. Please join in while we're waiting. Dmitry Vladimirovich is still there. Hello, can you hear me? I have 2 comments to make while Sergey is reconnecting. I'd like to draw your attention to the following thing. Big part of pelvic exectorations are done for cervical cancer. Most of these operations are for cervical cancer. And we know from gynecologists, from oncologists, that cervical cancer is operable only when it's 2B stage. If it's more advanced, then we can't consider operation even. We can't consider operations. And these patients will definitely have recurrences despite all surgical efforts. So I asked gynecologists, why then do we do all these pelvic eviscerations to patients with cervical cancer? Because it just doesn't make any sense. And as I was told, maybe it's a good point for discussion, it makes sense if we want to eliminate problems connected to forming of cloaca after radiation therapy, or if it's not parametral version, which is quite rare, if this tumor grows into the intestine or bladder, either downwards or upwards. I think that Sergey has reconnected, and after his presentation, we could speak about that. Thank you, Ilya Leonidovich. Sergey Viktorovich, I think that he has reconnected using his phone. Can we see him? Sergey Viktorovich, you are on mute. Please check your settings. What about now? Now it's all right. I'm sorry. It's kind of systemic failure. My Wi-Fi internet seems not to be working. I'm using my telephone. I will not be able to show you the 1.5 slides that I was going to. So to sum up, the main difficulties here are position, no differentiation between tissues, that we need to rely on. We need to rely on pre-op examinations when we choose the plan of dissection than just the surgeon's intuition. Because to distinguish infiltrate from tumor, infiltrate from inflammatory tumor, it's not an easy thing to do. And interventions are always lengthy and they are not always precise. How to solve all these issues? First of all, we need to put patients in the right position, to not to be stingy and to buy special gel cushions to put them under the sacrum, under the shoulders, and at the beginning to put a patient into the correct position yourself, because nurses, they can position the patient, but it's you who will be speaking to the patient whose main concern will be some shoulder spatial syndrome after 10 years in Trendelenburg position. And all this is easy to prevent if the position is correct. It's very desirable if the expected length of intervention is over 5 years or over 5 hours, is to make some 5 to 7 pauses during the intervention, to leave, to let the team leave, to go to the bathroom or just stretch themselves. And it shows that actually it decreases the length of the intervention itself, and also decreases the number of intra-op and post-op complications. The easiest way to avoid all these difficulties is not to have any exaggerations. It's an open secret that there is educative internet channel, and you can watch pelvic exaggerations, either early ones, 7 hours, or later ones when from the first insertion of trocar to the final stage, and it takes 4.5 to 5 hours. This is not for Schumachers, you know. By Ilya's classification, this is for mature surgeons who already have good skills and whose team have good skills, and they are competent enough, because if everything is done well, then the post-op will be much easier for such patients. Pelvic exaggerations, I have seen people from Charité Hospital, from Malheur Hospital, where there were 14, 16-hour open interventions. Just imagine.
Не спасти, там получается, как знаете, даже
just not possible to save them.
Все это заживает и очень плохо эвентрирует.
And then it heals very badly. And such patients usually need more than one surgery. They usually need at least post-op chemotherapy. And I think that there is light at the end of the tunnel, and these surgeries have the right to exist, so to speak. Thank you for your attention. Thank you, Sergey Viktorovich. It's not my first time. I'm listening to your presentation for the second time, and I see evolution in this presentation. Little comment. What do you think? How do you think this area will develop in the future? Maybe we need to narrow the indications or broaden them. You already have experience of analyzing all that. What have you arrived at?
Это очень узкая сфера,
This is a narrow, small area. In order to become a high-volume center, and do pelvic exenterations, there may be a couple of clinics in Moscow, given the epidemiology in Moscow, maybe one in St. Petersburg. As for big cities that have over a million population, they will have to collect, so to speak, people from all over the area to have at least 25 to 30 exenterations per year for surgeons to know how to perform exenterations and how to do post-op management, because we know that there should be a proper number of surgeries performed by surgeons every year, because otherwise survival will just decrease. So these patients should be selected. They should be those who they should be surgeons who are ready to perform these surgeons, paying the price of their varicoses. If there are less than at least 25 surgeries per year, then I think it just doesn't make sense to do them. Can you please put on the screen all the participants of this closing session, everyone we have with us? Everyone, please make kind of a conclusion, and then I will sum up myself. Artem Leonidovich, we will start with you. Thank you very much. I want to say thank you to the organizers, to those who have come up with the idea of this festival. Yuri, everything has been organized very well on all levels as usual, and it would not be possible without your constant co-participants. Big thank you to our colleagues, to all those who have agreed to participate, who have presented their latest cases and developments. We have seen great live operations that were so quick and that even gave us a couple extra minutes for our future session. And despite technical problems with equipment, it showed us that all anastomosis, extracorporeal anastomosis in competent hands, they don't seem that difficult. And Stanislav did resection of rectum. Thank you very much. I'm a little bit tired. Sorry about that, but it's been a whole day. I think it's easier to work in the surgery room than to assist in such sessions. This one is also a very difficult job, you know.
Спасибо. Вы мне по привычке передаете слово, по привычке.
You are giving me the floor. It's a kind of a habit for you. Thank you very much to the organizers. Everything has been organized at the highest level as usual, even though it was online. It's been a great pleasure. I want to ask you why we're not collecting in an art space as usual today, but we will organize it for ourselves anyways. Our favorite colleagues will come to the city. Okay, and thirdly, I loved the pilot study that was spoken about in the last session. I think that this is very important work. I think that it's interesting, and I really want to hear about the results and further development of the study. I'm also happy to see Sergey Baido, but we see each other so often online that maybe it's even bad that we are living through COVID times, because we see each other really often. As for evisceration, the last but one Thursday of this year will be about pelvic eviscerations, where there will be Sergey Baido and Kirill, who has been mentioned several times today. So please join in and watch it. And now I want to give the floor to Sergey Baido. Thank you very much to everyone. Sound. Can you hear me? Thank you very much, Ilya Leonidovich, for giving me the floor. Yuri Gennadievich said, Vissarionov. I regret that we are seeing each other in the online format. These habitual autumn congresses, they have always been famous for being really hearty, not only during speeches and presentations, not only during live operations, but also due to the after-party part of it. I really regret that we can't have it now, and I miss this format, but well, unfortunately we have to adapt. I was really happy to take part in your congress and to share my thoughts, my developments, and my worries. Thank you very much. No sound.
Мы не слышим вас, Седа
We can't hear you. What about now? Yes. I think that the whole floor can hear me now. Thank you so much to all the experts that were taking part in today's intense and long day. And a big thank you to Artyom Leonidovich Goncharov, who is program director of this day. And this is the person who has invited all the leading experts in this area. You have made this day really incredible. There is a lot of feedback from listeners. We have been watched by many listeners. They were asking questions. I think that this day has been very intense, very active, and it has been really useful for our listeners. And I think that we will continue this tradition next year, but I hope that we will see each other live on offline and that we will meet in the art space. And closing remarks, please. Thank you very much. Dear colleagues, dear friends, Sergei Viktorovich, we have seen each other, well, at least in this format, online. It's a great pleasure for me that Artyom Leonidovich managed to put together a great program, and we have had a lot of foreign colleagues in this conference from different cities and countries. Great program. Dmitry Legan said before the conference that the program was really fabulous. I think that Artyom could hear his words, and he was absolutely correct. Very interesting 3 sessions that we have had today, and we were really happy to see everyone in good health and smiling and happy with each other and with everyone else, happy with our event. Good luck to all of you. Stay healthy, stay safe, be happy. I have to say thank you to our sponsors, Medtronic company, that supported our today's conference. Thank you to our experts who were operating from Rizhik Center, Nikolai Viktorovich and Ilya Leonidovich. Of course, the operations were magnificent, and the quality of broadcast, your comments, the equipment, everything was amazing. I could not be present all the time. We have 2 virtual halls. There was a congress on endo inspections, but I was watching some parts of it and I was really happy. Thank you to your teams, to your anesthesiologists, to your nurses who helped you in operations. Thank you to your assistants that were doing really their best. And robotic surgery as well. The presentation was brilliant. And I want to say to the medical company, the T Group, that again managed to hold this event at a very decent level. We are having 2 days ahead, 2 more virtual halls tomorrow and the day after tomorrow. The day after tomorrow, we'll have 3 virtual halls. Very extensive program. Thank you to all of you. Thank you to Artyom. Thank you very much and see you soon. I hope that next year we will be able to go to art space and anywhere else, anywhere that we will imagine, and just get together in a professional and friendly, at the same time, setting and leave behind COVID issues. Thank you very much and see you very soon. Thank you, everyone, and goodbye, dear friends. Thank you very much.
Experience the evolution of freedom of movement. From the trusted name in cordless ultrasonic dissection devices. Introducing the redesigned Sonicision Curved Jaw Cordless Ultrasonic Dissection Device. The cordless design reduces the challenge of managing cords in the sterile field and provides freedom of movement and mobility during your surgical procedures, contributing to a safer and more efficient OR. Available in 4 shaft links to help meet your specific need, the Sonicision Curved Jaw Cordless Ultrasonic Dissection Device enables secure vessel coagulation and efficient dissection in open and minimally invasive surgical procedures. The tapered design of the curved jaws enables precise access to tissue planes in confined spaces. The intuitive dual-mode energy button is designed to improve focus on the surgical field and procedure. The Sonicision Curved Jaw device has an improved reusable generator that is now autoclavable and enables 1.5 times more procedural uses than the legacy device. The improved battery can be used in twice as many procedures. The redesigned charger features a user interface that provides easy-to-interpret battery charge status and battery end-of-life indications, enabling efficient battery management. The non-sterile nature of the battery also removes the need for sterilization and streamlines preparation for reuse, and provides an 88% increase in battery capacity, which may mean fewer procedural delays due to mid-case battery exchanges. The Sonicision Curved
you.